Chapter 9. Human Development. Introduction. One of the most interesting things about humans is that we evolve, not just as a species, but also as people over our lifespan. Paramedics must be aware of both the obvious and subtle changes that a person undergoes physically and mentally at various stages of life, and understand how these changes might alter the approach to patient care. Infants. As any parent can attest, infants, 1 month to 1 year, develop at a startling rate. Neonates, birth to 1 month, are covered in detail in Chapter 43, Neonatology. Physical changes. Vital signs. Normal ranges of vital signs for various age groups are outlined in Chapter 16, Physical Examination, and Chapter 44, Pediatrics. The younger the person, the faster the pulse rate and respirations. At birth, an average pulse rate of 140 beats per minute, and a respiratory rate of 30 to 60 breaths per minute are considered normal. Tidal volume in infants starts at 6 to 8 milliliters per kilogram. By age 1 year, the tidal volume increases to 10 to 15 milliliters per kilogram. Normal oxygen saturation level is 94% or greater. Blood glucose level is normally 45 milligrams per deciliter or greater at birth, then increases to 60 milligrams per deciliter or greater from age 1 month on. In children, blood pressure directly corresponds to the patient's weight, so it typically increases with age. At birth, the average systolic blood pressure of an infant is 67 to 84 millimeters of mercury. By age 1 year, systolic blood pressure is in the range of 85 to 104 millimeters of mercury. Weight. A full-term newborn usually weighs around 3.4 kilograms at birth. In the first week after birth, infants usually have a loss of 5% to 10% of their birth weight due to the loss of fluid. By the second week of life, infants normally gain weight. From here on, infants grow at a rate of about 30 grams per day, doubling their weight by age 6 months, and tripling it by age 1 year. Cardiovascular system. Prior to birth, fetal circulation occurs through the placenta. Just after birth, physiologic changes take place in the cardiovascular system that allow independent circulation via the newborn's own vasculature. This process will be covered in detail in Chapter 43, Neonatology. Pulmonary system. Prior to an infant's first breath, the lungs have never been inflated. An infant's first breath is therefore forceful, it has to be. Infants are primarily nose breathers for the first several months of their lives. Infants younger than 6 months are particularly prone to nasal congestion, which can cause viral upper respiratory infections. If you receive a call for an infant who is choking, then always make sure the infant's nasal passages are clear and unobstructed by mucus. The rib cages of infants are less rigid than those of older people, and the ribs sit horizontally. The diaphragm is the newborn's major respiratory muscle. Intercostal muscles are not well developed. Thus you observe the abdomen bulge with each inspiration, but see little thoracic expansion. Because of the immaturity of the accessory muscles, the infant can quickly become fatigued. 2 other important anatomic points relate to an infant's airway. When compared with an adult's, an infant's tongue is larger in proportion to the oral cavity, and the airway is proportionally shorter and narrower. As a result of these 2 factors, the airway in an infant can be occluded more easily than the airway in older children or adults. Infants have a smaller functional residual capacity F(r), C, and fewer alveoli, and they metabolize oxygen more rapidly. You should monitor closely an infant with possible apnea, as he or she is more prone to respiratory failure than a child or an adult. Renal system. Newborns and infants can become easily dehydrated. Newborn kidneys are less able than adult kidneys to concentrate urine and excrete water. Therefore, when dehydration occurs, newborns and infants cannot compensate to the same extent adults can. Also, an infant's urine consists mainly of water, which can cause the infant to develop electrolyte imbalances. Immune system. While in the womb, infants collect antibodies from the maternal blood. For the first year of life, the infant maintains some of the mother's immunities, so he or she has naturally acquired passive immunities. Infants can also receive antibodies via breastfeeding, further bolstering their immune system. Nervous system. Although the infant's nervous system is developed at birth, its evolution continues after birth. For example, the newborn lacks the ability to localize and isolate a particular response to sensation. An infant's brainstem and spinal cord are present and functioning, but memory and fine motor coordination are not yet fully developed. Also, the ability to control body temperature is limited. An infant is born with certain reflexes. Motor and sensory development are most developed in the cranial nerves, which control blinking, sucking, and gag reflexes. The Moro reflex, startle reflex, happens when an infant is caught off guard by something or someone. The infant opens his or her arms wide, spreads the fingers, and seems to grab at things. A palmar grasp occurs when an object is placed into the infant's palm. The infant will close the fingers around the object. The rooting reflex occurs when something touches an infant's cheek. The infant will instinctively turn his or her head toward the touch. In conjunction with the sucking reflex, which occurs when an infant's lips are stroked, these reflexes are often tested when feeding. An infant's fontanelles allow the head to be molded, for example, when the newborn passes through the birth canal. These 3 or 4 bones of the skull eventually bind together and form sutured joints by age 2 years. The fontanelles play a key role in your assessment of an infant. An anterior fontanelle that is sunken may be a sign of dehydration. Perhaps the neurologic development that is of most interest to parents is the development of a sleep pattern. Sleep pattern is developed through a combination of central nervous system development and parental efforts. Most infants develop the ability to sleep for 5 hours by age 3 months, but some do not develop this until age 1 year. A concern related to infant sleep is sudden infant death syndrome, SIDS. This is discussed in Chapter 44, Pediatrics. Musculoskeletal system. Growth plates, often called epiphyseal plates, are located on either end of an infant's long bones, and are the centers where longitudinal bone growth occurs. Bones grow in thickness by building on themselves. An infant's muscles account for approximately 25% of his or her total weight. Psychosocial changes. An infant's psychosocial development begins at birth, and continues to evolve as the infant interacts with and reacts to the environment. Parents and/or caregivers are often concerned about whether their child is developing within the socially accepted norms. Table 9-1 outlines typical ages at which major psychosocial changes are noticed. In most infants, the primary method of communicating distress is through crying. Parents can often tell what is upsetting their child simply by listening to the tone of the child's crying. That is, they know the difference between tears for anger, frustration, pain, fear, hunger, discomfort, and sleepiness. Infants occasionally make another distinct cry, an alarming distressed cry. This cry may be heard when an unexpected event occurs, causing a situational crisis for the infant. One key to having a happy, healthy infant is spending time with the child. Nevertheless, infants often have their own timetable as to when they will become attached to their parents and other family members. Bonding, or the formation of a close, personal relationship, is usually based on a secure attachment. A secure attachment occurs when an infant understands that parents or caregivers will be responsive to his or her needs. This realization encourages a child to reach out and explore, knowing that his or her parents will provide a so-called safety net. Another type of attachment, referred to as anxious avoidant attachment, is observed in infants who are repeatedly rejected. These children develop an isolated lifestyle where they do not have to depend on the support and care of others. Child neglect will be covered in more detail in Chapter 44, Pediatrics. Trust and mistrust refers to a stage of development from birth to about 18 months of age. Most infants desire that their world be planned, organized, and routine. If the infant perceives that his or her parents or caregivers will provide this environment for them, the infant gains trust in those people. The opposite also holds true. Toddlers and preschoolers. Physical changes. In toddlers, age 1 to 2 years, and preschoolers, age 3 to 5 years, the pulse rates and respiratory rates are slower than the corresponding vital signs in infants, whereas the systolic blood pressure is higher, approximately 100 millimeters of mercury. At the same time, weight gain should level off. A toddler's cardiovascular system is not dramatically different from that of an adult. A toddler's lungs continue to develop more bronchioles and alveoli. Although toddlers and preschoolers have more lung tissue, they do not have well-developed lung musculature. This anomaly prevents them from sustaining deep or rapid respirations for an extended period of time. The loss of passive immunity in the immune system is possibly the most obvious development at this stage of human life. Common colds often develop that may manifest as gastrointestinal distress or upper respiratory tract infections. As toddlers spend more time around playmates and classmates, they acquire their own immunity as the body is exposed to various viruses and germs. Neuromuscular growth also makes considerable progress at this age. Toddlers and preschoolers spend a great deal of time finding out exactly how to use their expansive nervous system and the muscles it controls by walking, running, jumping, and playing catch. This stage also includes the continued development of the renal system and of elimination patterns, for example, toilet training. Other developments that occur during this time frame include the emergence of baby teeth. Teething, for example, breaking teeth through the gums, can be painful and accompanied by fever. In addition, parents or caregivers and toddlers are enthralled with sensory development, for example, tickling. Psychosocial changes. This period of development is often exciting for parents. The toddler or preschooler is learning to speak and express himself or herself, thereby taking a major step toward independence. By the age of 3 or 4 years, most children can use and understand full sentences. As they progress through this stage of their life, they will go from using language to communicate what they want to using language creatively and playfully. This is also the time when toddlers begin to interact with other playmates and start to play games. Playing games teaches control, following of rules, and even competitiveness. A lot of learning and development takes place by the child watching his or her peers during group outings, such as playdates with other children. Of course, behavior observed on television and the internet can also be learned, which is why some parents limit their children's viewing choices or the amount of time they devote to these activities. During this phase of development, children also learn to recognize sexual differences by observing their role models. School-age children. Physical changes. From age 6 to 12 years, a school-age child's vital signs and body gradually approach those observed in adulthood. Obvious physical traits and body function changes become apparent as most children grow about 2.5 to 3.5 kilograms and 5 to 6 centimeters each year. Their permanent teeth also come in during this period. Psychosocial changes. Children are engaged in a lot of psychosocial growing up during the school years. Parents as a whole do not devote as much time to their children during this phase. Nevertheless, it is at this critical time in human development that children learn various types of reasoning. In pre-conventional reasoning, children act almost purely to avoid punishment and to get what they want. In conventional reasoning, they look for approval from their peers and society. In post-conventional reasoning, children make decisions guided by their conscience. During this stage, children begin to develop their self-concept and self-esteem. Self-concept is our perception of ourselves. Self-esteem is how we feel about ourselves and how we fit in with our peers. Adolescents, teenagers. Physical changes. The vital signs of adolescence age 13 to 18 exists years begin to level off within the adult ranges, with the systolic blood pressure generally between 110 and 131 millimeters of mercury, a pulse rate between 60 and 100 beats per minute, and respirations in the range of 12 to 20 breaths per minute. Adolescence is also the time of life when humans experience a growth spurt, for example, an increase in muscle and bone growth, and blood changes. As a whole, boys experience this stage of development later in life than girls do. When this period of growth has finished, however, boys are generally taller and physically stronger than girls. One of the more subtle changes during this phase of life is the maturation of the human reproductive system. Secondary sexual development begins, along with enlargement of the external sex organs. Pubic hair and axillary hair begin to appear. Voices start to change in range and depth. In girls, the breasts and thighs increase in size as adipose tissue is deposited there. Menstruation begins during this time. Menarche, the first menstrual bleeding, is starting to occur at increasingly younger ages, however, so it is not uncommon to begin menstruation prior to becoming a teenager. Another key development in girls is the release of follicle-stimulating hormone and luteinizing hormone, both of which increase estrogen and progesterone production. In contrast, the hormone gonadotropin is secreted in boys and results in the production of testosterone. Acne can occur due to hormonal changes. Psychosocial changes. Adolescents and their families often deal with conflict as teenagers try to gain control of their lives from their parents. Privacy becomes an issue among adolescents, their siblings, and their parents. Adolescents may struggle to create their own identity, to define who they are. They may also show greater interest in sexual relations. Many adolescents are fixated on their public image, and are terrified of being embarrassed. At this age, a code of personal ethics is developed, based partly on parents' ethics and values and partly on the influence of the teenager's environment. At this tumultuous time, teenagers are at a higher risk than other populations for suicide and depression. Early adults. Physical changes. Early adults range in age from 19 to 40 years. Their vital signs do not vary greatly from those seen throughout adulthood. Ideally, the pulse rate will stay around 70 beats per minute, the respiratory rate will stay in the range of 12 to 20 breaths per minute, and the blood pressure will be approximately 120 per 80 millimeters of mercury. From age 19 years to just a little after 25 years, the human body should be functioning at its optimal level. Between 25 and 30 years of age, the intervertebral discs in the spine begin to settle, and height can sometimes be affected, causing a shrinking. Fatty tissue increases, which leads to weight gain. Muscle strength decreases and reflexes slow. The loss of muscle mass begins at middle age at a rate of approximately 1% per year. In severe cases, it can lead to a loss of approximately 50% by the time a person reaches their 80s or 90s. This phenomenon is called sarcopenia. Proper maintenance of physical activity beginning at any point in life can minimize and even reverse loss of skeletal muscle mass, in part. When in its advanced stage, it becomes a component of the frailty syndrome in late adult age. Psychosocial changes. 3 words best describe a human's world during this stage of life: work, family, stress. During this period, humans strive to create a place for themselves in the world, and many do everything they can to settle down. Along with this natural tendency to settle comes romantic love and childbirth. Despite all of the stress and change, this age group enjoys one of the more stable periods of life. Middle adults. Physical changes. Middle adults are ages 41 to 60 years. This group is vulnerable to vision and hearing loss. Cardiovascular health also becomes an issue in many people, as does the greater incidence of cancer. In women, menopause, the cessation of menstruation, begins in the late 40s or early 50s. A great variability in general health condition exists depending on each adult's lifestyle, living environment, and his or her capacity to respond to adverse situations. Each individual needs to be assessed as a unique case. Psychosocial changes. Middle adults tend to focus on achieving their life's goals, as they realize that they are approaching the halfway point in human life expectancy. At this point, some parents must readjust their lives as their children leave the home, commonly called empty nest syndrome. This may be different for middle adults who have not invested in a nuclear family earlier on. New models of lifestyles are emerging. Many women conceive children at a later age, after having entered the workforce at an early age. Also, more people remain single, particularly in urban cities. Fewer people get married, and some choose to live in non-marital partnerships. Depending on earlier social investment, some may experience more isolation and loneliness. Others may invest more in their community or new relationships. New realities at this time of life, such as living with a chronic illness or a diagnosis of cancer, or financial and retirement concerns, may become worrisome issues for some. As consumption, debts, and retirement age are rising, middle adults may view these concerns as challenges to be overcome rather than a threat to be avoided. Late adults. Physical changes. Late adults include those ages 61 years and older. Life expectancy is constantly changing. In 1979, life expectancy was about 73 years. It is approximately 78 years at this time, with maximum life expectancy estimated at 115 years. Later in life, the vital signs depend on the patient's overall health, medical conditions, and medications taken. Currently, late adults are staying active longer than did their predecessors. Thanks to medical advances, they are often able to overcome numerous medical problems, but may need multiple medications to do so. Cardiovascular system. Cardiac function declines with age consequent to anatomic and physiologic changes that are largely related to atherosclerosis. In this disorder, which most commonly affects coronary vessels, cholesterol and calcium build up inside the walls of blood vessels, forming plaque. The accumulation of plaque eventually leads to partial or complete blockage of blood flow. Atherosclerosis can also contribute to development of an aneurysm, or weakening and bulging of the blood vessel wall. An aneurysm may potentially rupture if it is subjected to high stretching forces. Many people older than age 65 years have atherosclerotic disease. Other age-related changes typically include a decrease in heart rate, a decline in cardiac output, the amount of blood circulated each minute, and the inability to elevate cardiac output to match the demands of the body. The vascular system also becomes stiff. For example, the pressure of systole increases with age. The left ventricle must then work harder, so it becomes thicker, losing its elasticity in this process. The thickening and stiffening of this muscle hinders ventricular filling, thereby decreasing cardiac output. Similar stiffening occurs in the heart valves, which may impede normal blood flow into and out of the heart. As the blood passes through these stiffened valves, a heart murmur may be heard, even in the absence of disease. Decreases in elastin and collagen in blood vessel walls, in turn, reduce the elasticity of the peripheral vessels by as much as 70%. Compensation for blood pressure changes will be hampered because these vessels are less able to distend and contract. Respiratory system. In late adults, the size of the airway increases, and the surface area of the alveoli decreases. The natural elasticity of the lungs also decreases, forcing late adults to use their intercostal muscles more to breathe. In addition, the chest becomes more rigid because of calcification of the ribs to the sternum, which adds to the difficulty of breathing. The loss of the mechanisms that protect the upper airway can include a decreased ability to clear secretions as well as decreased cough and gag reflexes. The cilia that line the airways diminish with age, while the innervation of the structures in the airway provides increasingly less sensation. Without the ability to maintain the upper airway, aspiration and obstruction become more likely. When a younger patient inhales, the airway maintains its shape, allowing air to enter. As the smooth muscles of the lower airway weaken with age, strong inhalation can make the walls of the airway collapse inward and cause inspiratory wheezing. The collapsing airways result in low flow rates, because less air can move through the smaller airways, and air trapping, because air does not completely exit the alveoli, incomplete expiration. In older adults, the vital capacity, the volume of air moved during the deepest inspiration and expiration, is significantly decreased as compared with the vital capacity noted in young adulthood. Factors contributing to this decline include loss of respiratory muscle mass, increased stiffness of the thoracic cage, and decreased surface area available for the exchange of air. Physiologically, vital capacity decreases, and residual volume, the amount of air left in the lungs after expiration of the maximum possible amount of air, increases with age. As a consequence, stagnant air remains in the alveoli and hampers gas exchange. This effect can produce hypercarbia, increased carbon dioxide in the bloodstream, and acidosis, even when the person is at rest. Renal and gastric systems. In the kidneys, both structural and functional changes occur in the late adult. The filtration function of these organs, for example, declines significantly between the ages of 20 and 90 years. Kidney mass decreases over the same span of time. The number of nephrons, the basic filtering units in the kidneys, also declines between the ages of 30 and 80 years. Aging kidneys respond less efficiently to hemodynamic stress, for example, stress relating to the circulation of blood, and to fluid and electrolyte imbalances. Changes in gastric and intestinal function may inhibit nutritional intake and utilization in older adults. For example, taste bud sensitivity to salty and sweet sensations decreases. Saliva secretion decreases, which reduces the body's ability to process complex carbohydrates. Gastric motility slows with age because of the loss of intestinal tract neurons, which can lead older adults to feel constipated or not hungry. Likewise, gastric acid secretion diminishes. Blood flow in the mesenteries, membranes that connect organs to the abdominal wall, may drop by as much as 50%, decreasing the ability of the intestines to extract nutrients from digested food. Gallstones become increasingly common with age, and anal sphincter changes reduce elasticity, and can produce fecal incontinence. Nervous system. Nervous system changes can result in the most debilitating of age-related ailments. In the central nervous system, the brain weight may shrink 10% to 20% by age 80 years. A selective loss of 5% to 50% of neurons occurs, and the surviving neurons shrink in size. The frontal lobe may lose as much as 20% of its synapses, the junctions between neurons, over the course of a person's life. Motor and sensory neural networks become slower and less responsive. The metabolic rate in the older brain does not change, however, and oxygen consumption remains constant throughout life. The brain, which is surrounded by the meninges, takes up almost all of the space in the skull. Cerebrospinal fluid protects the brain inside these membranes. Unfortunately, age-related shrinkage creates a void between the brain and the outermost layer of the meninges, which provides room for the brain to move when stressed. This shrinkage also stretches the bridging veins that return blood from inside the brain to the dura mater. If trauma moves the brain forcibly, the bridging veins can tear and bleed. Bleeding can empty into this void, resulting in a subdural hematoma, which may go unnoticed for some time. Increased intracranial pressure is required for signs of head trauma to be present. The intracranial pressure will not rise, and, therefore, its signs will not be present until the void has been filled and pressurized. For more information, see Chapter 24, Head and Face Injuries. Functioning of the peripheral nervous system also slows with age. Sensation becomes diminished and misinterpreted. The resulting slowdown in reflexes may contribute to the incidence of trauma. Nerve endings deteriorate, and the ability of the skin to sense the surroundings becomes hindered. Hot, cold, sharp, and wet items can all create dangerous situations because the body cannot sense them quickly enough. Sensory changes. Pupillary reaction and ocular movements become more restricted with age. The pupils are generally smaller in older patients, and the opacity of the eye's lens diminishes visual acuity, and makes the pupil sluggish when responding to light. Visual distortions are also common in older people. Thickening of the lens makes it harder for the eye to focus, especially at close range. Peripheral fields of vision become narrower, and a greater sensitivity to glare constricts the visual field. Hearing loss is about 4 times more common than loss of vision in late adults. Changes in several hearing-related structures may lead to a loss of high-frequency hearing, or even deafness. Psychosocial changes. As a paramedic, you should treasure your opportunities to spend time with and communicate with late adults. Many of them have amazing stories and experiences to share with us, yet we often take them for granted. Older people share with us a great amount of wisdom, and we need to remind them of their self-worth. Indeed, until about 5 years before death, most late-stage adults retain high brain function. During the last 5 years preceding death, however, mental function is presumed to decline, a theory referred to as the terminal drop hypothesis. As the older population continues to grow, we have the responsibility to seek out unique ways to accommodate their needs during their last 20 to 40 years of life. While many older adults refuse to give up the independence of having their own home, the number of assisted living communities is growing. These facilities allow older adults to live in campus-based communities with people in their own age group, while enjoying the privacy of their own apartment, and the security of nursing care, maintenance, and food preparation, if desired. Some assisted living facilities are being created near childcare facilities, for example preschools or kindergartens, to allow older adults the opportunity to interact with children. Unfortunately, assisted living facilities can be expensive. The decision to stay at home or to move to a facility may be limited by frailty or economic issues. Prolonging life and maintaining quality of life depends on also maintaining meaningful social interactions, mobility, and the best level of independence possible in a safe environment where the person can feel connected. Most people need to deal with financial issues throughout their lives. Few things in life produce more worry and stress than money problems. Late adults, in particular, may constantly worry about rising costs of healthcare, and are often forced to make decisions such as whether to pay for groceries or their medication. Modern families often take less responsibility for their older family members than earlier generations did. Women aged 65 and over are more likely to live in low-income households than their male counterparts. In 2015, 16.3% of elderly women were in low income, compared with 11.9% of their male counterparts. In addition, 33% of single elderly women were in low-income households, as were 29.8% of their male counterparts. In contrast, 8.7% of seniors in couples were in low income. This problem remains to be resolved. Chapter 3. Illness and Injury Prevention. Injury Prevention and EMS. Nearly 30 years ago, San Diego paramedic Paul Maxwell went on a drowning call. A 2-year-old boy had wandered away from a daycare facility and fallen into a neighbor's backyard pool. Despite everyone's best efforts, he could not be resuscitated. The mother was inconsolable, and her cries haunted the paramedic. Maxwell wondered how such tragedies could be prevented if he could help it. He never wanted to go on another call like that again. Through a little investigation, and looking up incidents on his EMS systems database, he discovered a pattern of increased drownings in his region. Maxwell made the decision to get involved. In cooperation with his EMS agency, he contacted other groups in his community with an interest in child safety. Using his system's data, and motivated by his first-hand knowledge of the suffering that such a death inflicts, Maxwell began a coordinated and successful effort to reduce backyard pool drownings in his community, through both legislation and education. Although the reduction in drownings was incentive enough for Maxwell, he was recognized with a special award by the state of California. More than a few paramedics have been motivated by their experiences to work actively on prevention. Throughout Canada, paramedics are taking the lead or providing support in a wide variety of intervention-specific prevention measures or activities designed to increase positive health and safety outcomes. From beginnings such as these, EMS has emerged as a strong advocate and practitioner of injury prevention. Few paramedics see the scene of an injury as a whole, the physical situation, the design flaws in home or highway, and the tragic stress of trauma. Paramedics, of course, participate in illness prevention such as influenza immunization programs or blood pressure screening. However, illness prevention programs are often the focus of physicians and public health officials. This chapter focuses on injury because of your unique perspective on injuries. Few providers in a hospital or a physician's office are conscious of the physical situation of an accident site, for example, or the number of times an incident has occurred at that site. You are uniquely aware. The principles and techniques for illness prevention are not substantially different from those for injury prevention. If you discover a need for a prevention program, perhaps some of your older patients might not be getting their influenza or pneumococcal vaccines. By all means, apply the principles. Common roots. Injury prevention shares a common root with EMS, the historic National Academy of Sciences National Research Council 1966 study, Accidental Death and Disability. The neglected disease of modern society. The Commission noted that just as EMS could help with trauma after an event, injury prevention initiatives could help before an accident happened. Strengthening this link, the broader definition of injury prevention has always included EMS. Primary injury prevention is defined as keeping an injury from ever occurring. EMS traditionally has focused on secondary injury prevention, reducing the effects of an injury that has already happened. For the inquiring mind, a third area, tertiary prevention, is defined as the effort to rehabilitate a person who has survived an injury. In 1996, the consensus statement on the EMS role in primary injury prevention was published. Representing every imaginable EMS constituency, the authors of the statement made clear that primary injury prevention is an essential activity that must be undertaken by the leaders, decision-makers, and providers of every EMS system. The 2011 revision of the National Occupational Competency Profile, NOCP, for paramedics, published by the Paramedic Association of Canada, added a new section on health promotion and public safety. Paramedics should have, at a minimum, an academic understanding of illness and injury prevention as defined by Competency 8.1a, participate in health promotion activities and initiatives, and 8.1b, participate in injury prevention and public safety activities and initiatives. Of course, the number one priority for paramedics is to be prepared to respond to and treat the injuries that will inevitably occur in their communities. And all paramedics in particularly busy systems will find that time for prevention initiatives will be limited. However, there is a role for every paramedic, at some level, in primary injury prevention. This includes, first and foremost, teaching others in the healthcare system and the public why you see an injury recurring at the same place. Why EMS should be involved. Leaders in both EMS and the prevention field offer the following rationale. Paramedics are widely distributed in the population. Paramedics reflect the composition of the community they serve. In many rural communities, the paramedic might be the most medically sophisticated person. If properly coordinated, EMS would provide a formidable resource in the effort to reduce the overall injury burden. Paramedics are high-profile role models. Paramedics are perceived as champions of their patients. Paramedics are welcome in schools and other environments conducive to delivering the prevention message. Because they face the results of injuries every day, EMS providers are perceived as authorities on injury and prevention. A paramedic talking to a city council about drowning prevention legislation, relating a true story about the suffering he or she witnessed, can be an extremely effective teacher. Injuries as public health threat. According to the U.S. National Center for Injury Prevention and Control, part of the Centers for Disease Control and Prevention, CDC, injuries are the intentional or unintentional damage to the person resulting from acute exposure to thermal, mechanical, electrical, or chemical energy or from the absence of such essentials as heat or oxygen. Historically, injuries were not grouped together. Instead, they were reported under distinct umbrellas, which made it difficult to let the lay population see just how widespread injuries truly are. Grouping injuries as a common health problem makes it possible to consider the breadth and depth of the problem. It has enabled public health officials and other healthcare providers to call attention to important problems and target more effective interventions. Intentional injuries, such as assaults or suicide, are included in the definition. EMS can often play a supporting role here too, but can usually have a greater impact in preventing unintentional injuries. How big a problem are injuries in Canada? To many health experts, it is the largest public health problem facing the country today. According to data published by Statistics Canada, in 2016, 16,527 people died of injury-related causes, up from 15,064 in 2007. The majority were unintentional injuries. 21% transport-related, 18% fall-related, and 9% poison-related. Unintentional injuries are the fifth leading cause of hospitalization and fifth leading cause of death in Canada. Unintentional injuries account for approximately 200,000 hospital admissions. Intentional injuries included suicide, 24%, and homicide, 3%. These figures are likely to change given the current opioid epidemic. In British Columbia, for example, the coroner's office has reported an increase in illicit drug poisoning deaths from 211 in 2009 to 1,450 in 2017. It is estimated that 15% of the Canadian population, or 4.27 million people, sustained an injury in 2009 and 2010 that limited their daily activities, over one-half of whom sought medical treatment within 48 hours for their injury. Table 3-1 shows the top 10 causes of death in Canada. This information is extremely important in understanding how injury impacts different age groups. Unintentional injuries are the leading cause of death for males age 1 to 45 years, and for females age 1 to 24 years. Over one-half of deaths can be attributed to unintentional injuries, and intentional self-harm combined. For all ages combined, unintentional injuries are the fifth leading cause of death. How much do these injuries cost society, above and beyond the tremendous personal suffering? It is estimated that unintentional injuries account for more than $16 billion, 81% of injury costs, in Canada. There is another concept that researchers are using to measure the cost to society: years of potential life lost. It works like this: assume a productive work life until age 65, and deduct the year of death from that age. Thus, an 18-year-old who dies in a traffic collision has lost 47 years of potential productive work life, whereas someone who dies of a stroke at age 63 years has lost 2 years. Because injuries are a leading cause of death in the young, it quickly adds up. This method allows a comparison of the years of productive work life lost, disease by disease. It can measure how many years of usefulness to society a child killed in an accident could have had, comparing those years to those of an older person who, for example, had a myocardial infarction. The value of the comparison is to teach members of your community that the prevention of a childhood accident is of great importance to the community. It is easier to measure death rates than to measure non-fatal injury, morbidity rates, because visits to clinics, emergency departments, doctors' offices, and other places for treatment are scattered throughout a number of agencies and professional groups. Principles of injury prevention. The 4 E's of prevention. An injury risk is a potentially hazardous situation in which the well-being of people can be harmed. Interventions need to combine education with 3 other types of interventions: enforcement, engineering or environment, and economic incentives. These are commonly referred to as the 4 S's of injury prevention. The most effective injury prevention efforts reflect a combination of these interventions. Education. Most paramedics know that people can behave in ways that cause them to become injured or put others at risk. Many people do not know, and therefore cannot assess the risk of doing something. I didn't know it was unsafe to put my baby's seat in the front passenger seat. Or, people know the risk: I won't wear seat belts, they are too uncomfortable, and disregard it anyway. Through education, you can often inform people about potential dangers, and then act to persuade them to change risky behavior. Show moms and dads how to use an infant car seat. Tell people about the horrors of being thrown from a vehicle. To be effective, messages need to be tailored to very specific groups, and reinforced with meaningful rewards. Educational techniques that seem to be particularly promising include the use of contracts or participant commitment, incentives, behavioral feedback, and modeling. However, despite your best efforts, some members of your community may know about a risk, but their behavior will not necessarily change. There are even some paramedics who refuse to wear seat belts in their ambulances. A crucial advantage of any educational effort is that it can pave the way to legislative, environmental, and technological changes. Enforcement. Behavior can be forced to change by law, that is why it is called law enforcement. Legislation and regulation formulate rules that require people, manufacturers, and governments to comply with certain safety practices. Legislation is made by elected government bodies enacting laws that require safe practices, while regulations are made by bureaucracies or agencies that set policies and establish procedures that control the manufacture, sale, and/or use of products. Litigation sets policy when lawsuits are brought against manufacturers or distributors of dangerous products. For example, product liability litigation can encourage manufacturers to remove dangerous products from the market or make them safer. All these measures have been shown to be helpful in enforcement of safety regulations. You can play a role in working with other stakeholders involved in injury prevention to educate and support lawmakers or regulators where further measures are needed. Engineering or environment. Most paramedics know spots where adding guardrails or smoothing out dangerous curves in a road could prevent collisions. Changing the design of products or spaces such as roads can offer automatic protection from injury, often without any conscious change of behavior by the individual. These are called passive interventions. For example, Making child-resistant bottles is a passive intervention that reduces poisonings, and it can be more effective than trying to keep the bottle out of children's reach. Strategies to change the environment can include social, legal, political, and cultural approaches. Environmental modifications, which are often expensive, usually happen when the community's awareness of the problem is raised, causing that community to accept responsibility for change. Economic incentives. Economic self-interest. Saving money on healthcare costs or insurance rate reduction for careful drivers provides monetary incentives to reinforce safe behavior. The threat of lawsuits and significant monetary damages often causes manufacturers to improve the safety of consumer products, an economic loss that serves as an incentive to change behavior. Organizations also recognize the value of offering free or subsidized safety products, bike helmets, fire extinguishers, safety locks, to encourage use. The value of automatic protections. Passive interventions, those that do not require a conscious decision to act, are often the most successful of all interventions. This approach is also referred to as automatic protection. Examples include the use of sprinkler systems in commercial buildings, airbags in vehicles, or softer, yielding materials for playground surfaces. These measures provide 24-hour protection without requiring a conscious action or decision on the part of the user. Consider the following injury prevention strategies, comparing education to automatic protection, in the case of head and chest injuries of drivers in motor vehicle collisions. Option 1. Educate people to buckle up every time they drive. Option 2. Require that car manufacturers install automatic seat belts and airbags. The automatic protection offered by option 2 is more likely to reduce injuries because people do not have to do anything to protect themselves each time they are at risk. Again, however, a combination of approaches, education, enforcement, engineering, or environmental modifications, and economic incentives, will result in the most effective strategy. Note that education is still an important aspect of the above examples. Motor vehicle passengers need to know that airbags do not replace the need for seat belts. Models for injury prevention. A variety of visual models have been created to describe a health problem and how to approach it. The public health model identifies and seeks to control 3 factors: the host, the agent, and the environment. The public health model triumphed in the prevention and control of diseases such as malaria and polio, sometimes by attacking only 2 parts of the model. For example, to prevent malaria, you might develop a vaccine, spray pesticides to kill mosquitoes, and/or drain swamps to keep mosquitoes from breeding. These approaches target the host, people, the agent, mosquitoes, and the environment, swamps. The public health model has been applied to a variety of injury problems. If you add the 4 S of injury prevention, you can think through appropriate strategies for each part of the model: the host, the agent, and the environment. Figure 3-6 sets out the 3 parts of the public health model using the example of bicycle vehicle collisions. The Haddon Matrix. William Haddon, Jr., MD, the U.S. National Highway Traffic Safety Administration's first director, had a mandate to find ways to prevent people from being killed and injured on U.S. highways. Haddon created a matrix that identified several principles of injury prevention. The matrix proved so successful in helping researchers think about injuries that it was named after Haddon, the Haddon Matrix. Haddon added the factor of time to the previous models used to address the causes of injury. The host, agent, and environment are seen as factors that interact over time to cause injury. These factors correspond to 3 phases of the event: pre-event, event, and post-event. The matrix uses 9 separate components to analyze the injury. The Haddon Matrix encourages creative thinking and understanding the causes of and potential interventions for injury. Table 3-2 shows a Haddon Matrix for the example of childhood motor vehicle occupant injuries. Most paramedics are trained to respond to the post-event, the period of time after an injury has already occurred. The 911 call is received by the emergency medical dispatcher, who sends a service unit to the scene. There, the team members administer emergency pre-hospital care, a form of secondary intervention that can change the outcome, severity, or result of the event. You can use the Haddon Matrix to trigger your fellow paramedics and others in the community to think about and plan for strategies before the 911 call comes through. The pre-event phase can get everyone brainstorming about everything that can be done to prevent an injury from occurring. The event phase can get all people involved thinking about interventions to minimize an injury at the time of the event. The post-event phase can address ways to lessen the severity of the injury once it has occurred. Injury prevention requires broad and innovative thinking to be most successful. The Haddon Matrix helps you to think through which interventions can be effective at certain points in time. Addressing injury prevention within the context of a timeline pre-event, event, and post-event can expand our problem-solving capabilities beyond the answer of more education. Blaming the parent for lack of supervision or the driver for going too fast does not generate solutions to the problem of childhood injury. You can generate solutions with physical and measurable attributes using the Haddon Matrix as a guide. Injury surveillance. Surveillance in injury prevention does not mean watching over a criminal suspect. In injury prevention, it means watching over society by collecting and analyzing injury data. Injury surveillance is the ongoing, systematic collection, analysis, and interpretation of injury data essential to the planning, implementation, and evaluation of public health practice. These data are collected, and then carefully disseminated to people or organizations who can use the data to effect change. The final link in the surveillance chain is the application of these data to interventions aimed at preventing injuries. A strong surveillance system is fundamental to creating an effective injury prevention program. To do the most good, you need to know who is being injured, where, and by what mechanism. The news media may focus on a dramatic incident where a dozen people are severely injured, but surveillance data might show that a commonplace, but less newsworthy injury, such as falls among older people, is a greater threat to the community, and more easily remedied. As part of the health system, paramedics need to focus on injury prevention. Do not let the headlines be your guide. Getting started in your community. An abundance of problems faces every community. Each community requires an assessment of the problems that are impairing the health of the largest number of people. Otherwise, you may be overwhelmed with the enormity of the task. There is a good chance that, eventually, you can roll up your sleeves and dig in to remedy even the problems that arise from the specific social conditions that cause some injuries. But it will give you and your community a good feeling to address a problem that will have the maximum impact on the community's well-being. Recognizing injury patterns in your community. To be effective in prevention, you need to understand the patterns of injuries that occur in your community, and learn the characteristics of its population and environment and the types of risks that are present. Your regional or provincial EMS department or public health office will have the most data about injury statistics, and is a good starting place to gather information. Many provinces have this information on the internet. A wide variety of other resources are readily available online, including detailed information about specific problems, case studies, and expert assistance. Intentional injuries. Intentional injuries include suicides and suicide attempts, homicides, assaults, including rapes and spousal abuse, and child and elder maltreatment. In 2017, there were 660 homicides and 3,926 suicides. It is estimated that nearly 5,000 intentional injuries are inflicted each year. Researchers are studying the causes of intentional violence in Canada. Certain factors emerge as numerically connected with intentional violence, being male, access to firearms, alcohol abuse, history of childhood maltreatment, mental illness, and poverty. These are all risk factors characteristics that increase the chances of disease or injury. It is often overwhelming to consider solutions when the challenges are linked to deeply rooted social ills. How can EMS personnel prevent intentional violence when it is clear that the scope of the problem is a wide one? One way paramedics have played important supporting roles in programs that seek to reduce suicide, domestic violence, and child maltreatment is by carefully reporting data and noting risk factors while on the scene. Also, paramedics can be taught to identify injuries and risk factors associated with domestic violence or child maltreatment, and report them to the proper channels. Remember, you are about to become a paramedic. What you do, your expectations of yourself, and your role will filter down to the other members of your crew. Being a conscientious observer will set an example. Unintentional injuries. Unintentional injuries have no premeditation. We often call them accidents. Table 3-3 shows the top 6 causes of unintentional injury. Falls account for the most unintentional deaths, followed by suicide or self-harm, transport incidents, other injuries, unintentional poisoning, and other causes. Almost all motor vehicle deaths are classified as unintentional. Unintentional injuries in children. Many prevention programs have been strongly linked to children, for good reason. Each year 20% to 25% of all children sustain an injury severe enough to require medical attention, miss school, and/or require bed rest. Each year, more than 30,000 injured children require medical treatment. Their developing bodies, including a larger head in proportion to the body, thinner skin, and a smaller airway, put them at higher risk of injury, and of being more seriously affected by the injury than adults. Grants, partners, and commercial sponsors support car seat inspections or donations of bike helmets for children because communities recognize that children are at risk. An additional reason to focus on children's issues is the pass-along effect. Other family members benefit from the message, too, such as when a third grader insists that Daddy buckle up too. Parachute Canada, which now includes the Safe Kids Canada campaign, is part of a worldwide organization that raises public awareness and is dedicated to reducing childhood injuries. It has an excellent website, which can easily be found by looking up the name in a search engine. Risk factors for children. Children at greatest risk of injury are of lower socioeconomic status. The patterns of injury will differ from community to community, but just as the poorest children statistically are most at risk of contracting a disease, they are also at risk of injury. Interestingly, evidence finds that children on both ends of the socioeconomic spectrum, the poorest and most affluent, are at higher risk of vaccine-preventable diseases due to poor immunization status, though for different reasons. The U.S. CDC reports that home injuries of children occur most frequently where the following exist. Water, such as in the kitchen or bathroom, or a backyard swimming pool. Intense heat, such as in the kitchen or backyard barbecue. Toxic agents, such as in the kitchen, bathroom, garage, or a purse. High potential energy, such as in stairwells or loaded firearms. Many community members have a common belief that schools have become more violent and that intentional injuries are an increasing threat to students. However, unintentional injuries accidents still represent a much greater threat to health. School injuries occur most frequently during sports activities, industrial arts classes, and on playgrounds. With the wide variety of injuries affecting children, how do we prioritize prevention efforts? Experts in public health suggest focusing on injuries that have high mortality, death rates or hospitalization rates, that have a high long-term disability rate, or that have effective countermeasures. The highest priorities are assigned to those types of injuries that are common, severe, and readily preventable. Opioids as a public health challenge. The opioid crisis is a major public health crisis across Canada. According to Canada's Chief Public Health Officer, in 2016, there were more than 2,800 apparent opioid-related deaths in Canada, which is greater than the number of Canadians who died at the height of the HIV epidemic in 1995. Substance use costs $38.4 billion a year to the Canadian economy through its direct effect on the healthcare and criminal justice systems, as well as indirect effect on loss of economic productivity due to premature death and poor health. Healthcare costs account for almost 30% of this figure. In 2014, opioids resulted in the third highest amount of healthcare costs, following tobacco and alcohol, due to substance use, totaling $313 million. There was a 53% increase in the rate of hospitalizations in Canada for opioid poisoning from 2009 to 2018, with the greatest increase in this time period occurring from 2016 to 2018 and amongst those aged 15 to 24 years. Although more than one-half of poisonings in 2018 were accidental, the highest rates of self-inflicted harm were seen among youth aged 15 to 24 years, underscoring the need for addressing the mental health challenges that contribute to illicit drug use. Much of the increase in deaths from illicit drug use has been attributed to fentanyl. In British Columbia, the rate of drug poisoning deaths per 100,000 increased from 4.2 in 2008 to 30.9 in 2018. According to data from the British Columbia Coroner's Service, the proportion of illicit drug poisoning deaths for which illicit fentanyl was detected was approximately 84% in 2017. Given that the number of non-fentanyl detected illicit poisoning deaths has remained stable since 2011, fentanyl appears to account for the increase in poisoning deaths since 2012. The majority of fatal illicit drug poisonings in 2018 occurred at inside locations, while notably there were no deaths at supervised consumption or drug overdose prevention sites. Paramedics should also be aware that evidence shows that supervised injection sites, such as Insight in Vancouver, increase client access to addiction treatment services, reduce disease transmission of blood-borne diseases, prevent morbidity and mortality associated with intravenous drug use, and reduce overall healthcare costs. While poisoning from fentanyl has rapidly increased in Canada, misinformation and inconsistent recommendations have resulted in confusion among first responders and healthcare providers. Paramedics responding to a situation in which there may be fentanyl or synthetic opioids require evidence-based recommendations to protect against exposure. These recommendations will also protect patients from additional harm due to unnecessary delays in care. In July 2017, the American College of Medical Toxicology and the American Academy of Clinical Toxicology released a joint position statement on preventing occupational fentanyl and fentanyl analog exposures among emergency responders. Based on review of the literature and reports to date, they recommend the following. Nitrile gloves provide sufficient dermal protection for routine drug handling. Incidental dermal exposures are unlikely to cause toxicity. However, exposures should be washed immediately with copious amounts of water. Alcohol-based hand sanitizers should not be used. If there is risk of significant airborne suspension of powdered opioids, a properly fitted N95 respirator or P100 mask should be worn. Workers who may encounter fentanyl or fentanyl analogs should be trained to recognize the objective signs of opioid intoxications, have naloxone readily available, and be trained to administer it to those with objective signs of hypoventilation. These recommendations do not apply to teams involved in heavily contaminated areas, such as drug labs, where additional precautions may be required. Community organizing. Those in EMS who have created successful prevention programs give the following advice for building a team and creating an implementation plan. Identify a lead person to coordinate the effort. Build as broad a base of support as possible. Create a realistic timeline for any project, keeping in mind that most must be ongoing to be effective. Gather data and facts that pinpoint who is being injured where, with what, and how frequently. Choose goals and objectives that are SMART, specific, measurable, attainable, realistic, and time-sensitive. Build consensus in the community on the need for action. Make sure you understand the religious, ethnic, cultural, and language challenges that you may face in implementing an intervention. Do not reinvent the wheel. Seek out others who have had success with similar interventions or who have expertise in public health. Anticipate opposition and expect some losses. Turf battles are common but not inevitable. As you lobby to legislators, be brief in phone calls, visits, and testimony. Set up your program so that you can measure results and make changes as needed. Use the PDSA cycle: plan, do, study, act. Establish self-sustaining funding sources. Keep a sense of humor, and persist. Change does not happen overnight. The 5 steps to developing a prevention program. This step-by-step approach to establishing an injury prevention program emphasizes the need to carefully establish goals and objectives with measurable outcomes. Although the following discusses childhood prevention programs, the methods can be applied to other age groups and their problems. 1. Conduct a community assessment. Bring people and groups together to assess what is already being accomplished in your region, and to establish what resources, expertise, time, money, are potentially available. Make sure to invite people who represent the community at large, in all its diversity, including survivors of injuries, and their families. Potential partners include EMS groups, private and public ground and air ambulance services, fire department-based services, volunteer services, unions or associations. Law enforcement, police departments and police officers, unions or associations, training centers. School groups, parent-teacher associations, student clubs, school boards, faculty. The media, management, editorial board members, staff reporters. Public health officials and healthcare providers, groups representing emergency physicians and nurses, pediatricians, hospitals, clinics. Members of the business community, including those related to insurance, cars, sports, home improvements, safety equipment, local chambers of commerce. Religious organizations, civic groups, and service clubs, such as the Kiwanis, Canadian Girl Guides, and Scouts Canada. Sports-related organizations such as Little Leagues or Young Men's Christian Associations YMCAs. Local chapters of non-profit groups, Parachute, Safe Communities Canada, Safe Kids Canada, Smart Risk, Think First Canada, Mothers Against Drug Driving, MAD, the Canadian Red Cross, Alzheimer's Society of Canada. Local and national celebrities, community leaders, and elected officials. Research groups, such as those at universities, private colleges, community colleges. Government bodies at federal, provincial, or municipal levels with programs aimed at injury prevention, Ministries of Transport, Health Canada, Public Health Agency of Canada. 2. Define the injury problem. On the basis of the community assessment, and the data you have been able to gather, define the problem in specific quantifiable terms. For example, you should be able to answer the following questions for your community. What are the most frequent causes of fatal and non-fatal childhood injuries? What populations, by age, location, and other characteristics, are at highest risk of these injuries? When and where are they occurring? Using the Haddon matrix, what other factors are associated with these causes? What, if anything, is already being done to prevent these injuries? Is there an effective intervention available? What resources do you have to develop, implement, and evaluate different interventions? 3. Set goals and objectives. Goals. Make this a broad, general statement about the long-term changes the prevention initiatives are designed to make. For example, a goal can be to decrease preventable injuries to children on the community's roadways. Objectives make these specific, time-limited, and quantifiable. There are 2 types. Process objectives. 1,000 child safety seats will be distributed to low-income families within the next 18 months, and outcome, impact, objectives. The bicycle safety program will increase the rate of helmet use by children younger than 18 years from 30% to 50% within the next 18 months. 4. Plan and test interventions. Interventions are the actions you take to accomplish your goals and objectives. Using the 4S of prevention, and the Haddon matrix, brainstorm options. Consider the resources you have available to commit, and make sure you have thoroughly reviewed what others have already done. You may find communities have had success with similar interventions in similar populations. In that case, you can reliably duplicate their efforts as a process objective. For example, other groups have shown that bike helmets reduce head injuries. You then need only to demonstrate increased usage of helmets in your targeted population. Experienced prevention specialists also suggest that you be keenly aware of timing and cultural considerations as you plan your intervention. Getting a sample group together and testing the intervention before actually rolling out the entire program usually helps to improve your chances of success. 5. Implement and evaluate interventions. To be credible, your intervention needs to be established so that the results can be measured quantitatively, that is, a formal evaluation will definitively tell you whether you met your goals and objectives. This is extremely important so that your experience can be shared with others. One EMS group knew from previous surveys that the seat belt usage rate in their community was well below the national average. They established an objective of improving seat belt usage in their community by 50%. Working with the Department of Public Health in their province, they enacted a series of prevention programs. To measure the effectiveness of different interventions, they put volunteers at selected intersections around the city. They physically counted with a clicker every belted, and non-belted motorist who stopped in front of them. You want to spend your time and resources on efforts you can show make a difference. There is a science to planning, implementing, and evaluating an intervention. Seek out others who have knowledge and experience in this facet of injury prevention. It will make for a better program. Finally, be aware that many, if not most, interventions demand ongoing attention to be effective. Those paramedics who had initial success in reducing backyard drownings saw the numbers go back up a few years after the initial burst of publicity, and after enthusiasm for the interventions began to wane. Legislation to fence pools worked well, but did not eliminate the problem. They had to gear back up to re-establish the educational interventions that had worked so well originally. Consider building long-term maintenance into any plan to continue the momentum of your program. Funding a prevention program. Ideally, emergency services should have the resources and motivation to include primary prevention activities in their normal operating budget. As a relatively new expansion of the EMS mission, this likely will take time. But motivated services and people have found a variety of innovative ways to secure resources, including partnering with the local media to create prevention messages, especially related to seasonal injuries or hazards. Seeking grants from regional, provincial, or national organizations. A good place to start is to contact your provincial EMS office about grant programs. Seeking sponsorships from local nonprofit service organizations or commercial firms, including fire, EMS, Kiwanis organizations, and car dealerships. Networking with other organizations interested in prevention often provides greater leverage in seeking grants or sponsorships. Perhaps the paramedic donates the time of volunteers and is a credible voice in the community, whereas the partner provides organizational resources and knowledge about establishing a scientifically credible injury intervention. How every paramedic can be involved. Taking care of patients is the #1 job of paramedics. You'll not have the time or inclination to get involved in every aspect of the primary injury prevention measures discussed here. However, there are certain things you can and should do, starting with preventing your own injuries. Primary injury prevention begins at home, so to speak, by taking care of yourself and at the same time presenting a role model for others in your service, and for the community in general. Do you always wear seatbelts, on and off duty? Do you drive safely? Have you prepared yourself physically for the rigors of the job? Do you practice safe lifting techniques? Do you always wear appropriate protective equipment? Do you always maintain scene safety? Your employer will have policies regarding many of these safety issues, but it is up to you to implement them and to take seriously the risks you face every day on and off the job. Refer back to Chapter 2 to review the appropriate use of personal protective equipment and practices. Responding to the call. Perhaps the most ironic, if not most tragic, of all injuries are those caused when an ambulance collides with another vehicle while speeding to a scene, only to find out later the original call was not serious or even one requiring transport. Studies have shown that very few calls demand the use of siren and lights, and many departments now require all ambulances to stop at every stop sign or red light on every call, and to maintain strict speed control. Prioritized dispatch systems using certified emergency medical dispatchers, EMDs, can provide sophisticated assessments of the need for different levels of response, and can improve scene safety while reducing the need for unnecessary responses. You can provide leadership within your own department for primary injury prevention by advocating policies or equipment that provide a safer environment or initiatives such as a paramedic wellness program. At the same time, you can be a role model by how you personally approach the multitude of decisions you face each day regarding the risks of injury. It is impossible to be a credible advocate for injury prevention if you do not practice what you preach. Education for paramedics. Every paramedic should understand the fundamentals of injury prevention. This can easily be the focus of a continuing education program. Some provinces sponsor injury prevention workshops geared specifically to paramedics. Contact your provincial EMS office to see if a workshop can be scheduled for your area, or contact your local public health office to see what training resources it might have available. There are also excellent self-paced courses, and additional information available online. The teachable moment. You are on the scene at the site of a collision between two vehicles. The injuries are not serious, and you notice one of the passengers was not wearing a seatbelt. As you prepare him for transport, you look him in the eye and say, "You were very lucky this time. The other vehicle didn't hit you square." I've seen plenty of very bad injuries from collisions less serious than this. You really need to wear your seatbelt every time you get in the car. It'll save your life. This was a teachable moment. Educators tell us that there are times when people are more receptive to accepting advice than others. A near miss like this makes people realize their vulnerability and the true risk of their behavior, and the lesson is more likely to stick. You are in the perfect position to articulate and reinforce this message. However, you must use good judgment and be sensitive to the situation. Lecturing a parent immediately after a child has been seriously injured is not going to be effective. What makes a teachable moment? The injuries are such that the parents, companions, or the patients themselves will be receptive to the message. You are aware of how ethnic and religious differences must temper the message. The scene is conducive to delivering such a message in a non-threatening, non-judgmental way. You are not intruding inappropriately or causing embarrassment. There is a definitive prevention measure that could have helped, such as using a seatbelt, correct installation of a car seat, wearing a helmet, or keeping firearms locked and safe. Vague advice is less likely to have a lasting effect. Collection and analysis of data. In the opening paragraph of this chapter, we referred to data about backyard drownings. The importance of collecting data and measuring trends, validating interventions, assessing resources, and ultimately persuading others to act cannot be overestimated. For the paramedic, this process starts with the pre-hospital care report, which is often approached as a necessary evil. Standardized coding of incidents is required to collect useful data from far-flung sources. By accurately and legibly describing the details of the scene, the external mechanism of injury, the nature of the injury, and the use or absence of protective devices, you can supply important evidence of the scope of a problem and help in monitoring trends. As a prevention advocate, assess your current pre-hospital care report to see if it can be modified to be a better tool. Are there ways for the information to be gathered more quickly? Can the information put into a computerized database be promptly updated, easily accessed, and searched? Get involved in local, provincial, or national database systems. Often, much information is being gathered, but agencies are not consistent or timely in the process, are not sharing data, or do not have it in a common database. For the injury prevention field, the accurate and timely collection of data is critically important. In EMS, our goal is to put resources into those prevention interventions that can do the most good. This requires documenting injuries and monitoring trends that can be tied to the effects of interventions. Conclusion. Injury prevention is a complex but rewarding field. Many veteran paramedics have embraced a leadership role in primary prevention after witnessing too many episodes of needless suffering. These leaders recognize their unique role and use their positions to support interventions that make a difference. In your own life, and in your workplace, you should be proactive in primary injury prevention, whether reducing the odds of a back injury by keeping fit, using proper lifting techniques, and protective gear, or taking advantage of a teachable moment with a patient. You can extend this interest further, reaching out in your community to become involved as a leader or a supporter of a wide variety of prevention programs. You'll find personal satisfaction and professional fulfillment in the challenge of learning a new field, interacting with a new set of colleagues, and reducing the suffering of those you serve. Chapter 35. Renal and Urologic Emergencies. Introduction. The urinary system performs two main functions for the body. It acts as the body's accounting firm, keeping track of the electrolytes, water content, and blood pH, and it acts as the blood sewage treatment plant, removing metabolic wastes, drug metabolites, and excess fluids. The kidneys perform these functions continuously, filtering 200 liters of blood each day. The most common renal disorder is kidney disease. Every day, an average of 15 Canadians are told their kidneys have failed, and each year there is a 7% increase in the number of people diagnosed with kidney disease. Today, Almost 43,200 Canadians are being treated for kidney failure. Dialysis treatment and care of patients who have received a kidney transplant cost the Canadian healthcare system approximately $2.6 billion annually. Kidney disease also contributes to the risk of cardiovascular disease, including hypertension, and other chronic diseases that shorten lifespan. Anatomy and physiology. The urinary system consists of the kidneys, which filter the blood and produce urine, the ureters, which transport urine from the kidneys to the bladder, the urinary bladder, which stores the urine until it is released from the body, and the urethra, which transports the urine from the bladder out of the body. The bean-shaped kidneys are found in the retroperitoneal space, behind the peritoneum, which extends from the 12th thoracic vertebra to the 3rd lumbar vertebra. The right kidney is slightly lower than the left due to the position of the liver. The medial side of the kidney is concave, forming a cleft called the hilum, where the ureters, renal blood vessels, lymphatic vessels, and nerves enter and leave the kidney. A fibrous capsule covers the kidney and protects it against infection. Surrounding this capsule is a fatty mass of adipose tissue, the paranephric fat, which cushions the kidney and holds it in place in the abdomen. A layer of dense fibrous connective tissue called the renal fascia anchors the kidney to the abdominal wall. The internal anatomy of the kidney can be divided into 3 distinct regions: the cortex, the medulla, and the pelvis. The cortex is the lighter-colored outer region closest to the capsule. Cortex is Latin for bark of a tree. The medulla, inner layer, meaning marrow in Latin, includes the cone-shaped renal pyramids, parallel bundles of urine-collecting tubules, and inward extensions of cortical tissue that surround the pyramids, called the renal columns. The renal pelvis is a flat, funnel-shaped tube that fills the sinus at the level of the hilum. The major and minor calyces branch off the pelvis and connect with the renal pyramids to receive the urine draining from the nephrons collecting tubules. This arrangement has been described as several strands of uncooked spaghetti, the collecting tubules, sitting in a thimble, the papilla, or tip, of the pelvis. The collected urine flows through the pelvis and into the ureter on its way to the bladder. Approximately 1/4 of the body's systemic cardiac output of blood flows through the kidney each minute. The blood flows from the abdominal aorta into the kidney via the renal artery. Once it enters the kidney at the hilum, the renal artery branches several times to become the microscopic afferent arterioles. The afferent arterioles quickly branch into a tuft of capillaries called a glomerulus, which is the main filter for the blood in the kidney. From the glomerulus, the blood enters the efferent arterioles, which branch into the peritubular capillaries, where tubular reabsorption occurs. This secondary set of capillaries is unique to the kidney. No other organ in the body has 2 distinct capillary beds. The capillaries then merge, forming venules and veins, until the renal vein leaves the hilum, carrying the cleansed blood to the heart via the inferior vena cava. Nephrons, found in the cortex, are the structural and functional units of the kidney that form urine. Each nephron is composed of the glomerulus, the glomerular, Bowman, capsule, which surrounds the glomerulus, the proximal convoluted tubule, the loop of Henle, and the distal convoluted tubule, which connects with the kidney's collecting tubules. Each kidney contains approximately 1.25 million nephrons. The glomerular capsule is a double-layered cup in which the inner layer infiltrates and surrounds the capillaries of the glomerulus. Special cells in the inner membrane called podocytes, foot cells, are foot-like extensions that wrap around the capillaries in the glomerulus to form filtration slits. The filtrate passes through these slits, across the filtration membrane, and into the capsule. In this manner, the filtration membrane prevents large molecules, such as proteins, from entering the capsule and being excreted. The amount of filtrate produced, called the glomerular filtration rate, is maintained at a relatively constant rate of 125 milliliters per minute in healthy adults. Changes in the glomerular filtration rate cause many of the renal emergencies encountered in the pre-hospital setting. Initially, the filtrate contains everything that can pass through the filtration membrane: salts, minerals, glucose, water, and metabolic wastes. As the filtrate passes through the rest of the nephron, tubular reabsorption and tubular secretion convert the filtrate into urine. As the fluid passes through the proximal convoluted tubule, the cells lining the proximal convoluted tubule remove all organic nutrients and plasma proteins, as well as some ions, from the filtrate to return them to the body. These compounds are deposited in the interstitial fluid surrounding the proximal convoluted tubule. As these solutes accumulate, the concentration of the surrounding fluid becomes higher than that of the filtrate. Water will then move from the filtrate by osmosis. The fluid and nutrients in the interstitial fluid, in turn, move into the peritubular capillaries around the proximal convoluted tubule. This process reestablishes the homeostatic balance in the blood, and reduces the volume of the tubular filtrate. Additional reabsorption of water and electrolytes occurs in the loop of Henle. The loop of Henle has two sections, the descending limb, extending toward the medulla, and the ascending limb, moving toward the cortex. The cells in the descending limb are permeable to water, but impermeable to sodium and chloride ions. The cells in the ascending limb are permeable to sodium and chloride ions, but impermeable to water. As a consequence, when the sodium and chloride ions move out of the ascending limb, they increase the solute concentration of the fluid surrounding the descending limb. Water moves by osmosis from the descending limb into the surrounding tissue, and eventually into the vasa recta, a series of peritubular capillaries that surround the loop of Henle. This countercurrent multiplier process allows the body to produce either concentrated or diluted urine, depending on the body's needs. After leaving the loop of Henle, the fluid enters the distal convoluted tubule. At this point, approximately 80% of the water and 85% of the solutes originally forced out of the glomerulus and into the filtrate have been reabsorbed. As the urine passes through the distal convoluted tubule and the collecting duct, both of which are impermeable to solutes, its composition undergoes its final adjustments. Ions are actively secreted or reabsorbed, and the body alters the permeability of the distal convoluted tubule and collecting ducts to water as necessary, depending on the body's homeostatic needs. These adjustments to the final composition of the urine facilitate the removal of metabolic waste while maintaining the body's fluid electrolyte balance. At the site where the efferent arteriole comes in contact with the distal convoluted tubule, a structure called the juxtaglomerular apparatus is formed. The cells in the efferent arteriole, called juxtaglomerular cells, are pressure sensitive and monitor the blood pressure. The cells in the distal convoluted tubule, called macula densa cells, are sensitive to chemical changes and monitor the concentration of the filtrate in the distal convoluted tubule. When triggered by decreases in the blood pressure of filtrate content, the juxtaglomerular cells release renin. This enzyme initiates a cascade of reactions in the body by converting the inactive plasma protein angiotensinogen into its active form, angiotensin 1. Other enzymes present in the blood then convert angiotensin 1 into angiotensin 2. A potent vasoconstrictor, angiotensin 2 promotes smooth muscle contraction in the arterioles throughout the body. This constriction raises the blood pressure by increasing peripheral resistance. Angiotensin 2 also increases the reabsorption of sodium from the proximal convoluted tubule. Given that water tends to follow sodium, by increasing sodium reabsorption, the kidney increases water reabsorption and, in turn, blood pressure. The final adjustments to the composition of the urine at the distal convoluted tubule and collecting duct are controlled primarily by two hormones, antidiuretic hormone, also known as vasopressin, and aldosterone. Antidiuretic hormone is produced by the hypothalamus and stored in the posterior lobe of the pituitary gland. Aldosterone is produced in the adrenal glands. Neurons in the hypothalamus monitor the solute concentration of the blood. When the solute concentration of the blood increases, that is, due to sweating or decreased fluid intake, antidiuretic hormone is released into the bloodstream. This hormone travels to the distal convoluted tubule and collecting ducts, increasing these structures' permeability to water. Water, therefore, leaves the distal convoluted tubule and collecting ducts and re-enters the bloodstream. As the solute concentration returns to normal, secretion of antidiuretic hormone will stop. Aldosterone increases the rate of active reabsorption of sodium and chloride ions into the blood. A corresponding increase occurs in water reabsorption. This hormone also decreases the reabsorption of potassium ions, resulting in excess potassium being secreted in the urine. Diuretics, chemicals that increase urinary output, work in a variety of ways. A substance that is not reabsorbed from the filtrate, for example, will increase the amount of water retained in the urine, a process called osmotic diuresis. An example of such an osmotic diuretic is glucose in a patient with diabetes mellitus. Alcohol encourages diuresis by inhibiting the production of antidiuretic hormone. Other diuretics, including caffeine and the diuretics commonly prescribed for hypertension and heart failure, Lasix, Diaril, inhibit the sodium importers in the distal convoluted tubule and collecting ducts, causing increased sodium and water excretion. Once the urine enters the collecting ducts, the renal pyramids of the medulla, it passes through the minor calyx, into the major calyx, and then into the renal pelvis. From there, the urine moves through the ureter, one ureter from each kidney, and is stored in the urinary bladder. Most of the bladder is infraperitoneal and sits in the pelvic cavity, but the dome of the bladder is in contact with the peritoneum, making it a retroperitoneal organ like the kidneys and ureters. When empty, the bladder collapses, and the muscular walls fold over onto themselves. In contrast, as urine accumulates, the bladder expands and becomes pear-shaped. The stretching of the bladder walls ultimately stimulates nerve impulses to produce the micturition reflex. This spinal reflex causes contraction of the bladder's smooth muscles, which in turn produces the urge to void as pressure is exerted on the internal urinary sphincter. Normally, the brain exerts control over this urge, keeping the external urinary sphincter contracted until conditions are favorable for urination. At this point, the inhibition of the external urinary sphincter is reduced, and the urine passes from the urinary bladder into the urethra. The urethra, through which urine is expelled, begins at the inferior aspect of the bladder and exits at the site of the external genitalia. The female urethra is shorter than the male urethra, 4 versus 20 centimeters. The male urethra can be divided into 3 regions. The prostatic urethra begins at the bladder and extends through the prostate gland. The membranous urethra extends from the prostate gland through the abdominal wall and into the penis. The spongy, or penile, urethra passes through the penis to the external urethral opening. Pathophysiology. Diseases and conditions of the renal and urologic systems range from mild, urinary tract infections, to true emergencies, acute kidney injury. Although the pre-hospital care for many urologic diseases is supportive, your ability to recognize the signs and symptoms of these conditions is critical to providing your patients with the best chance of a positive outcome. Urinary tract infections. Urinary tract infections usually develop in the lower urinary tract, urethra and bladder, when normal florobacteria, which exist naturally on the perineum, enter the urethra and grow. These infections are more common in women due to the relatively short urethra and its close proximity to the vagina and rectum. Urinary tract infections in the upper urinary tract, ureters and kidneys, occur most often when lower urinary tract infections go untreated. Upper urinary tract infections can lead to pyelonephritis, inflammation of the kidney linings, and abscesses, which eventually affect kidney function. In severe cases, untreated urinary tract infections can lead to sepsis, urosepsis. Kidney stones. Kidney stones, renal calculi, originate in the renal pelvis and result when excessive insoluble salts or uric acid crystallizes in the urine. The cause of kidney stones varies by type. Certain risk factors have been identified, including diet and hydration. General risk factors include a personal or family history of kidney stones, as well as hypertension. The most common types of stones are calcium oxalate and calcium phosphate, accounting for up to 80% of kidney stones. It is thought that they form when the concentration of calcium oxalate or phosphate becomes too high in the urine, although other theories exist. Their formation may have a hereditary component, and risk is increased in people with a history of gout, gastric bypass surgery, and certain metabolic disorders. Less common are stones made from either uric acid or cysteine. While uncommon overall, struvite stones are more common in women, and may be associated with chronic urinary tract infection or frequent catheterization. Acute kidney injury. Acute kidney injury, formerly referred to as acute renal failure, is a sudden, possibly over a period of days, decrease in the rate of filtration through the glomeruli, causing toxins to accumulate in the blood. Approximately 5% to 6% of all patients admitted to an intensive care unit have sustained an acute kidney injury. Sepsis is the most common contributing factor to acute kidney injury. Patients who are admitted to an intensive care unit with acute kidney injury have an overall mortality rate of 50% to 60%. However, the disease is reversible, and survival more likely, if diagnosed and treated. For those who survive, approximately 1 in 8 will require long-term dialysis. If the urine output drops to less than 500 milliliters per day, the condition is called oliguria. If urine production stops completely, the condition is called anuria. Whenever acute kidney injury occurs, the patient may experience generalized edema, acid buildup, and high levels of nitrogenous and metabolic wastes in the blood. If left untreated, acute kidney injury can lead to life-threatening volume overload, hyperkalemia, uremia, and metabolic acidosis. Acute kidney injury is classified into 3 types, based on the area in which the failure occurs: prerenal, intrarenal, and postrenal. The signs and symptoms of each type are summarized in Table 35-1. Prerenal acute kidney injury is caused by hypoperfusion of the kidneys. In other words, not enough blood passes into the glomeruli for them to produce filtrate. The most common causes of prerenal acute kidney injury are hypovolemia, low blood volume caused by hemorrhage or dehydration, trauma, shock, sepsis, and heart failure. Prerenal acute kidney injury is often reversible if the underlying condition can be treated, and perfusion restored to the kidney in a timely manner. Intrarenal acute kidney injury involves damage to one of 3 areas in the kidney: the glomeruli, capillaries, and small blood vessels, the cells of the kidney tubules, or the renal parenchyma, the interstitial cells around the nephrons. Damage to the small vessels and glomeruli hinders blood flow through these vital parts of the nephrons. This damage is often caused by immune-mediated diseases, for example, type 1 diabetes mellitus. Tubule damage can be caused by hypoperfusion, leading to acute tubular necrosis, or by toxins, for example, heavy metals. Rhabdomyolysis is another cause of intrarenal acute kidney injury, in which the released myoglobin damages the tubules. Chronic inflammation of the interstitial cells surrounding the nephrons, interstitial nephritis, can also produce intrarenal acute kidney injury. This type of kidney injury may be caused by medications such as antibiotics, and anti-cancer drugs, alcohol, and drugs of abuse, for example, cocaine. Postrenal acute kidney injury is caused by obstruction of urine flow from the kidneys. The source of this obstruction is often a blockage of the urethra by an enlarged prostate, kidney stones, blood clots, or strictures. This blockage raises pressure in the nephrons, which eventually causes filtration through the nephrons to cease as the pressure becomes higher in Bowman capsules than in the glomerular capillary network. Chronic kidney disease. Chronic kidney disease, formerly referred to as chronic renal failure, is progressive and irreversible loss of kidney function due to permanently damaged nephrons. This disease develops over months or years. More than 1/2 of all cases are caused by systemic diseases, such as diabetes or hypertension. Chronic kidney disease can also be caused by congenital disorders or a prolonged pyelonephritis. As the damaged nephrons cease to function, scarring occurs in the kidneys. The tissue begins to shrink and waste away as the scarring progresses, leading to a loss of nephrons and decreased renal mass. As kidney function diminishes in both acute kidney injury and chronic kidney disease, waste product and fluid buildup in the blood. Uremia, increased urea and other waste product in the blood, and azotemia, increased nitrogenous wastes in the blood, develop, leading to systemic complications such as hypertension, heart failure, anemia, and electrolyte imbalances. Renal dialysis. Renal dialysis, and problems associated with it, may require pre-hospital interventions. Renal dialysis is necessary in severe acute kidney injury or end-stage chronic kidney disease to maintain homeostasis when the kidneys are not able to do their job. Dialysis is a technique for filtering toxic wastes from the blood, removing excess fluid, and restoring the normal balance of electrolytes. There are two common types of dialysis: peritoneal dialysis and hemodialysis. In peritoneal dialysis, large amounts of specially formulated dialysis fluid are infused into, and then drained from, the peritoneal space of the abdominal cavity. This fluid typically remains in the cavity for 4 to 6 hours, allowing equilibrium to occur as waste diffuses across the peritoneal membrane and into the fluid. Peritoneal dialysis is very effective but carries a risk of peritonitis, a life-threatening infection of the peritoneal cavity. Consequently, aseptic technique is essential. With proper training, however, peritoneal dialysis can be performed in the home. In hemodialysis, the patient's blood circulates through a dialysis machine that functions in much the same way, albeit not as elegantly, as the normal kidneys. Most patients undergoing chronic hemodialysis have some sort of shunt, a surgically created connection between a vein and an artery. The patient is connected to the dialysis machine through the shunt, which allows blood to flow from the body into the dialysis machine, and back to the body. A Scribner shunt, for example, consists of two plastic tubes, one fastened in the radial artery, the other in the cephalic vein. These two tubes are joined together near the wrist with a Teflon connector. A Thomas shunt is similar, but this device is usually placed in the groin. Other patients will have a small, button-shaped device, a hemosite, with a rubber septum that can be punctured with dialysis needles during treatment. Hemosites are usually placed in the upper arm or proximal anterior thigh. Finally, some patients have an internal shunt, an arteriovenous fistula, which is an artificial connection between a vein and an artery that is usually located in the forearm or upper arm. Patients are educated to protect their arteriovenous fistula by avoiding having blood pressures taken on that arm. Fistulae are at high risk for thrombosis, and obstructing blood flow for even a few minutes can promote the development of a shunt thrombus. Paramedics must avoid measuring the patient's blood pressure with the blood pressure cuff on the arm with the fistula. Paramedics must also avoid placing peripheral intravenous lines on arms with shunts because intravenous catheterization can introduce infection, damage the existing shunt, and compromise veins that may be required for future shunts. Patients requiring chronic dialysis usually undergo the process every 2 or 3 days for 3 to 5 hours. Many receive dialysis in the hospital or in community dialysis facilities, but a growing number have home dialysis units. Patients undergoing dialysis at home usually have extensive training in the procedures, and someone else in the home must also be trained. If a problem with the machine occurs, the patient or family may know a lot more about it than you do, so always ask the patient or their family for guidance. Patients undergoing chronic dialysis can experience the same spectrum of illnesses and injuries as any other patients. Dialysis patients, however, are particularly vulnerable to certain problems, either because of the dialysis itself or because of the underlying renal failure. Problems associated with dialysis may result from accidental disconnection from the machine, air embolism, bleeding from a fistula or shunt, malfunction of the machine, or rapid shifts in fluids and electrolytes that produce hypotension, potassium imbalances, and disequilibrium syndrome. Hypotension, hemorrhage, and shock. A sudden drop in blood pressure is not uncommon during or immediately after dialysis, but it can lead to cardiac arrest if not promptly detected and treated. The patient may feel lightheaded or become confused, and often he or she yawns more than usual. Because dialysis alters the blood's chemistry, the patient may experience an electrolyte imbalance. For this reason, you should always monitor dialysis patients for cardiac dysrhythmias. Shock secondary to bleeding is also possible from any number of causes, such as hypovolemia resulting from fluid shifts or bleeding due to less functional platelets. Bleeding may also occur at the site of the dialysis cannula, and should be controlled with direct pressure. When you find a shunt leaking during the dialysis cycle, see if you can tighten the connection. If it has become disconnected at the vein, clamp the cannula, and disconnect the patient from the machine. In a suicide attempt, the patient may open up the cannula, and allow himself or herself to exsanguinate. Keep in mind that these patients have often endured numerous medical interventions to simply survive. If you encounter this situation, immediately clamp off the cannula, and apply direct pressure. Potassium imbalance. One consequence of renal impairment is the inability to excrete ingested potassium. As a consequence, chronic kidney disease patients are prone to developing hyperkalemia, especially in circumstances of increased potassium intake or catabolic stress. Such a patient may present with profound muscular weakness. As hyperkalemia develops, the heart's electrical conduction will be impaired. The electrocardiograph monitor will show predictable changes, typically progressing from tall, peaked T waves, seen best in the precordial leads, to flattening and widening of the P wave until it disappears completely, then widening of the QRS until eventually the waves become indiscernible and the electrocardiograph appears as a sine wave. As the hyperkalemia progresses, these dysrhythmias may evolve into an idioventricular rhythm. Complete heart block and asystole may occur. If you see these signs, treatment is urgently required. If within scope, this must be initiated in the pre-hospital environment with early transport. The receiving hospital should be notified prior to arrival so they are prepared to manage the potentially unstable patient. Hypokalemia may also occur as a consequence of overaggressive dialysis. The potassium level is most likely to fall during or immediately after a dialysis cycle. The patient may be hypotensive, and cardiac dysrhythmias may be present, usually bradycardias, though hypokalemia can lead to long QT, predisposing the patient to ventricular tachycardia, and Torsudstupwant. There are no pre-hospital treatments for hypokalemia itself, but treat the dysrhythmia as you normally would if it is hemodynamically significant or persistently symptomatic. Disequilibrium syndrome. Dialysis rapidly lowers the concentration of urea in the blood, whereas the concentration of solutes in the cerebrospinal fluid remains high. Water, of course, moves by osmosis from a solution of lower concentration into a solution of higher concentration. Thus, as a consequence of dialysis, water initially shifts from the bloodstream into the cerebrospinal fluid, thereby increasing intracranial pressure. When this occurs, the patient may experience disequilibrium syndrome, a condition characterized by nausea, vomiting, headache, and confusion. After a few hours, the fluid will re-equilibrate between the blood and cerebrospinal fluid, and the patient's symptoms will improve. In the pre-hospital environment, however, it may be impossible to distinguish between disequilibrium syndrome and other causes of raised intracranial pressure, as dialysis patients are particularly prone to subdural hematomas. In such a case, transport the patient to the hospital immediately for a full neurologic evaluation. Air embolism. If any of the fittings and connections in the dialysis system are loose, air may enter the system and produce an air embolism. Symptoms of air embolism include sudden dyspnea, hypotension, and cyanosis. If you suspect air embolism, clamp and disconnect the patient from the dialysis machine and place him or her in the left lateral recumbent position with approximately 10 degrees of head-down tilt. This position prevents the air from moving beyond the right side of the heart into the lungs. Transport the patient immediately. Tumor of the adrenal gland. Pheochromocytoma is a tumor of the adrenal gland, usually in the medulla, that causes excess release of the hormones epinephrine and norepinephrine. Fewer than 10% of the tumors are malignant, cancerous. The tumors may occur at any age, but they are most common in young to mid-adult life. A common clinical presentation is a combination of symptoms, for example, hypertension, anxiety, chest pain, abdominal pain, fatigue, weight loss, vision problems, and potentially seizures, that may be frequent but sporadic, and may increase in frequency, duration, and severity. Genitourinary trauma. Trauma to the genitourinary system, that is, the kidneys, ureters, bladder, and male and female reproductive organs, may result from either blunt or penetrating trauma. Such injuries are found in 10% to 20% of major trauma patients and 2% to 5% of all trauma patients. 80% of all injuries to the genitourinary system involve the kidneys. You should consider trauma to the genitourinary system whenever a patient has sustained injuries to the lower rib cage, abdomen, pelvis, or upper legs. Kidney. Renal, kidney, trauma is seen in less than 5% of all trauma patients, with about 75% of such cases involving patients younger than age 45 years. Injuries to the kidneys generally require large forces, such as falls from height, high-speed motor vehicle collisions, or sports-related injuries, because the kidneys are well protected by the rib cage, abdominal wall musculature, and paranephric fat. Blunt renal trauma results when the kidney becomes compressed against the lower ribs or lumbar spine, as is seen in sports injuries, also known as a kidney punch, or when the upper abdomen becomes compressed just below the rib cage, such as when a child is run over by a car. Contact sports such as football, soccer, hockey, boxing, and rugby are some of the more common culprits in renal injury. The most frequent presentation of blunt renal trauma is flank pain and hematuria, blood in the urine, which usually goes undetected until evaluation in the emergency department. Suspicion for renal injuries should be high whenever a patient has obvious hematomas or ecchymosis over the upper abdomen, middle back, or lower rib cage. Fractures of the lower rib cage should also raise the suspicion for renal trauma. Penetrating renal trauma can occur with gunshot or stab wounds in the abdomen or lower chest. A high suspicion for significant injury must be maintained regardless of the site of the entry wound. Penetrating renal trauma is likely to be associated with additional injuries to the liver, lung, and spleen. For instance, the upward motion of stabbing may cause a renal laceration as well as a pneumothorax. A gunshot wound may result in direct injury to the kidney, but produce greater surrounding tissue destruction due to the expanding cavity created by the traveling bullet. Pre-hospital care of renal injuries relies on the basics of abdominal trauma. Any obvious external abdominal hemorrhage must be addressed with standard hemorrhage control techniques. If hemorrhage is not readily apparent but the patient has a large abdominal bruise in the region of the kidneys or is hypotensive, the astute paramedic can assume the patient has significant internal hemorrhage. Intravenous fluids are indicated if the patient requires resuscitation, and if this is within local or regional protocols. Ureter. Ureteral injuries are difficult, if not impossible, to identify in the pre-hospital setting. However, they rarely lead to an immediate life-threatening condition. Bladder and urethra. Trauma to the bladder or urethra is often associated with other significant injuries. For instance, 27% of urethral injuries occur in conjunction with other intra-abdominal injuries. Injury to the bladder is often due to blunt forces, and may result in bladder rupture or laceration. Bladder injury should be suspected in any patient with trauma to the lower abdomen or pelvis. In particular, obvious pelvic fractures are frequently associated with bladder injury. A seat belt that causes contusions to the lower abdomen may also cause blunt trauma to the bladder. This type of injury is seen more frequently in drunk drivers, who are more likely to have a full bladder. Bladder rupture is associated with a high mortality rate because the trauma required to pierce the bladder frequently damages other organs or vascular structures. In addition, bladder rupture can cause urine to be spilled into any part of the abdominal cavity, leading to intraperitoneal or extraperitoneal contamination. Bladder injury may be suspected in the pre-hospital setting if a patient reports an inability to urinate, if blood is noted or reported at the penile opening during the focused history and physical examination, or if the patient has tenderness on palpation of the suprapubic region. Pre-hospital care of such injuries follows basic trauma principles: secure the airway, address breathing issues, support the circulatory system, and implement spinal precautions as indicated. Injuries to the male genitalia. Testicle and scrotal sac. The testicles have two layers of covering, the tunica albuginea and the tunica vaginalis, and are held outside the body in the scrotal sac. The testicles can be retracted into a more protected position by the cremaster muscles. Due to their mobility and natural position, severe injuries to the testicles are rare. Although loss of fertility is the major concern when a patient sustains a testicular injury, the exact outcome depends on whether the testicle can be preserved via definitive treatment in the hospital setting. Blunt trauma to the testicles or scrotal sac can result from motor vehicle collisions, physical assaults, or sports injuries. Blunt testicular trauma can result in simple contusions, rupture of the testicle, loss of integrity of the tunica albuginea, and, in rare cases, torsion, twisting, of the testicle. More than 1/2 of all testicular ruptures occur in sports participants. Testicular injuries frequently present following trauma to the thighs, buttocks, penis, lower abdomen, and pelvis. Contusions result in painful hematomas that may respond to application of ice packs. Rupture of the testicle is difficult to identify in the pre-hospital setting, although tender scrotal swelling should raise suspicion. Similarly, you will not know if a particular blunt trauma has resulted in a testicular torsion, which can be a fertility-threatening condition. Although serious injury to the testicles is rare, it does not require much force to cause intrascrotal bleeding. If enough bleeding or concomitant swelling occurs, pressure necrosis, tissue death, may result. For this reason, you should not ignore testicular symptoms even in the face of other trauma, and should communicate this concern to the receiving hospital staff. Penetrating trauma to the testicles or scrotal sac may result from stab wounds, gunshot wounds, blast wounds, or animal bites. A high suspicion for other associated injuries is well advised in cases of obvious penetrating trauma. Scrotal lacerations or avulsions should be treated with proper attention to any hemorrhage or eviscerated testicle. Gentle compression, analgesic medication, and the application of ice packs may help decrease bleeding, swelling, and pain. Penis. The penis is vital for both proper urination and reproductive and sexual function. Injuries to the penis may result from blunt or penetrating trauma, but also may arise from sexual behavior or self-mutilation. Physiologically, a penis becomes erect when blood fills the corpora cavernosa. Priapism, a sustained, painful penile erection, can be caused by conditions such as spinal injury or, more commonly, the use of erectile dysfunction drugs, for example, Viagra, Levitra, Cialis. A fractured penis, rupture of one or both tunica of albuginea, which enclose the corpora cavernosa, may occur when an erect penis is accidentally impacted against the partner's pubic symphysis or bent too far via self-manipulation. Pain and a large hematoma are the presenting signs and symptoms. In the pediatric population, penile contusions have been reported to occur when a toilet seat falls unexpectedly and compresses the child's penis. Ice packs can help decrease swelling. Note that penile trauma in a child may be a sign of abuse, and transport for further investigation and evaluation for other injuries is indicated. Penetrating trauma to the penis most often results from gunshot wounds. Attention should be paid to controlling hemorrhage and assessment for other injuries resulting from the trauma. Reports in the medical literature describe self-mutilation or amputation of the penis. Typically, this type of injury occurs in patients with significant psychiatric disorders. Attempts should be made to recover the amputated penis and transport it, as you would any other amputated part, because surgical repair is often possible. In addition, a number of reports have described people who have placed objects around the penis, testicles, or both. Inability to remove the object can result in incarceration of the organ, with tissue death being the most feared consequence. No attempt to remove the object should be made in the pre-hospital environment. Instead, the patient should be urgently transported to the hospital for proper evaluation and treatment, which may necessitate the use of cutting devices or aspiration of the distal edema. Injuries to the female genitalia. In women, the uterus lies behind the bladder, and is well protected within the pelvis. On either side of the uterus are the ovaries. In non-menopausal women, these release an egg every month that travels to the uterus through the fallopian tubes. In non-pregnant women, the uterus then sheds its lining each month, as evidenced by bleeding through the vaginal canal. Vaginal trauma may be the result of accidental blunt or penetrating trauma, assault, or self-inflicted injuries. Blunt trauma may result from motor vehicle collisions in which high-energy impacts cause significant abdominal and pelvic trauma, or from saddle-type injuries, for example, landing on a bicycle seat. Lacerations to the vaginal wall can occur, as well as uterine rupture or ovarian contusion. Trauma to the external genitalia may produce contusions to the vulva or labia. Signs of trauma may include hematomas and ecchymosis in the lower pelvic area, and on the external female genitalia, bleeding from the vagina, and tenderness on palpation of the lower pelvis. Penetrating trauma to the reproductive organs may result from stabbings to the lower pelvis or gunshot wounds. Because the path of a bullet cannot be predicted from the entry wound alone, and the injuries to the abdomen or upper legs should be assumed to have also damaged the reproductive organs. Use packing and compression to stem any external hemorrhage, and administer replacement fluids to treat the hypotensive patient. Self-inflicted trauma has been reported in young girls and in psychiatric patients who insert foreign bodies into their genitalia. Occasionally, women of reproductive age can cause vaginal lacerations by using foreign bodies for sexual purposes, or with the use of devices or tools to remove tampons, pads, and other products that they could not digitally remove from the vaginal canal. Do not attempt to remove any object believed to be in the vagina. Transport the patient immediately for definitive treatment at the hospital. Assessment. Assessment of a patient with renal and urologic emergencies is the same as with any other medical patient. Begin with the scene assessment, perform an initial assessment, obtain a focused history and physical examination, form an initial impression, and make a treatment decision, and perform ongoing assessments en route to the hospital. Patients who are experiencing renal problems may exhibit many of the same symptoms as a patient with other abdominal problems: nausea and vomiting, constipation or diarrhea, weight loss, loss of appetite, chest pain, and abdominal pain. Because pain is a common symptom in both abdominal and urologic ailments, it is often difficult to determine the source of the pain. Urologic pain can have many origins, for example, bacterial infection, inflammation of the ureter by a kidney stone, or distension of the bladder because of prostate enlargement. Your assessment should be intended to detect and prevent life threats and provide supportive pre-hospital care for the patient. Be sure to keep a wide differential diagnosis as you progress through your evaluation. When receptors at the affected organs are stimulated, they send impulses along the nerves to the brain, where the impulses are evaluated and interpreted as pain. Visceral pain, the type of pain most commonly associated with urologic problems, usually occurs when receptors in the hollow structures, such as the ureters, urinary bladder, and urethra, become stimulated. Pinpointing the source of such pain is challenging because only a few nerve fibers may be involved in the pain transmission. Because many different nerve fibers travel to the brain through the spinal cord, pain that originates in one area of the body, for example, the urinary bladder, may be perceived by the brain as coming from a different area of the body, for example, the low back. This referred pain can be used as a diagnostic tool in some urologic and kidney diseases. Scene assessment. In the scene assessment, you should not only ensure that the scene is safe for you and your fellow paramedics, but also take routine precautions, consider the mechanism of injury, assess for hazards, and the need for additional help, and determine the number of patients. Is the patient in obvious pain? Does he or she appear pale or jaundiced? What is the patient's level of consciousness? This general impression will be continually re-evaluated, but it is important to establish your baseline impression early in the assessment process. Initial assessment. In the initial assessment, you form your general impression of the patient and check for life-threatening conditions with the assessment of the patient's mental status and airway, breathing, and circulation. A patient with urologic or renal problems may exhibit extremes of activity. Is the patient constantly changing positions in an attempt to find a comfortable position, the kidney stone dance? Or is the patient sitting very still with the knees drawn to the chest, suggestive of peritonitic pain? Now check for life threats. Do you see signs of respiratory distress or failure? Are there signs of profuse bleeding or circulatory compromise? Is the abdomen distended or rigid? If you discover any life-threatening conditions, take immediate steps to correct them and initiate rapid transport. Focused history and physical examination or detailed physical examination. In urologic patients, the patient history and physical examination will provide the information needed to successfully manage the patient. Because 80% of all medical diagnoses are based on the patient's history, it is imperative that you ask the right questions during this examination. Determining that the pain actually started in the flank, and not in its present location of the lower right quadrant, could mean the difference between a correct initial diagnosis of a kidney stone and an incorrect initial diagnosis of appendicitis. Similarly, determining that the patient has a history of diabetes and hypertension along with signs of uremia can help confirm your impression of chronic kidney disease. The sample mnemonic can guide you in obtaining pertinent historical information from the patient. For example, a patient who reports flank pain and is agitated S, who has had 2 previous kidney stone attacks. P, who had bacon, eggs, and coffee for breakfast 7 hours ago. L, and who has been working in the sun all day. E, has presented a history that would lead you to suspect kidney stones. Before proceeding with treatment, you would obviously want to assess allergies, A, and any medications, M, the patient has taken. The OPQRST mnemonic is used to evaluate the type and severity of pain. Onset involves questions about when the pain started, and what the patient was doing at the time. The patient may describe visceral pain, such as from a kidney stone, as a crampy or aching sensation deep within the body. Next, determine what, if anything, provokes or palliates the pain, for example, the kidney stone dance or statue stillness. To help rule out other abdominal causes of pain, take note of any relationship between food consumption and the pain. After determining the onset and provocation, assess the quality of the pain. The pain from a kidney stone usually begins as a vague discomfort that becomes extremely sharp pain within an hour. The R stands for region, location, radiation, or referral. For example, the pain from a kidney stone moves from the flank anteriorly toward the groin. The fact that the pain has moved also suggests that a kidney stone is passing through the system. To evaluate the severity of the pain, ask the patient, on a scale of 0 to 10, with 10 being the worst pain you have ever experienced, how would you rate the pain? Although this number is helpful, by itself it tells you very little. The severity of the pain may not be consistent with the severity of the condition. It is important to repeat the severity assessment to look for trends or to verify efficacy of the treatment. The final pain evaluation is to inquire about the timing of the pain. Did the pain come on suddenly, or more gradually? Has it been constant, or does it come and go? In the case of a kidney stone, you would expect fairly constant pain that varies in severity, and moves as the stone travels through the system. The physical examination includes monitoring and vital signs. ECG monitoring is extremely important in any patient with a suspected urologic emergency due to the possible electrolyte imbalances and their effect on the heart. The examination may be focused, or you may move from head to toe, depending on the presentation of signs and symptoms. The abdominal region is divided into either 4 quadrants overlying the internal organs or 9 anatomic segments. A more detailed physical examination may be performed en route if one is not done at the scene. Be sure to assess for flank tenderness, which could imply kidney infection or distension. If a male patient reports lower abdominal pain without other clear cause, visually inspect the genitalia for signs of infection, swelling, or torsion. Monitoring the patient's vital signs is part of the physical exam. You should obtain serial vital signs at least every 5 minutes if renal failure is suspected. Take prompt action if you note any deterioration in the patient's vital signs or level of consciousness. Initial impression and treatment plan. Once you have completed the focused history and physical examination, you must use the information obtained to form an initial impression and create a treatment plan. This could be as simple as monitoring the airway, breathing, and circulation and providing circulatory support for a patient with a urinary tract infection, or as complex as administering medications in patients with hyperkalemia secondary to renal failure, as suggested by changes in the ECG, with medical consultation and direction. The treatment plan includes the transport decision, which may be made at any time during the assessment process. If the disease process requires immediate medical procedures, for example, removal of an urinary catheter, adjustment of a fistula or shunt, that may go beyond the scope of the pre-hospital setting, perform the treatment plan, and transport, reassessing the patient en route to the hospital. Ongoing assessment. Patients with urologic emergencies, especially those with signs and symptoms of renal failure, need ongoing assessment. The electrolyte imbalances caused by the buildup of toxins can cause rapid deterioration in the functioning of the body's organs. The heart is particularly susceptible to electrolyte changes, so cardiac monitoring should be established for every renal patient. Serial vital signs should be obtained and documented on the pre-hospital care report. Note any trends in the vital signs and level of consciousness because they can be indicators of disease progression. Patients with possible urologic disease should not be given anything by mouth because this may induce vomiting or complicate surgical procedures. Document all vital signs, and report any apparent trends to the receiving facility during your transfer of care. Management. The treatment of patients with a urinary tract infection or renal calculi centers on comfort and support. Once you have checked and established adequate airway, breathing, and circulation, allow the patient to assume a position of comfort. Patients in severe pain may have nausea and vomiting, so be prepared to respond as necessary, for example, antiemetic medications, positioning, suction, to prevent aspiration. Establish an intravenous line, and administer fluids as indicated, in keeping with your local or regional protocols. Acute kidney injury and chronic kidney disease can lead to life-threatening emergencies. Support of the airway, breathing, and circulation is imperative. Because of the possible toxic buildup and electrolyte problems, medications to regulate acidosis and electrolyte imbalance as well as fluids for volume regulation may be required. With either of these treatments, you must monitor the patient's reaction because drastic shifts in electrolytes, although rare, may occur. Emergent transport and supportive pre-hospital care are often preferred over aggressive management in these patients. The management of medical emergencies resulting from dialysis is summarized in Table 35-2. Assessment and management of specific emergencies. This section considers how the specifics of the more common renal and urologic emergencies lead to the appropriate management plan. Urinary tract infections. Common symptoms in patients with a urinary tract infection affecting the lower urinary tract include painful urination, dysuria, urinary frequency, a sense of urgency with urination, and difficulty in urination. Hematuria or a foul odor with a cloudy appearance may also be reported. The pain usually begins as a visceral discomfort, but then converts to an extreme burning pain, especially during urination. The visceral pain is often perceived as bladder pain in women, and as prostate pain in men. Palpation of the abdomen will usually reveal tenderness over the pubis or pain in the flank, depending on the area of the infection. The patient may appear restless and uncomfortable. The skin and vital signs will vary broadly depending on the location and severity of infection. Although this is the classic presentation of urinary tract infections, it is not uncommon for older patients to present with vague symptoms of weakness and confusion. When the upper urinary tract is affected by an infection, the patient will also present with flank pain and evidence of systemic illness, such as fever, chills, and hemodynamic instability. Caution should be exercised in the elderly with a urinary tract infection. They may present with vague symptoms, often including confusion, without any symptoms specific to the urinary tract. The wise paramedic should suspect a urinary tract infection in any elderly patient who has an altered mental status. Treatment of patients with urinary tract infections consists mainly of supportive care of the airway, breathing, and circulation. Allow the patient to ride in a position of comfort, but be prepared for nausea and vomiting. Analgesics are not typically required. Non-pharmacologic pain management with breathing and relaxation techniques is usually sufficient. Establish an intravenous line, and administer a fluid bolus if sepsis is suspected, in addition to supporting perfusion. This will promote blood flow through the kidney, and dilute the urine. Transport the patient to the nearest appropriate facility for evaluation. Kidney stones. Patients who have kidney stones will almost always be in pain. Many rate kidney stone pain as 11 on a scale of 1 to 10. As stated earlier, the pain usually starts as a vague discomfort in the flank, but becomes very intense within 30 to 60 minutes. It may migrate forward and toward the groin as the stone passes through the system. Some patients will be agitated and restless as they walk and move in an attempt to relieve the pain. Others will attempt to remain motionless and guard the abdomen. Either behavior makes palpation of the abdomen difficult. Vital signs will vary, but patients will commonly be tachycardic, hypertensive, and tachypneic in response to the severe pain. If a stone has become lodged in the lower ureter, signs and symptoms of an urinary tract infection may be present. If a kidney stone is suspected, be sure to obtain both a patient history and a relevant family history. Both can supply important information. The pre-hospital management of kidney stones centers on pain relief. After ensuring the airway, breathing, and circulation, allow the patient to assume a position of comfort. Analgesic medications should be given for renal colic if no contraindications exist. The once common belief that treating abdominal pain will impede subsequent assessment and diagnosis has been shown to be a fallacy, and only deprives the patient in distress from appropriate therapy. Pain management may also be accomplished by using breathing techniques like those used for women during labor. Many patients with renal colic will also be nauseated and vomiting. Administer antiemetic medications as indicated. For the patient with renal calculi, although it was previously thought that fluid boluses would improve stone passage rates, this has been disproven and it may in fact increase pain. As such, provide intravenous fluids in the suspected renal colic patient only as needed for medication delivery or hypotension. Transport the patient to an appropriate facility with urologic expertise, providing supportive pre-hospital care as necessary. Acute kidney injury. The toxic buildup of nitrogenous wastes and salts in the blood associated with acute kidney injury causes impaired mentation, fluid retention, tachycardia, acid-base imbalances, and ECG changes associated with hyperkalemia. The patient's skin will be pale, cool, and moist, and edema will appear on the extremities and face. When inspecting the abdomen, look for any scars, ecchymosis, or distension. If the abdomen is distended, note whether the swelling is symmetric. Palpate the abdomen for any pulsing masses, which could indicate an aortic aneurysm. Because the metabolic changes caused by acute kidney injury can be life-threatening, it is imperative that the treatment plan supports and manages the airway, breathing, and circulation as needed. Consider supplemental oxygen for the hypoxic patient and, if necessary, provide ventilatory support with bag mask ventilation. Place the hypotensive patient in a supine position to increase blood flow to the brain and vital organs, if pulmonary edema is not present. Consider an intravenous bolus if the patient exhibits signs of shock, but use caution to prevent pulmonary edema. Patients with concern for rhabdomyolysis may benefit from intravenous fluid boluses. If signs of hyperkalemia are present on the ECG, discuss with medical control, and consider treating with intravenous calcium and bicarbonate. The buildup of metabolic product in cases of acute kidney injury may be toxic to the kidneys. Many medications can be nephrotoxic, including many analgesics and antibiotics. Consult with direct medical control if you suspect acute kidney injury and are transporting a patient with antibiotic or analgesic drips. Many patients with acute kidney injury have other comorbid diseases that also may need to be addressed. Chronic kidney disease. Patients with chronic kidney disease may have an altered level of consciousness caused by electrolyte imbalances and their effect on transmission of nerve impulses in the brain. Patients may also present with lethargy, nausea, headaches, cramps, signs of anemia, weakness, vomiting, anorexia, increased thirst, pruritus, and hypertension. Ask if the patient still produces urine, and ask the patient to describe the appearance of any urine. Urine volume may have decreased or the urine may appear rusty brown. The skin will be pale, cool, and moist, and may demonstrate uremic frost around the face. Bruising of the skin and muscle twitching may also be present. Edema in the extremities and face will often be apparent, and patients may be hypotensive and tachycardic. Hyperkalemic ECG changes may be identified. Pericarditis and pulmonary edema are also common and should be evaluated during auscultation of the chest. Management of a chronic kidney disease patient is initially similar to managing an acute kidney injury patient. Support the airway, breathing, and circulation. Provide the hypoxic patient with supplemental oxygen and, if necessary, ventilatory support with bag mask ventilation. If not otherwise contraindicated, place the hypotensive patient in a supine position to increase blood flow to the brain and vital organs. If there are no signs of pulmonary edema, consider an intravenous bolus if the patient shows signs of shock. Because chronic kidney disease patients are prone to third space shock, due to fluid shifts and major electrolyte changes, treatment strategies should center on the regulation of fluid imbalances and cardiovascular function. For example, if hypotension occurs, a vasopressor may be administered, or direct medical control may order the administration of sodium bicarbonate to correct acidosis. Ultimately, patients with chronic kidney disease will require renal dialysis. After life threats are addressed, transport the patient to the appropriate facility for treatment. Because patients in chronic kidney disease are already experiencing electrolyte imbalances in their blood, be as conservative as possible with your treatment plans for these patients. Transport should be undertaken in a calm manner. Talk quietly and confidently with the patient. If the patient has an altered mental status, be sure to assess his or her orientation frequently and record any changes.
Chapter 36. Toxicology. Substance abuse and poisoning. Introduction. Paramedics provide pre-hospital care to patients who are on prescription medications, who take over-the-counter substances, who take supplements, or who take preparations for pleasurable purposes, whether these are licit, as in alcohol, or illicit, as in cocaine. Other exposures can occur in the workplace and the home through ingestion, inhalation, or by surface contact. All of these scenarios can lead to morbidity, whether through interactions with underlying diseases or with other substances, because of the inherent toxicity of the involved substance, or because of excessive dosing, whether intentional or inadvertent. Although illicit drugs such as heroin and methamphetamine are still common on the streets, waves of highly potent and chemically engineered drugs are finding their way into local communities as well. In addition, with the legalization of marijuana in Canada, paramedics are seeing more calls related to its use and abuse. The objective of this chapter is to give the paramedic an informed approach to the patient with toxic exposure. Types of toxicologic emergencies. Toxicologic emergencies usually fall under one of two general headings, intentional and unintentional. Poisoning in adults is commonly intentional. In particular, suicide is often accomplished with the use of drugs. In Canada in 2017, there were 4,392 deaths due to poisonings, of which 4,108 were due to drug overdose. This is a doubling of drug-related death in just a few years, rising from 5.8 deaths per 100,000 in 2011 to 11.9 deaths per 100,000 in 2019. This increase is related to opioids, most commonly fentanyl and fentanyl analogs. An unintentional toxicologic emergency can occur in many ways. For example, medication dosing errors are common problems in clinical practice. In some cases, the event may be idiosyncratic. A 2 mg intravenous dose of midazolam may simply relax one patient but cause respiratory arrest in another. Childhood poisonings are quite common, especially in younger children who may put anything into their mouths, such as colorful berries on a house or garden plant that draw a child's attention. A parent's prescription medication may be mistaken for candy. Indeed, many pediatric medications are formulated as candy look-alikes to improve compliance. The 10 most common types of exposures in children younger than 5 years as managed by Ontario's Poison Centre are, in descending order, pain relievers, cleaning substances, cosmetics and personal care products, vitamins, foreign bodies, skin creams, plants, cough and cold medicines, pesticides, and antihistamines. Even nature is fraught with toxicologic perils, as any hiker who has inadvertently wandered through a patch of poison ivy would attest. Wild mushrooms, once in the body, can produce a wide spectrum of results, from being a tasty treat, to being nauseating, to being deadly. Most therapeutic medications were originally derived from natural sources. Chemical substitution gives these substances more specific effects. For example, digoxin is derived from the foxglove plant. The workplace also harbors its share of toxic hazards. Carbon monoxide, hydrogen sulfide, acids, and alkalis are some of the exposures to be expected in the occupational setting, all of which the paramedic must protect himself or herself against. Unfortunately, some of these hazards are not identified until after the exposure has occurred. For example, thousands of people developed asbestosis after continued exposure to asbestos in the workplace. Unintentional toxicologic emergencies can also occur from simple neglect or oversight. Consider a geriatric person with diabetes, possibly combined with early onset dementia or Alzheimer's disease, who takes his or her insulin in the morning, and later cannot remember whether the dose was taken and takes another dose. The result, a call to 911 for an unconscious, unresponsive person in need of assistance. Biologic warfare has drawn increasing attention in recent years owing to the heightened awareness of bioterrorism, but intentional poisoning or overdose may also commonly occur during more intimate crimes. In recent years, date rape drugs such as flunitrazepam, Rohypnol, have been used to facilitate sexual assault. Chloral hydrate, knockout drops, has been used to commit assault for decades, and pharmacologic agents are used in homicide as well. Poison centers in Canada. Given the variety of illicit drugs coupled with the continued growth of licit drugs, even the most well-read veteran paramedic may find it difficult to keep current with the myriad drugs sold in the streets today. For this reason, poison centers may be an indispensable aid. Suppose you are called to a home where a frantic mother is hovering over a toddler who sits beside the remains of a potted philodendron, most of which he apparently just ate. Is the plant poisonous? How poisonous? Should you make the child vomit? Is an antidote available? In such a scenario, you can call the poison center to get information on the ingestion, its toxic potential, and steps to negate its effects, thereby providing proper pre-hospital care. In fact, philodendrons are not poisonous per se, but contain tiny spicules of insoluble calcium oxalate crystals. Biting a leaf will cause immediate oral burning but no systemic toxicity. It is highly unlikely that a child will take more than one bite. Poison centers are a virtual gold mine of information that you should add to your toolbox. Never hesitate to tap these resources when confronted with any toxin for which you have limited or no familiarity. Also, your call helps the center collect data on poisonings in your region. These data may be analyzed to help detect trends, spot developing public health problems, and evaluate current treatment protocols for different poisonings. However, note that there is no universal number to contact poison centers in Canada. In fact, some provinces and territories do not even have such a center. In some provinces and territories, calls from the public are hosted by 911, and others by a regional hospital. In New Brunswick, calls are hosted by telehealth, and in Manitoba, the number is only accessible to callers local to Winnipeg. In these provinces, the advice is not offered to members of the healthcare profession. The following is a list of numbers to provincial centers, accessible within the designated province only. Alberta Poison and Drug Information Services. 1-800-332-1414. British Columbia Drug and Poison Center. 1-800-567-8911. Centre Anti-Poison du Québec. 1-800-463-5060. Manitoba Poison Center. 1-855-776-4766. Newfoundland Poison Information Center. 1-866-727-1110. Nova Scotia and Prince Edward Island Regional Poison Center. 1-800-565-8161. Ontario Poison Center. 1-800-268-9017. Saskatchewan Poison and Drug Information Services. 1-866-454-1212. Where a provincial poison center is available, specially trained registered nurses and/or pharmacists answer the phone lines 24 hours per day, 7 days per week. In Canada, the respective colleges of nurses and pharmacists have standards for the practice of telephone medicine. A registered nurse or pharmacist may give telephone information to a registered health professional only. In the case of a paramedic, the nurse or pharmacist may provide advice on which you may act directly, but he or she cannot give you information to relay to the hospital. For example, you may be told that the substance can cause loss of consciousness and seizures so that you may be prepared. The poison specialist will not tell you that the substance is also one that may be able to be dialyzed, because you will not be able to carry out that intervention yourself. Routes of absorption. To exert its effects, a substance must first enter the human body. The four primary methods of entry are ingestion, inhalation, injection, and dermal absorption. Just as each of these methods of entry is unique, so is the rate at which a given toxin is absorbed into the body. Once a toxin is in the body, the combination of the amount of toxin and the relative speed at which it is metabolized affect the bioavailability of the toxin and the excretion rate. Poisoning by ingestion. Ingested poisons may produce immediate damage to tissues, or their toxic effects may be delayed for several hours. Ingestions of a caustic substance, that is, a strong acid or alkali, can cause immediate damage. By contrast, some poisons must be absorbed into the bloodstream before they can produce their toxic effects. Medications around the home and household chemicals, such as cleaning agents, are the most common sources of poisoning by ingestion. Poisoning by ingestion is marked by a wide range of possibilities regarding what is ingested and why it was ingested. Consider the curious child who eats a few bright red berries from the holly plant, and the patient with pain who inadvertently increases the amount of analgesia taken from every 4 hours to every 2 hours to get relief. Both scenarios are considered accidental. Minor gastrointestinal discomfort may result from the former, whereas if the analgesia was acetaminophen, fulminant hepatic failure could result. Intentional poisonings occur as well. The suicidal patient may take a full prescription of a benzodiazepine with little consequence. The teenager who eats a liquid laundry detergent capsule after seeing others doing it online may end up with caustic burns to the pharynx and esophagus, or aspiration due to altered mental status and vomiting. A teen may attempt to get high one night, take a single tablet of ecstasy, and die. Assessment clues pointing toward ingestion can be as obvious as a plant with partially chewed leaves or a section of plant with berries missing. Stained fingers, lips, or tongue are also worth noting. Any patient reporting a sudden onset of stomach cramps with or without nausea, vomiting, or diarrhea may have an ingestion-related problem. Empty pill bottles are another obvious clue, as is the date on which the prescription was filled. The bottle for a prescription filled 6 months ago likely was not full today. An empty bottle for a prescription filled yesterday is far more ominous. A thorough search for substances, including medications, should be made, and all should be brought with the patient to the emergency department if patient stability allows. A toxin that enters the body by the oral route generally provides a more forgiving time frame for treatment. Little absorption occurs in the stomach. Indeed, the ingested substance may stay there for a variable period, with most absorption actually taking place in the small intestine. Consequently, much of the management of poisoning by ingestion aims to remove or neutralize the poison before it gains access to the intestines. Poisoning by inhalation. A person can be poisoned by inhalation only if the poison is present in the surrounding atmosphere. That fact, obvious as it seems, has important implications. First, as long as the patient remains in the toxic environment, he or she will keep inhaling the poison, and so will you, if you enter that environment without the appropriate protective breathing apparatus. Do not make the mistake of rushing to the patient's aid only to become a patient yourself. Your assessment of scene safety must include an assessment for possible toxins. In the summer of 2017, an ammonia leak in an enclosed room at an arena in British Columbia killed 3 people. First responders recognized the potential for a toxic gas, and did not enter the building due to their suspicion of a potentially toxic gas. Their decision prevented further loss of life. Second, when poisoning occurs because of a toxic environment, you are likely to encounter more than one patient at the emergency scene. Household chemical products, such as bleach and cleaning agents, are responsible for the most common types of inhalation emergencies. Poisoning by inhalation may be accidental or intentional. Consider carbon monoxide poisoning. Leaving the garage door shut while seated in an automobile with the engine running provides a quick, painless method of suicide. Similarly, an automatic damper on a furnace that fails to open or a bird nest that blocks a chimney may fill a house with colorless, odorless carbon monoxide, quietly and efficiently poisoning those inside. From the anatomic and physiologic perspective, inhaled toxins quickly reach the alveoli, providing almost instant access to the circulation. Carbon monoxide, for example, binds to hemoglobin in the red blood cells approximately 250 times more avidly than do oxygen molecules. As a result, rapid systemic distribution can occur with an equally rapid onset of signs and symptoms. For this reason, the window of opportunity for treatment is limited. When dealing with an inhalation emergency, the first general management consideration is that of scene safety. After donning the appropriate breathing apparatus, remove the patient or patients to a safe environment before beginning any treatment. Inhaled toxins produce a wide range of signs and symptoms, many of which are unique to the toxin involved. A patient with carbon monoxide poisoning does not exhibit the same signs and symptoms as a person who has sniffed glue, who in turn looks nothing like a patient poisoned by a furniture stripper containing methylene chloride. Frequently, the emergency scene itself contains the clues to the identification of the toxin that is making the patient ill. That information, coupled with the assistance of the poison center and direction from the physician providing direct medical control, will drive your treatment plan. Correction of hypoxia is a must, so administer a high concentration of supplemental oxygen. Establish vascular access, monitor the patient's cardiac rhythm, and perform pulse oximetry and capnography. Poisoning by injection. Injected poisons usually gain access to the body as the result of stings or bites from a variety of unpleasant creatures. Abuse of intravenous administered drugs such as heroin, cocaine, amphetamines, and speedballs, heroin and cocaine together, is an increasingly common reason for calls to a paramedic service. Although the patient or bystanders may not be forthcoming with information about the substances involved, you can focus your attention on the physical assessment, signs, and symptoms to help with possible identification. The patient's presentation and the setting in which you attend to the patient will likely help guide you in identifying the type of drug involved. In Canada, the risk of poisoning by injection from natural products is limited. 3 venomous species of snakes exist. In British Columbia, one might encounter the northern Pacific rattlesnake, in Alberta, the prairie rattlesnake, and in selected areas of Ontario, the Massasauga rattlesnake. While these venomous creatures are not common encountered in Canada, a variety of snakes, spiders, and scorpions not native to Canada are often kept as exotic pets. Some of these exotic pets produce poisons that can produce localized or systemic reactions, whereas others may be neurotoxic. Wasps, yellow jackets, hornets, and bees have a ubiquitous distribution throughout Canada. Stings from these insects can occur anywhere. In Canada, the manifestations of a bite from most of these injected natural venoms can be local, allergic, or occult systemic. When a bite or sting hits a blood vessel, it results in a toxin immediately entering the bloodstream. The outcome is much more dangerous than when the same toxin enters a muscle mass, from which the toxin has a much slower rate of absorption and distribution. When assessing bites and stings, physical findings will usually provide the most clues, especially local reactions such as pain at the wound site. Depending on the specific toxin, signs and symptoms can vary greatly. Frequently, the patient may be able to identify the source, greatly simplifying the assessment process. Poisoning by dermal absorption. Some poisons gain access to the body by being absorbed through the skin. Of the poisonings that occur by dermal absorption, those caused by pesticides such as organophosphates and similar substances are often the most serious. Because of the highly toxic nature of organophosphates, scene safety remains paramount. These patients may need to be decontaminated. Follow your service's decontamination protocols, which may include using a hazmat team. Organophosphates are discussed in detail later in this chapter. Understanding and using toxidromes. Although the sheer number of substances of abuse may seem daunting, the good news is that many drugs, on entering the body, result in similar signs and symptoms. Consider narcotics. Regardless of whether it is a natural product derived from opium, that is, an opiate, or a synthetic, non-opium derived narcotic, that is, and opioid. All drugs in this group work in a similar manner, so they produce similar signs and symptoms. The syndrome-like symptoms of a poisonous agent are termed a toxic syndrome or toxidrome. Toxidromes are useful for remembering the assessment and management of different substances that fall under the same clinical umbrella. The major toxidromes are produced by narcotics, cholinergics, anticholinergics, sympathomimetics, stimulants, and sedative hypnotics. Table 36-2 lists common signs and symptoms of poisoning. If you look at your history and physical examination findings in conjunction with the vital signs, more often than not you can develop an initial diagnosis that will allow you to provide appropriate pre-hospital care until you can deliver the patient to the receiving facility. Overview of substance abuse. Human beings have a long history of abusing drugs and alcohol. With the passing of time, the physiologic and societal effects of alcohol abuse have become well known and thoroughly documented. Unfortunately, the area of medicine dealing with drugs of abuse is challenging because of uncertainty about the prevalence of the problem and the continual evolution of the substances themselves. In the 1980s, creative chemists took existing pharmacologic agents and structurally manipulated them to create new or different drugs, designer drugs, that were often far more potent than the original drugs. The same is now taking place as illicit labs are creating fentanyl analogs that are hundreds or thousands of times more potent than fentanyl itself. Substance abuse can be broadly defined as the self-administration of licit or illicit substances in a manner not in accord with approved medical or social practice. Part of that definition is cultural, and there is great variation in what is considered substance abuse. In our society, for example, it is acceptable to administer narcotics under medical supervision for the relief of pain. Conversely, self-administration of the same drugs for the purpose of inducing euphoria is regarded as drug abuse. Indeed, the legalization of marijuana in 2018 demonstrates the evolution of society's view on a substance prohibited in Canada since 1923. Any given society's definition of abuse may have little relation to the potential harm from the abused substance. For example, our culture places no restrictions on the long-term and compulsive use of tobacco, even though it is a major contributor to cardiovascular and respiratory disease. Let us formally define some basic terms and concepts related to substance abuse. Drug abuse. Any use of drugs that causes physical, psychological, economic, legal, or social harm to the user or to others affected by the drug user's behavior. Habituation. Psychological and/or physical dependence on a drug or drugs. Physical dependence. A physiologic state of adaptation to a drug, usually characterized by tolerance to the drug's effects, and by a withdrawal syndrome if the drug use is stopped, especially if it is stopped abruptly. Psychological dependence. The emotional state of craving a drug to maintain a feeling of well-being. Tolerance. Physiologic adaptation to the effects of a drug such that increasingly larger doses of the drug are required to achieve the same effect. Withdrawal syndrome. A predictable set of signs and symptoms, usually involving altered central nervous system activity, that occurs after the abrupt cessation of a drug or after rapidly decreasing the usual dosage of a drug. Drug addiction. A chronic disorder characterized by the compulsive use of a substance resulting in physical, psychological, or social harm to the user, who continues to use the substance despite the harm. Antagonist. An agent that blocks the ability of a given chemical, molecule, or protein to bind to its receptor, inhibiting its ability to produce its biologic response. Potentiation. Enhancement of the effect of one drug by another drug. Synergism. The action of two substances, such as drugs, in which the total effects are greater than the sum of the independent effects of the two substances, that is, 2 + 2 = 5. Drug abuse is not limited to members of the younger generation or to any particular stratum of society. It occurs in all age groups, and at all social levels. General principles of assessment and management for toxicologic emergencies. Generally, patients with toxicologic emergencies are considered medical patients, although toxicologic emergencies may also lead to trauma. The general assessment approach is the same for all patients: scene assessment, initial assessment, and then focused history and physical examination. If the mental status is altered, monitor the patient's airway and breathing diligently to ensure that he or she does not aspirate and is adequately filling the chest with air. If the patient is responsive, use the OPQRST mnemonic to elaborate on the chief complaint, take the patient's vital signs, take a sample history, and perform a focused physical examination. If the patient is not responsive, obtain vital signs, and complete a rapid medical assessment. Obtain the OPQRST and sample history from bystanders and family members, if possible. To choose the appropriate course of action in a toxicologic emergency, obtain at least the following specific information. What is the agent? If the patient has overdosed on a prescription drug, bring the pill bottle and the remaining pills with the patient. If the substance was a commercial product, take the closed container and its remaining contents to the emergency department. Remember that the container should be capped or kept in another closed container. If the patient ingested a plant, find out what part, roots, leaves, stem, flower, or fruit, and take a sample of the plant to the emergency department for identification. If the patient vomits, save a sample of the vomitus in a clean, closed container, and take it with you to the emergency department. Vomitus can rarely be analyzed except in the incidence of mushroom ingestions. Do not delay transport of an ill patient to obtain this sample. When was the poison ingested, injected, dermally absorbed, or inhaled? The decision to decontaminate the gastrointestinal tract is strongly influenced by the amount of time that has elapsed since the exposure. The likelihood of binding significant quantities of the poison in the stomach decreases rapidly after the first 30 to 60 minutes in most circumstances. How much was taken, injected, dermally absorbed, or inhaled? Street drugs are commonly sold in single dose hits or tablets. If the patient says he has taken 3 hits of acid, you know he has taken 3 times the normal dose of LSD. If the patient says that she took 4 tabs of ecstasy, that is 4 times a single dose. There is almost always a distinct correlation between dose and toxic effects. What else was taken? A majority of intentional self-poisonings, suicide attempts, or illicit drug overdoses involve polydrug ingestion, often with alcohol as one of the drugs. The patient may also have tried to take something as an antidote, that is, something to counteract the effect of the poison. This information can be invaluable to emergency department staff when deciding which tests to order. Has the patient vomited or aspirated? If so, how soon after the ingestion or exposure did the vomiting occur? How much? Was there evidence of toxin, tablets, or pills in the vomitus? Why was the substance taken? Although you may not get a reliable answer from someone abusing illicit drugs, this is still a question worth asking. Do not assume that every patient is trying to get high. Drug use could be a coping mechanism for a person who is being abused, or it could be a suicide attempt. Put the reason in quotation marks on your patient care report. Scene assessment. Patients who have taken an overdose may be extremely dangerous, so make sure you do a scene assessment in every case. If necessary, call for law enforcement backup or a crisis unit to minimize potential for injury to paramedics. Pay particular attention to the safety of the pre-hospital environment if you suspect an accidental inhaled or a dermal route of absorption. In some cases, personal protective equipment will be required or the patient will require decontamination prior to contact, for example, gross contamination of the patient with organophosphate-based insecticide. Cooperation with hazmat teams may be required to safely extricate and decontaminate patients prior to detailed assessment. Initial assessment. The initial assessment of a patient who has overdosed or been poisoned begins with your general impression. It can be as simple as a young adult man snoring in a public bathroom stall. The initial assessment seeks to rapidly identify concerns with mental status, airway, breathing, and circulation. Threats to life need to be quickly managed by measures such as a head tilt chin lift, suctioning, or ventilation assistance with a bag mask device. The initial assessment may identify the mechanism of injury or nature of illness, and the need for additional units, and set the priority and tone of the call. Focused history and physical examination. After completing the initial assessment, begin the focused history and physical examination. With a trauma case, you will need to classify the patient as having a significant or non-significant mechanism of injury. With the significant mechanism of injury, you must quickly perform a rapid trauma assessment of the major body regions: head, neck, chest, abdomen, pelvis, back, buttocks, and 4 extremities. Obtain a set of baseline vital signs and a sample history. This patient should also receive a detailed physical examination en route to the hospital. If the patient does not have a significant mechanism of injury, perform a focused exam of the injured body part, that is, evaluate distal pulse, motor, and sensory functions, and range of motion. Most poisoning and overdose cases involve patients with medical conditions, so you will need to elaborate on their chief complaint using the OPQRST questions. If the patient is not responsive, perform a rapid medical assessment, basically the same as the rapid trauma assessment, obtain baseline vital signs, and ask the sample history questions of the family or bystanders, if possible. If the patient is responsive, complete the sample history, obtain the baseline vital signs, and conduct a focused examination targeting the body system most relevant to the chief complaint, for example, cardiovascular, pulmonary, neurologic, trauma. Detailed physical examination. The detailed physical examination should be conducted en route to the emergency department, unless you are delayed on the scene, and have the time to complete it there. Such an examination is usually conducted on a patient who has trauma with a significant mechanism of injury, as may occur in a patient who fell, was assaulted, or decided he or she could fly after the overdose or poisoning. The detailed physical examination is similar to the rapid trauma assessment, except that it is slower, is more involved, and looks more closely at the head. After completing the detailed physical examination, prioritize the injuries, manage them appropriately, and document your findings on the patient care report. Ongoing assessment. The ongoing assessment includes reassessment, reprioritizing, and checking the effectiveness of interventions provided. It is done en route to the emergency department. Continually monitor all patients who have ingested, injected, absorbed, or inhaled a poisonous substance, and be aware that they may vomit at any point. A stable patient may become unstable en route as more toxin is absorbed over time. Assessment and management of overdose with specific substances. From a management perspective, advanced life support care builds on the basics. Ensure the scene is safe for access and egress. Maintain the airway. Ensure that breathing is adequate. Ensure that circulation is not compromised, that is, by hypoperfusion or dysrhythmia. Administer high-concentration supplemental oxygen. Establish vascular access. Be prepared to manage shock, coma, seizures, and dysrhythmias. Transport the patient as soon as possible. Place the patient in the left lateral recumbent position if there is any risk of vomiting to reduce the risk of aspiration. Alcohol. Alcohol is the most widely abused drug in Canada. From million-dollar gated communities to low-income housing developments, alcoholism occurs in all social strata, and in almost every culture. In one survey, 75% of the Canadian population indicated that they used alcohol in the past year. 2016 statistics indicate that, in Canadians aged 12 and older, 19%, roughly 5.8 million people, are heavy drinkers. Furthermore, because of its harmful effects on organs, including the liver, stomach, heart, pancreas, brain, and central nervous system, alcoholism decreases a person's lifespan by 10 to 20 years. In addition, people with alcoholism tend to have chronic malnutrition and fall frequently, increasing the likelihood of head injury or other trauma. Alcoholism usually consists of 2 distinct phases. The first phase is problem drinking, during which alcohol is used increasingly more often to relieve tensions or other emotional difficulties. Because of the disinhibition, relaxation, and sense of well-being mediated by alcohol. Some degree of psychological dependence often develops with its use. Unfortunately, many people become so dependent on the psychological influences of alcohol that they become compulsive consumers. As a person becomes more dependent on drinking, his or her performance at work and relationships with friends, family, and colleagues may deteriorate. Increased absence from work, emotional disturbances, and automobile collisions become more frequent. Physical dependence also results from the regular consumption of large quantities of alcohol. This becomes apparent when a person abruptly stops consuming alcohol and withdrawal symptoms result. The severity of the withdrawal can vary according to the length and intensity of the alcoholic habit. Minor withdrawal is characterized by restlessness, anxiousness, difficulty sleeping, agitation, and tremors. For those with a more serious physical dependence, sudden abstinence can cause significant symptoms, such as hypertension, tachycardia, vomiting, hallucinations, and delirium tremens. The Diagnostic and Statistical Manual of Mental Disorders, 5th edition outlines criteria that are used to diagnose someone with an alcohol use disorder. Common warning signs include the following: consuming alcohol in large quantities or over a long period, spending considerable time in activities necessary to obtain alcohol, use alcohol, or recover from its effects, causing or exacerbating social or interpersonal problems due to alcohol use, reducing social, occupational, or recreational activities due to alcohol use, continuing to use alcohol even after acknowledging the physical or psychological problems that are caused or exacerbated by alcohol use. In the second phase of alcoholism, true addiction, abstinence causes major withdrawal symptoms, for example, increased blood pressure, vomiting, and hallucinations. Delirium tremens, or alcohol withdrawal delirium, results in fever, disorientation, confusion, seizures, and possibly death. Red flags pointing to alcohol abuse include the following: drinking early in the day, drinking alone or in secret, periodic binges, loss of memory, or blackouts, tremulousness and anxiety, chronically flushed face and palms. Medical consequences of alcohol abuse. Because of the toxic effects of alcohol, a person with alcoholism is considerably more prone to a number of serious illnesses and injuries. Chronic damage to the central nervous system, for example, leads to deterioration in higher mental functions, such as memory and logical thinking. Damage to the cerebellum affects balance, which in turn contributes to frequent falls. Damage to the peripheral nerves leads to decreased sensation in the extremities, making one prone to burns and similar injuries that an intact pain sense would ordinarily prevent. As alcohol travels through the digestive system, it irritates tissue and can damage the lining of the stomach by causing acid imbalances, inflammation, and acute gastric distress. Often, the result is gastritis, an inflamed stomach, and heartburn. The more frequently consumption takes place, the greater the irritation. 1 in 3 heavy drinkers has chronic gastritis. Heavy drinkers also have double the risk of cancer of the mouth and esophagus. Prolonged heavy use of alcohol may cause ulcers, hiatal hernias, and cancers throughout the digestive tract. The toxic effects of alcohol on the liver produce a variety of complications, such as coagulopathies, easy bleeding and poor clotting ability, hypoglycemia, and cirrhosis. In addition, people with alcoholism are at high risk of acute pancreatitis, pneumonia, and cardiomyopathy. Any of the conditions previously mentioned may contribute to an emergency. In addition, acute consumption of and acute abstinence from alcohol may produce serious problems, including withdrawal seizures. Acute alcohol intoxication. Severe alcohol intoxication is a form of poisoning and carries the same lethal potential as poisoning with any other central nervous system depressant. Death from alcohol intoxication has been reported with blood alcohol levels of 80 millimoles per liter or more, which can be attained by the relatively rapid consumption of as little as 1/2 pint of whiskey. The most immediate danger to an acutely intoxicated person is death because of respiratory depression and/or aspiration of vomitus or stomach contents secondary to a suppressed gag reflex. Remember that the legal blood alcohol level is 17 millimoles per liter in most provinces and territories in Canada. If an intoxicated patient is unresponsive, treat him or her as you would any unresponsive patient. As always, first establish and maintain the airway. With an intact gag reflex, place the patient in left lateral recumbent position with suction ready. If there is no gag reflex, intubate the patient. In addition, give high-concentration supplemental oxygen, and assist ventilation as needed. Establish vascular access. Monitor the ECG rhythm. Assess the patient's blood glucose level, treating hypoglycemia if it is found. Thiamine 100 mg via slow intravenous push may be administered on arrival to the emergency department to prevent Wernicke-Korsakoff syndrome, an acute onset delirium secondary to thiamine deficiency. Finally, transport the patient to an appropriate facility. Alcohol withdrawal seizures. A person who has been drinking heavily for an extended period, and suddenly stops drinking may have a variety of withdrawal phenomena. Seizures usually occur within about 12 to 48 hours of the last drink. Use the same pre-hospital care plan described for alcohol intoxication, and consult with direct medical control about giving benzodiazepines for seizure control. Simple withdrawal seizures usually are short-lived and self-resolving. With delirium tremens, however, the seizures may mimic that of status epilepticus and require massive amounts of benzodiazepines for improvement. Delirium tremens. One of the most serious and lethal complications of alcohol withdrawal is delirium tremens. Symptoms usually start 48 to 72 hours after the last alcohol intake, although 7 to 10 days may pass before the onset of symptoms in some cases. Delirium tremens is a serious and potentially fatal syndrome with mortality reported as high as 15%. Signs and symptoms are typically related to excess catecholamine release and can include confusion, tremors and restlessness, tachycardia, fever, and diaphoresis, hallucinations, extremely frightening, such as snakes, spiders, and rats, and hypotension, often secondary to dehydration. Hypertension is often seen initially, but hypotension may later ensue because patients are typically dehydrated. The treatment for a patient in delirium tremens is aimed at protecting him or her from injury, and providing supportive pre-hospital care. The often terrifying hallucinations associated with delirium tremens typically make for an agitated, frequently combative patient. Try to keep the patient calm. In addition, you should administer supplemental oxygen by nasal cannula, and establish vascular access. Benzodiazepines are the treatment of choice for signs and symptoms associated with the excess catecholamines. If the patient is hypotensive due to dehydration or benzodiazepine use, or if dehydration is noted clinically, then the treatment of choice is infusion of normal saline. You should ensure that the patient is assessed frequently and maintain an ongoing dialogue with the patient throughout transport to help orient and reassure the patient. Stimulants. Few drugs compare with stimulants in potential for abuse, particularly cocaine and amphetamines. A first-time user may become addicted to one of these substances within just a few days. Very few of those who are addicted to stimulants successfully complete treatment and stay sober for the remainder of their life. Depending on the formulation, stimulant drugs may be taken orally, smoked, or injected intravenously. Most stimulants work to enhance the release of catecholamines, which stimulate the central nervous system, specifically, alpha and beta receptors. This central nervous system stimulation can increase alertness and create a sense of euphoria. The clinical presentation of the stimulant abuser includes excitement, delirium, tachycardia, hypertension, or hypotension, and dilated pupils. As toxic catecholamine levels are reached, the patient may develop outright psychosis, hyperpyrexia, tremors, seizures, and cardiac arrest. The chronic user may appear wild-eyed and cachectic with nervous or jittery movements. Week-long stretches without sleeping are not unusual, with little attention paid to normal nutrition or self-care. As the days pass, increasing paranoia makes encounters risky. Patients can be very agitated. It often takes very little to provoke someone. Cocaine. Cocaine is a naturally occurring alkaloid that is extracted from the Erythroxylum coca plant leaves found in South America. In the 6th century, the chewing of coca leaves was a daily event for people living in the coca-growing region of South America. With a relative purity of only about 2%, the leaves served as a mild stimulant, with no real potential for overdose. Chewing coca leaves also produced anorexia, euphoria, and improved energy. Once processed into cocaine hydrochloride, however, the active ingredient in the leaves goes from 2% to 100% pure, dramatically increasing its toxic potential. During the 1800s, cocaine and opium were commonly found in the elixirs, potions, and syrups sold by traveling medicine shows. Although neither substance cures anything, the people who use these products did not complain, given the drug's euphoria-producing capabilities. Cocaine is a local anesthetic and a central nervous system stimulant. It also has the capability of creating a euphoria that features enhanced alertness and a tremendous sense of well-being. Collectively, this constellation of effects makes cocaine a very psychologically addictive drug. The amount of biologically active cocaine may vary from one form to another. Some variants may exist based on the amount of filler, potentially toxic adulterants, used to dilute or cut the drug. The higher the purity of the cocaine, the more severe the potential dependence becomes. People who occasionally use a less pure solution of the drug will not be as psychologically or physiologically dependent as someone who is using a purer solution. Cocaine users with serious dependence problems may have significant health conditions as well as social and psychological challenges. Today, cocaine has limited use in clinical medicine, mostly in ear, nose, throat, and eye surgery. This water-soluble hydrochloride salt is quickly absorbed across all mucosal membranes, allowing it to be applied topically, swallowed, or injected intravenously. Cocaine powder, hydrochloride, is usually insufflated, snorted, or injected. Crack cocaine is simply cocaine mixed with two inexpensive ingredients, baking soda and water. After being mixed together into a paste-like slurry, and cooked or baked, the end result is smokable cocaine, crack. When cocaine is snorted nasally, effects are felt within 1 to 2 minutes, and peak effects occur in 20 to 30 minutes. After the intense, initial high, only 15 to 30 minutes passes before the user wants to redose. When cocaine is smoked, and the alveoli are literally bathed in cocaine-laden smoke, the onset of effects is much more rapid, in the 8 to 10 second range, and the high is even more intense than when cocaine is snorted. When the effects of cocaine wear off, a predictable cycle of events occurs. The user experiences a collision or crash, which is characterized by depression, irritability, sleeplessness, and exhaustion. To avoid this collision, the user will often seek more cocaine. Adding to the problem, a cocaine addict who is trying to escape the unpleasant effects of a collision often takes a sedative, such as diazepam, alcohol, or heroin. Thus, a chronic cocaine user might practice polypharmacy and may be dependent on more than cocaine, increasing the likelihood that he or she will need pre-hospital care, possibly overdosing on uppers, downers, or both. A person who has overdosed on cocaine may exhibit any of the signs and symptoms for stimulants in general, discussed earlier. Furthermore, cocaine has been reported to cause a variety of serious, sometimes fatal, complications, lethal dysrhythmias, acute myocardial infarction, seizures, stroke, apnea, and hyperthermia. In addition, a crack smoker risks pneumothorax and pneumomediastinum. Give particular attention to the electrocardiogram rhythm in the case of a suspected cocaine overdose. Cocaine has membrane-stabilizing effects on cardiac conduction, causing widening of the QRS. With increased dosing levels, cocaine exerts potentially deadly effects on the myocardium, which may present as wide complex dysrhythmias, negative inotropic effects with decreased cardiac outputs, hypotension, or tachycardia initially, followed by bradycardia. For these reasons, use of beta or calcium channel blockers is contraindicated in managing tachydysrhythmias due to cocaine intoxication. A speedball is a combination of heroin and cocaine. Heroin addicts may use cocaine to withdraw or detoxify themselves from heroin by gradually decreasing the amounts of heroin taken while increasing the amounts of cocaine used. Addicts claim that cocaine provides relief from the unpleasant withdrawal effects that accompany heroin abstinence in a dependent user. Amphetamine, methamphetamine, and amphetamine-like drugs. Amphetamines are structurally similar to the derivatives of phenylethylamine and include methamphetamine, crank or ice, methylene dioxyamphetamine, MDA, atom, and methylene dioxymethamphetamine, MDMA, ecstasy. Amphetamine and amphetamine-like drugs have many legitimate clinical applications. Most nasal decongestants and diet pills are members of this family, as are the drugs used to treat narcolepsy, attention deficit disorder, and attention deficit or hyperactivity disorder. Methamphetamine is problematic because it is a low-cost, long-acting, up to 12 hours, stimulant that is extremely addictive. Although methamphetamine use is increasing across the country, with the greatest in the West, and the least in the East, the methamphetamine epidemic has not influenced Canada to the same degree as in the United States. Cooking methamphetamine is easily done from common ingredients. For this reason, many decongestant cold medications have been placed behind the counter in attempts to limit its manufacture. Meth labs are dangerous and should be treated as hazardous materials incidents. See Chapter 53. The clinical presentation of the patient abusing amphetamine or methamphetamine is almost identical to that of a person abusing cocaine, with the primary exception that the effects of the former drugs last many hours longer than those of cocaine. Patient management remains the same as well. In most cases, pre-hospital management is primarily supportive. Never forget about the potential emotional and psychological instability, particularly in patients who have been on a binge. With each passing day of no sleep, and little or no food, the users become increasingly paranoid and even psychotic. Be prepared to contact law enforcement for support. Chapter 40 deals with the issue of restraint in detail. Synthetic cathinones, bath salts. Synthetic cathinones, also known as bath salts, refer to an emerging group of drugs similar to MDMA. Synthetic cathinones are psychoactive substances related to the chemical compound derived from the khat plant, which is native to East Africa. Khat leaves are traditionally chewed for a stimulant and euphoric effect. Synthetic cathinones are chemically engineered to have a higher potency than the natural compound. However, bath salts should not be confused with bathing products such as Epsom salt, magnesium sulfate. Several of the chemical components used in synthetic cathinones originate in countries such as China. Synthetic cathinones are popular because they offer effects similar to stimulants such as cocaine and amphetamines, which usually cost less. Bath salts are sometimes sold as plant food or cleaners, and are labeled as not for human consumption. Synthetic cathinones often have a white or brown crystal-like appearance, and come in foil packages with names like Flakka, Cloud9, or White Lightning. They may be sold in convenience stores or gas stations, making them more accessible than other illicit drugs. It is difficult to identify new psychoactive substances, and their unique characteristics, creating huge challenges in recognizing and treating patients appropriately. Similar to other stimulants, synthetic cathinones can be ingested, insufflated, smoked, or injected. The speed of onset depends on the route of absorption. The two routes associated with the highest mortality rates are insufflation and needle injection. Synthetic cathinone use has been associated with significant paranoia, hallucinations, incredible strength, excited delirium, and other bizarre behaviors. Tachycardia, diaphoresis, nausea, and hyperthermia may also be present. Management of stimulant abuse. The treatment for patients abusing cocaine, amphetamine, or methamphetamine is fundamentally the same: maintain maximum oxygen saturation levels, prevent seizures with adequate sedation, and monitor serial vital signs. The most life-threatening presentations of stimulant abuse include dysrhythmias, vascular events, hypertension, hyperthermia, seizures, and agitation. Treatment of stimulant abuse and toxicity includes supportive care, maintaining oxygenation, proper monitoring, and assessing the need for appropriate intervention with intravenous fluids and/or medications. Establish and maintain the airway. Consider an advanced airway as needed. Provide supplemental oxygen to maintain saturation levels greater than 94%. Establish vascular access. Apply the ECG monitor, pulse oximeter, and capnometer. Manage hypotension with a fluid infusion of normal saline. Benzodiazepines are first-line treatments for hypertension, tachycardia, anxiety, and seizures. For violent behavior, follow local or regional protocols, or contact direct medical control for sedation. Transport to the appropriate facility. The administration of beta-adrenergic antagonist agents is absolutely contraindicated for patients abusing stimulants. In severe cases of stimulant overdose, the patient may present with hyperthermia, which can be lethal. Cooled intravenous fluids or application of ice packs or misting the patient's skin may reduce his or her temperature. If the patient has a seizure, then benzodiazepines remain the treatment of choice. Marijuana and cannabinoids. When the leaves and flower buds of the cannabis sativa plant are harvested and dried, the end product is referred to as marijuana, also known as weed, pot, dope, and smoke. The resin produced by the maturing flower tops can also be harvested and used to produce hashish, also known as hash. According to Statistics Canada, approximately 5.3 million Canadians, 18%, age 15 years and older reported using cannabis in the first 3 months of 2019. This was higher than the 14% who reported use prior to legalization in October 2018. Use is more common among 15 to 24-year-olds, 30%, than among people aged 25 and older, 16%. Clinical uses of marijuana are limited, but include the treatment of glaucoma and relief of nausea and appetite loss for patients undergoing chemotherapy. The primary psychoactive ingredient in marijuana and hashish is delta-9 tetrahydrocannabinol. Marijuana is usually smoked, but can be ingested, such as when baked in cookies or brownies. The onset of effects from smoking marijuana is a matter of minutes. Oral ingestion slows the onset time to several hours. When smoked, the effects generally last 2 to 4 hours. When ingested, the effects can last twice as long. Although classified as a hallucinogen, marijuana does not produce true hallucinations, unlike PCP, phencyclidine, LSD, lysergic acid diethylamide, and mescaline, but users may have a distorted sense of time and space and, occasionally, a feeling of unreality. Smoking marijuana results in bronchodilation and slight tachycardia. Other signs and symptoms of marijuana use include euphoria, drowsiness, decreased short-term memory, diminished motor coordination, increased appetite, and injected conjunctiva. Cannabidiol is one of the main active chemical compounds in marijuana but does not have the euphoric or intoxicating effects of tetrahydrocannabinol. There is some suggestion that cannabidiol may have therapeutic effects, including anti-seizure, neuroprotective, analgesia, and anti-tumor properties. Management focuses on supportive pre-hospital care because the likelihood of a serious medical complication is small. A novice user may exhibit some behavioral symptoms such as paranoia and, rarely, psychosis. Psychological first aid and reassurance generally suffice to address either issue. If the patient remains anxious, low-dose benzodiazepines may be administered. Transport for continued evaluation is rarely warranted, but providing information for support and counseling services can be helpful. Spice. Similar to synthetic catharones, spice is a synthetic cannabinoid that falls into the category of new psychoactive substances. Because the cannabinoids act on the same cellular receptors as tetrahydrocannabinol, spice is often marketed as synthetic marijuana. However, The active substance is a blend of chemicals that is either sprayed onto plant-like material for smoking, or sold as a liquid for vaporizing in electronic cigarettes. Some users report euphoria similar to marijuana use. However, these chemicals can be much more dangerous than marijuana. Adverse effects of spice use include psychosis, hallucinations, tachycardia, vomiting, renal conditions, and seizures. As with synthetic catharones, it can be challenging to obtain a good assessment and form a treatment plan for someone who has used spice. Various chemicals may have been used in the spice, so patient presentations may vary. Supportive care with fluids and antiemetics is often appropriate. If the patient is experiencing a seizure, then benzodiazepines are the medication of choice. Hallucinogens. A hallucinogen is a substance that causes some distortion of sense perception, seeing, hearing, or feeling things that are not actually present. These outcomes are termed psychedelic effects. Experiences involving hallucinogens can vary markedly, with people taking the same dose of the same drug from the same batch experiencing totally different effects. The overall drug experience is affected by the user's previous drug experience, the dose taken, the user's expectations, and the social setting. A wide variety of substances have been used over the centuries for their hallucinogenic properties, and these substances can be classified into two categories: synthetic and naturally occurring. The synthetic class includes LSD, PCP, and ketamine. The naturally occurring hallucinogens include marijuana, mescaline, psilocybin-containing mushrooms, and the seeds of the Jimson weed plant. Lysergic acid diethylamide. In 1938, Dr. Albert Hofmann discovered what would be the prototype for synthetic hallucinogens, LSD. Use of this drug peaked in the 1960s, faded, and resurfaced in the 1990s. LSD is considered a non-habit-forming drug, although tolerance can occur if it is taken for several days in a row. LSD primarily affects the senses. Synesthesias, crossing of the senses, often prompt a user to respond to the question "What were you doing?" with a reply such as "I was watching the music play" or "I was listening to that painting." Users often experiment with LSD for self-exploration, for religious reasons, or to experience its often stunning visual and auditory effects. Because of LSD's high potency, as little as 25 micrograms can produce central nervous system effects. A single dose or hit is 25 to 100 micrograms, although many users take 3 or more hits. As dosing increases to approximately 1,000 micrograms, there is a proportional increase in the drug's effects, which may last as long as 12 hours, although 3 to 4 hours is more typical. From a physiologic perspective, LSD is a serotonin receptor agonist, with the effects being mostly sympathomimetic, often consisting of tachycardia, mild hypertension, and dilated pupils. In a bad trip, the user has a frightening experience, resulting in an acute anxiety attack, and the physical effects secondary to increased anxiety. The treatment for a patient using LSD is primarily supportive, focusing on the psychological aspects of the drug experience. For a person having a bad trip, think of it as being in a living nightmare or a dream that is as real as reality. This dream does not end until the drug wears off, however. Try to limit sensory stimulation as much as possible, for example, by avoiding the use of emergency lights and sirens. Routine transport to the appropriate facility plus psychological support are usually all that is required in the pre-hospital setting. Phencyclidine. Phencyclidine, PCP, also called angel dust or dust, was developed in the late 1950s as a potential anesthetic. In clinical trial, problems with the drug, namely, delirium, and psychotic-appearing symptoms, led PCP to be relegated to use as an animal tranquilizer, Sernilin. PCP abuse was first noted in the 1970s. PCP is not commonly available on the streets of Canada today, because most people are now aware of its significant untoward effects, particularly the delirium it causes. What is available is manufactured in clandestine laboratories, so variations in potency and purity are common. PCP can be a contaminant of other street drugs. Although PCP is grouped with the hallucinogens here, it is actually classified as a dissociative anesthetic, like ketamine, and acts on N-methyl D-aspartate receptors. It is typically smoked or snorted, although it can be injected. Small doses, 25 to 50 milligrams, can produce signs and symptoms of intoxication in an adult, with a high from a single dose typically lasting 4 to 6 hours. Users typically exhibit slurred speech, staggering gait, tachycardia, hypertension, staring blankly for extended periods, and horizontal nystagmus, involuntary, rhythmic movement of the eyes. This is the prototypical substance of abuse that can cause opisthotosis, a severe form of muscle rigidity where the occiput and heels of the patient touch the bed when supine, but the neck, back, and pelvis are severely arched. More problematic are the mind-body separation, related hallucinations, and violent outbreaks that are hallmarks of PCP use. PCP has the capability to distort sight and sound and make the user feel separated from his or her own body. Users may make bizarre comments such as "I can fly," and then jump off a balcony to prove it. Users have an almost unfathomable ability to tolerate pain with no reaction and exhibit almost superhuman strength. PCP can cause some of the most violent and difficult behavior you will encounter in the pre-hospital environment, so pre-hospital care focuses on protecting the patient and providers alike from the patient's poor judgment and impaired behavior. Supportive pre-hospital care includes oxygen, cardiac monitoring, intravenous access without provoking the patient, and benzodiazepines for sedation. If an intravenous access cannot be established, then a benzodiazepine may be given intramuscularly. Ketamine. Ketamine, special K, vitamin K, also discussed in Chapter 41, is an analog of PCP and another dissociative anesthetic. Most ketamine available on the streets is diverted from veterinary clinics, although this drug is used in clinical medicine. Liquid ketamine is colorless and odorless. Ketamine can also be found in a powdered form. It is often mixed in a drink, although it can be snorted. It is physically and psychologically addicting. Typical oral dosing is 75 to 300 milligrams. When snorted, the dose is reduced slightly to 15 to 200 milligrams. Like PCP, ketamine works at the N-methyl D-aspartate receptors. It also binds to mu-opioid receptors, giving it analgesic properties. At low doses, a user presents with mild inebriation, euphoria, erotic thoughts, and increased sociability. At higher doses, a patient may have pronounced nausea, difficulty moving, and significant hallucinations, often referred to as entering another reality or entering the K-hole, out-of-body experiences, a feeling of being detached from one's surroundings. Although violent outbreaks are much less likely with ketamine than with PCP, the principles of management are the same for the two drugs. Secure the patient well, assess and manage the airway, breathing, and circulation, provide oxygen therapy, and establish vascular access if time and the situation allow as you provide safe transport to the appropriate facility. Keep a close eye on the patient because both agitation and profound sedation with respiratory compromise can occur with this drug. If violent behavior occurs, it can be sudden, with benzodiazepines being helpful in calming an agitated patient who is experiencing significant delirium. Psilocybin mushrooms. Hallucinogenic mushrooms that contain psilocybin and psilocin are native to both the east and west coasts of Canada, but not central Canada. They can, however, be purchased on the streets as dried caps anywhere in the country. The typical dose is estimated to be 4 to 10 milligrams, approximately 2 to 4 mushrooms. Consumption of 100 mushrooms or more as a single dose has been reported. The onset of symptoms and hallucinogenic effects, similar to LSD but less intense, is within 30 minutes of ingestion, and effects usually last 4 to 6 hours. Signs and symptoms include nausea and vomiting, mydriasis, mild tachycardia, and mild hypertension. As doses increase, frank psychosis, wild agitation, and other sympathomimetic symptoms can occur. The likelihood of any serious medical side effects is low, although the literature describes seizures and hyperthermia in some cases. Because there are many look-alikes, foraging for magic mushrooms raises the risk of eating hepatotoxic mushrooms. Delayed onset vomiting, diarrhea, and the absence of hallucinations should alert the healthcare provider to the possibility of a hepatotoxic mushroom ingestion. Treat the patient with supportive pre-hospital care. Hallucinations are likely to subside quickly if the patient is in a secure, safe environment. Managing the airway, breathing, and circulation and monitoring vital signs are usually all that is required, along with safe transport to the appropriate facility. If time and circumstances allow, establish vascular access to facilitate seizure control with benzodiazepines, if necessary. Sedatives and hypnotics. The drugs in the sedative-hypnotic category have a wide range of applications. Drugs with sedative qualities are used to reduce anxiety and to calm agitated patients. Drugs with hypnotic qualities are used as sleep aids, helping produce drowsiness and sleep. In either case, sedative hypnotic drugs function primarily as central nervous system depressants. These drugs have a high potential for abuse, and are at high risk for drug diversion in the medical field. Barbiturates. The barbiturates have a long history of use as sleep aids, anti-anxiety drugs, and seizure control medications. Barbiturates use and abuse reached their peak in the late 1970s, when these drugs were tagged with street names that coincided with the color of the pill or capsule: reds, secabarbital; yellows or yellow jackets, pentobarbital; blues or blue heavens, amobarbital; and rainbows, amobarbital plus secabarbital. The frequent combination of alcohol and barbiturates as a suicide mechanism, coupled with the high incidence of accidental overdoses, pushed researchers to develop sedative hypnotic drugs that had fewer depressive effects on the respiratory system, and that were less lethal. Today, there is little prescribing or abuse of barbiturates except for phenobarbital, which continues to be used for seizure control. Barbiturates potentiate gamma-aminobutyric acid at specific receptors to inhibit cellular excitation. As the dose increases, barbiturates bind to other receptor sites and cause more widespread central nervous system depression. Barbiturates come in 4 basic configurations: long-acting, intermediate-acting, short-acting, and ultra-short-acting. Ultra-short-acting barbiturates are highly lipid-soluble and have a rapid onset because they quickly cross the blood-brain barrier. These substances are preferred when time is of the essence, such as with airway management or stopping an active seizure. Long-acting barbiturates are less lipid-soluble, therefore, they have a delayed onset of action, and are preferred when a sustained therapeutic level of a medication is required over a long period. The liver metabolizes most barbiturates into inactive waste products, although barbiturates that bind less tightly to proteins tend to be excreted unchanged in the urine. Clinically speaking, barbiturates are similar to alcohol in terms of symptoms, dependence, and withdrawal symptoms. Mild to moderate barbiturate intoxication is similar to alcohol intoxication. Symptoms include decreased alertness, nystagmus, ataxia, mental confusion, and slurred speech. As the dose increases, the patient moves further down the scale of central nervous system depression, becoming increasingly lethargic and eventually unresponsive. Be aware of the potential for respiratory depression. Barbiturate abusers quickly develop tolerance, and require increasing doses to produce the desired effects. Long-term use results in physical addiction. Abrupt cessation in a long-term barbiturate abuser will produce typical signs and symptoms of the withdrawal syndrome in approximately 24 hours, with potentially life-threatening signs and symptoms arising up to 1 week after abrupt cessation. In the case of minor withdrawal, the patient may present with symptoms similar to those observed in a patient with alcohol withdrawal: restlessness and anxiety, depression, insomnia, diaphoresis, abdominal cramping, nausea, and vomiting. With severe cases of withdrawal, patients commonly experience delirium, hallucinations, psychosis, seizures, hyperthermia, and cardiovascular collapse. Your assessment of the barbiturate intoxicated patient should focus on airway protection and ventilatory support as management priorities. because of the central nervous system depressant effects of these drugs. The patient may require intubation or other advanced airway maneuver to secure the airway and prevent aspiration should the patient vomit. Supplemental oxygen is needed because patients with altered levels of consciousness typically hypoventilate and are hypoxic before treatment begins. Once the airway and breathing are managed, attention to circulation should include monitoring cardiac rhythm and obtaining intravenous access. The paramedic should consider one or more crystalloid boluses for hypovolemia, hypotension, or signs of shock. If the patient remains refractory, consider a vasopressor such as dopamine or follow local or regional protocols or medical directives to manage ongoing hypotension. Once absorbed, a variety of interventions can be used to cause the phenobarbital to be eliminated more quickly from the body. Although these are best initiated in the emergency department setting, if patient transport times are very long, you may wish to contact direct medical control to discuss further therapies such as activated charcoal or alkalinization of urine. While multiple dose activated charcoal decreases the half-life of phenobarbital, it does not appear to have an impact on overall morbidity and mortality. Although not typically administered in the pre-hospital setting, it may be useful if administered soon after drug ingestion. You should take great care in administering charcoal to a patient who has taken a drug that can depress the central nervous system. If the patient who has received charcoal then requires airway protection or ventilatory support, aspiration of the charcoal will cause significant injury to the lungs. Alkalinization of the patient's urine with intravenous sodium bicarbonate can alter phenobarbital's charge in the blood, thereby trapping it in the urine, and promoting its excretion via this route. Although these two therapies, charcoal and alkalinization, may decrease phenobarbital's toxicity, they must not be delivered without first contacting direct medical control. There is no evidence that forced diuresis using a diuretic, such as furosemide, decreases the half-life or toxicity of phenobarbital. Finally, the patient with severe phenobarbital poisoning might require dialysis for drug removal. If you encounter barbiturate withdrawal in the pre-hospital setting, focus your treatment on immediate threats to life, including seizures, and providing supportive pre-hospital care. You should promptly initiate transport to the emergency department, because the patient will require investigations and care that can only be delivered in the hospital. Benzodiazepines and other sedative hypnotics. Benzodiazepines are also members of the sedative hypnotic family, and include diazepam, nitrazepam, clonazepam, midazolam, and lorazepam, to name a few. They are most commonly used to treat anxiety, seizures, and withdrawal symptoms. The drugs can be delivered orally, and some via the intramuscular or intravenous route, and are metabolized by the liver. In recent years, fast-acting sedative hypnotic agents such as zolpidem, zopiclone, and S-zopiclone were developed for the treatment of insomnia. These drugs are not true benzodiazepines, but have the same effects on the inhibitory neurotransmitter gamma-aminobutyric acid as do benzodiazepines. Although apparently less addictive than benzodiazepines, zolpidem, zopiclone, and S-zopiclone have the potential to cause a similar clinical picture of sedation in overdose. Dependence can develop in chronic use, and when stopped suddenly after a period of prolonged use, a withdrawal syndrome can occur. In a single-entity overdose, benzodiazepines have a relatively low rate of morbidity and mortality. The most common clinical effects of benzodiazepine overdose include altered mentation, drowsiness, confusion, slurred speech, ataxia, and general incoordination. Overdose of benzodiazepine rarely causes hypotension, and has not been known to cause dysrhythmias. For a suspected overdose in which the patient presents with severe respiratory depression, hypotension, or coma, it is likely that multiple substances were taken. Think to other central nervous system depressants and alcohol. Treatment of benzodiazepine overdose is relatively straightforward. Assess and manage the airway, inserting an advanced airway as needed. Give high-concentration supplemental oxygen. Establish vascular access. Apply the ECG monitor, pulse oximeter, and capnometer. Transport to the appropriate facility. Withdrawal from benzodiazepines may include tachycardia, tremulousness, confusion, and possibly seizures. Withdrawal is rarely a life-threatening event, but it can be complicated by withdrawal from other substances, such as alcohol. Management of withdrawal symptoms is similar to management of an overdose, but includes judicious use of a benzodiazepine to alleviate the withdrawal symptoms until a medically managed withdrawal can be accomplished in a hospital or other appropriate inpatient setting. Flumazenil is a benzodiazepine receptor antagonist. It is indicated for respiratory depression secondary to benzodiazepine overdose. Contraindications for flumazenil include long-term benzodiazepine use, concomitant epileptogenic overdose, tricyclic antidepressants, and underlying seizure disorder, and is not routinely advised in benzodiazepine overdose because its administration can precipitate acute benzodiazepine withdrawal. In the pre-hospital environment, this could translate into intractable seizures, and no available treatment because benzodiazepine receptors are then blocked. Gamma-hydroxybutyrate. Gamma-hydroxybutyrate is an endogenous metabolite of gamma-aminobutyric acid, a neuromodulator involved with sleep cycles, memory retention, and emotional control. It causes intoxication similar to alcohol use. Gamma-hydroxybutyrate was initially used as an anesthetic in Europe before it appeared in North America as a bodybuilding aid. By the late 1980s, gamma-hydroxybutyrate had gained popularity with young people as a club drug, earning the name liquid ecstasy from its euphoric effects at raves, all-night dance parties. In the mid-1990s, gamma-hydroxybutyrate became increasingly associated with sexual assaults. Gamma-hydroxybutyrate is available as an odorless and colorless liquid that, despite its slightly salty taste, may go undetected when placed in a drink. Once ingested, gamma-hydroxybutyrate quickly crosses the blood-brain barrier, exerting its effects within 30 to 60 minutes. As little as 0.5 mg of gamma-hydroxybutyrate can produce a pronounced hypnotic effect along with disinhibition, passivity, and anterograde amnesia. When taken with alcohol, gamma-hydroxybutyrate increases the risk of central nervous system depression. Withdrawal may produce symptoms similar to alcohol or benzodiazepine withdrawal. Gamma-hydroxybutyrate intoxication can result in significant, but fluctuating, central nervous system depression and airway compromise. Treatment of gamma-hydroxybutyrate intoxication focuses on supportive care. The patient may be unable to protect the airway. First, establish and maintain the airway, inserting an advanced airway as needed. Carefully monitor the patient's level of consciousness, provide supplemental oxygen, and assist with ventilations as necessary. Establish vascular access. Apply the ECG monitor, pulse oximeter, and capnometer. Finally, provide transport to the hospital. Narcotics, opiates, and opioids. A narcotic is a drug that produces sleep or altered mental status. Historically, narcotics have been classified into two major divisions, opiates and opioids. The term opiate is used to describe natural drugs derived from opium or the poppy, such as morphine and codeine. The term opioid refers to non-opium-derived synthetics, such as fentanyl, oxycodone, and hydrocodone. In this textbook, the term opioids is used to describe both illicit therapeutic agents and illicit substances in this group. Opioids have a long history of use and abuse, with writings as far back as the 3rd century BC mentioning the use of poppy juice. Today, abuse of narcotics remains one of the most common causes of overdose deaths reported to poison centers. In recent years, incredibly potent drugs such as carfentanil and decimorphine have increased in use on the streets. Carfentanil is a fentanyl analog used as an animal tranquilizer for large mammals such as elephants. It is far more potent than morphine or fentanyl, and its use by abusers seeking a quick opioid high can be fatal. Even more dangerous is the fact that other drugs are now being found to contain carfentanil, with the user being unaware they're ingesting a highly potent and potentially lethal drug. Opioids share certain properties but exhibit highly diverse effects, and vary widely in their potency. Opioids are used primarily in clinical medicine for analgesia, whereas the illicit drug heroin is abused for the unique euphoria it produces. Regarding potency, 80 to 100 milligrams of meperidine, Demerol, produces analgesia for 2 to 4 hours. 10 milligrams of morphine produces a similar effect for 4 to 5 hours, and just 2 milligrams of hydromorphone, dilaudid, has an analgesic effect, which also lasts for 4 to 5 hours. In 2016, the Public Health Agency of Canada declared the presence of an opioid crisis due to a doubling in drug-related deaths compared to prior years, almost exclusively due to opioids. More than 11,500 lives were lost due to opioid overdoses from January 2016 to December 2018, with an additional 1,082 opioid-related deaths in the first 3 months of 2019. Nearly 3/4 of these deaths were due to fentanyl and fentanyl analogs. In response to the crisis, the Government of Canada is using a public health approach to increase access to treatment, supporting approaches to harm reduction, improving public health data, intercepting illegal opioids as they enter Canada, and addressing the stigma related to opioid use. Opioids produce major effects on the central nervous system by binding with 3 main opioid receptor sites, delta, kappa, and mu. These receptor sites can produce analgesia and a euphoric sensation. The highest concentrations of receptor sites are found in the limbic system, frontal and temporal cortices, thalamus, hypothalamus, midbrain, and spinal cord. Opioids can be ingested, insufflated, inhaled, and injected. As with other substances, the route of absorption will help determine the speed of onset and duration of effect. When taken orally, the effects of these drugs are lessened owing to their significant first-pass metabolism through the liver compared with their effects when given parenterally. Opioids can also be absorbed through the skin via transdermal patches. Morphine and fentanyl are 2 commonly used analgesics in the pre-hospital setting. Fentanyl is a far more potent drug than morphine, and has a more rapid onset of action, and a shorter half-life. This potency does not mean that fentanyl is a stronger or better medication, it simply takes less of the medication to create a therapeutic effect. Morphine has some vasodilatory properties due to histamine release. Assessment. The classic presentation of opioid use features euphoria, hypotension, respiratory depression, and pinpoint pupils. Depending on the particular agent, nausea, vomiting, and constipation may occur as well. Allergic phenomena may also occur with opioid use, albeit rarely. With increased doses, coma, seizures, usually secondary to hypoxia, and cardiac arrest, usually secondary to respiratory arrest, are common. Morphine, named after Morpheus, the god of dreams, and heroin produce an impressive dreamlike state. Shortly after injecting heroin, a user will appear to pass out, in street terms, going on the nod. However, the user is typically quite lucid and remains aware of what is being done or said. Management. Because of the central nervous system depressant effects, patient management initially focuses on establishing and maintaining a patent airway, and providing adequate ventilation. A patient who has overdosed on opioids is almost always hypoventilating, sometimes breathing as few as 4 or 5 breaths per minute, and is consequently hypoxic and hypercarbic. Rather than moving immediately to intubation, place an oropharyngeal airway, and provide bag mask ventilation with 15 liters per minute of supplemental oxygen. Be aware that opioid-induced hypoventilation can cause significant hypercapnia, which can further suppress the patient's level of awareness due to carbon dioxide narcosis. This may be worsened by partial airway obstruction due to reduced pharyngeal muscle tone and tongue malpositioning. Neurologic status may improve with basic airway management and reduction of arterial dioxide levels, independent of other interventions. Next, establish vascular excess, and administer intravenous naloxone in doses ranging from 0.4 mg to 2 mg. Naloxone is a competitive antagonist acting at opioid receptor sites, reversing the effects of opioids, including respiratory depression, sedation, and hypotension. The goal of using naloxone is to improve the patient's spontaneous respiratory effort. You can titrate naloxone dosing to improve the respiratory status without bringing the patient back to a fully conscious and alert state. The desired response is improved ventilation so that intubation and ventilation might be avoided. Too large of a dose will precipitate acute narcotic withdrawal in a chronic user. These withdrawal symptoms are not life-threatening, as is alcohol or benzodiazepine withdrawal. The chronic abuser, abruptly waken, may become agitated and uncooperative because he or she is in pain and refuse to be transported to the hospital. Remember that a dose of naloxone has a shorter half-life as compared to many opioids. Redosing of naloxone is the rule rather than the exception. A patient should not be allowed to refuse transport after a dose of naloxone, because he or she may lapse back into unconsciousness. In March 2016, Health Canada removed naloxone from the prescription drug list, making it available without a prescription across Canada. In conjunction with this change, provinces and territories established a variety of dispensing and distribution systems to make naloxone kits available to those seeking it. The kits are available at no cost, and contain naloxone, which can be administered via a nasal delivery device, intranasal, or via injection, intramuscular. In Ontario alone, there were 147,303 naloxone kits distributed between July 2017 and June 2018. Many law enforcement and first response agencies now also carry naloxone kits. In addition, paramedic dispatch centers now provide callers with instructions on how to use a naloxone kit, if one is available, prior to the arrival of first responders or paramedics. Sometimes the patient may not respond to the initial dose of naloxone and may remain unresponsive. It is possible that the patient is under the influence of a very potent and/or large dose of the opioid. Follow your local or regional protocols, and consider contacting medical control if you believe the patient may require higher doses of naloxone. Failure to respond should prompt you to consider that the coma may be from another source altogether, such as a cerebrovascular accident or an overdose caused by polypharmacy. In either scenario, you should insert an advanced airway, provide supportive care as needed, and transport the patient to an appropriate facility without delay. Because of the nature of opioid overdose, particularly the respiratory and central nervous system depression with hypoxia, acidosis, and loss of airway protective reflexes, you may find the patient in cardiac arrest. Structure your resuscitation around high-quality chest compressions, and providing ventilations at the proper rate. Early administration of naloxone is indicated if you have a high index of suspicion that opioid poisoning may have precipitated the cardiac arrest. Carbon monoxide. Carbon monoxide causes more accidental poisoning deaths than any other toxic substance. It is produced by incomplete combustion of organic fuels, such as a motor vehicle engine or home heating device. Its presentation is often seasonal, occurring when furnaces are running, and flues or ventilation systems become blocked. It is also a major hazard when a running engine in an enclosed space generates the gas. A running engine in a closed garage can generate lethal concentrations of carbon monoxide within 30 minutes. This is often a mechanism of successful suicide. Carbon monoxide is a major component of smoke in enclosed space fires, and can be responsible for fire-related deaths. The use of carbon monoxide detectors in homes and other locations is a critical preventive health measure that can save lives and should be highly encouraged by all paramedic services and first response agencies. Carbon monoxide is a colorless, odorless, tasteless gas. Hence, those exposed to it have no warning of its presence. The toxicity arises primarily from its affinity for hemoglobin in red blood cells. Carbon monoxide displaces oxygen, thereby preventing the red blood cells from carrying oxygen to the tissues, and leading to suffocation at the cellular level. Hemoglobin's affinity for carbon monoxide is more than 250 times its affinity for oxygen, so the atmospheric level of carbon monoxide does not need to be very high for poisoning to occur. Even relatively small concentrations of carbon monoxide in the atmosphere can convert a significant proportion of hemoglobin into carboxyhemoglobin, hemoglobin combined with carbon dioxide, making it ineffective as an oxygen carrier. Because the overall ability of the blood to transport oxygen is so dramatically reduced when carbon monoxide reaches toxic levels, anything that increases the body's oxygen requirements, such as physical exertion or a fever, will increase the severity of the poisoning. Children, whose metabolic rate is intrinsically higher than that of adults, tend to have more severe symptoms at any given level of exposure. Carbon monoxide poisoning can be difficult to diagnose in the pre-hospital setting unless it is the direct result of an easily identifiable cause such as a fire or intentional exposure to exhaust fumes from an automobile. Its signs and symptoms are highly variable and quite vague, often resembling early onset of the flu, for example, headache, nausea, and vomiting. With acute carbon monoxide poisoning, the patient may be confused and unable to think clearly. Physical examination often reveals bounding pulses, dilated pupils, and pallor or cyanosis. Consider the possibility of carbon monoxide poisoning whenever you are confronted with several, possibly many, people who have shared the same accommodations for any period, especially if they have been quartered together in a closed area, such as one house in the winter. The cherry red color of the skin that is mentioned in many textbooks is a very late sign of carbon monoxide poisoning. Put bluntly, cherry red usually means really dead. Note that pulse oximetry at the scene will not provide a true assessment of arterial oxygenation because the device cannot determine whether carbon monoxide or oxygen is bound to the hemoglobin. A reading of 99% on the pulse oximeter would be excellent in a normal environmental setting, but would be a grave error in the presence of carboxyhemoglobin because the hemoglobin is saturated with the wrong chemical. Application of the ECG monitor to assess for cardiac ischemia can further support diagnostic and treatment efforts when carbon monoxide is the suspected culprit. Portable non-invasive oximeters can also measure carbon monoxide levels in the pre-hospital setting and have the potential to more rapidly identify patients with carbon monoxide poisoning. Treatment of carbon monoxide poisoning in the pre-hospital setting is aimed at providing the highest concentration of oxygen possible to attempt to displace carbon monoxide molecules from the hemoglobin. For patients breathing room air, the elimination half-life of carboxyhemoglobin is roughly 4 hours. By comparison, if the patient is breathing 100% oxygen, the half-life can be reduced to approximately 1.5 hours. Hyperbaric oxygen therapy at 2.5 atmospheres of pressure can further reduce the elimination time to 15 to 20 minutes, although its use is controversial. Hyperbaric oxygen may improve neurologic outcome in some situations through mechanisms unrelated to carbon monoxide elimination. If you suspect carbon monoxide poisoning, you should perform the following. Remove the patient from the exposure environment. Establish and maintain the airway, inserting an advanced airway as needed. Give high-flow supplemental oxygen by tight-fitting non-rebreathing mask. Maintain maximal inspired oxygen concentration regardless of measured arterial oxygen saturation. Establish vascular access. Keep the patient quiet and at rest to minimize oxygen demand. Monitor the ECG rhythm and level of consciousness. Transport to your nearest medical facility. If the patient is unresponsive or has signs of serious carbon monoxide poisoning, transport directly to a facility capable of providing hyperbaric medicine, if available. For patients with injuries or illness from a structural or vehicular fire, consider the possibility of combined carbon monoxide or cyanide poisoning, especially if the patient has signs of shock. Contact medical control for an order to administer hydroxycobalamin or sodium thiosulfate, if available. Carbon monoxide poisoning can be reversed if it is diagnosed and treated in time. However, even if the patient recovers, acute carbon monoxide poisoning may result in permanent damage to vital organs, and lead to mild to severe neurologic deficits. Chlorine gas. Incidents involving chlorine gas are relatively common because of the widespread use of chlorine compounds in the home and occupational settings. Household exposures usually occur on mixing a cleaning agent containing sodium hypochlorite, such as bleach, with a strong acid in an overzealous attempt to remove a stain. The resulting chemical reaction releases chlorine gas, often in high concentrations. However, most cases of chlorine gas exposure occur outside the home. The chlorination of large swimming pools, which tends to rely on gaseous rather than liquid or solid forms of chlorine, has led to mass exposures at hotels and community recreation centers. Leakage of chlorine gas from an industrial storage tank, truck, or rail car can also result in a mass casualty incident. The signs and symptoms of chlorine gas exposure depend on the concentration of the inhaled gas and the duration of exposure. Chlorine gas is extremely irritating to all mucous membranes. When it comes in contact with the moisture on those surfaces, it can form hydrochloric and other acids that are damaging to human tissue. With a minor exposure, the patient will experience burning sensations in the eyes, nose, and throat along with a slight cough. More intense exposure to chlorine gas causes chest tightness, choking, paroxysmal cough, headache, nausea, and vomiting, and diffuse wheezing. Patients with more severe exposures may also develop cyanosis, crackles in the chest, shock, seizures, and loss of consciousness. When treating patients who have been exposed to chlorine gas, your first priority is to remove them from the area of exposure. Take the same precautions that would apply in a hazmat situation when you choose where to position your vehicle, what personal protective equipment is needed, and what additional resources you need to maintain a safe scene. Once in a safe environment, quickly triage the patients. Irrigate burning or itching eyes with water, as well as any areas of the skin that have come in contact with the chlorine gas. People with dyspnea, wheezing, severe cough, or other signs of respiratory distress are priority patients, and should ideally receive high concentration, humidified oxygen by mask. Nebulized bronchodilators may ease wheezing. Patients with a significant exposure may develop non-cardiogenic pulmonary edema. The use of continuous positive airway pressure may benefit these patients. The administration of a nebulized sodium bicarbonate solution, 2 ml 8.4% sodium bicarbonate and 2 ml sterile water, may be ordered by medical control in confirmed symptomatic chlorine exposures, and can provide symptomatic relief. Consider tracheal intubation for patients who are fatigued and can no longer compensate, noting that laryngeal edema due to the inhalation injury may make intubation more difficult. If patients are exposed to very high concentrations of chlorine gas, then laryngospasm and edema may also complicate your airway management. Cyanide. Cyanide is used in industry for electroplating, or extraction, and fumigation of structures. In addition to industrial exposures, poisoning can occur after ingestion of cyanide contained in commercial products such as silver polish or from the seeds of cherries, apples, pears, and apricots. More commonly, cyanide poisoning occurs when a household fire results in the combustion of nitrogen-containing materials such as plastic items or furnishings, wool carpeting, or polyurethane silk. Cyanide is a rapid-acting and deadly poison. It combines with a crucial cellular enzyme, cytochrome oxidase, which in turn blocks the utilization of oxygen at the cellular level. The results are cellular suffocation and death within seconds if the cyanide was inhaled, or within minutes to possibly 1 or 2 hours if it was ingested. Cyanide can enter the body through inhalation, ingestion, or absorption through the skin. Physical examination of a patient who has been poisoned with cyanide may reveal an altered mental state. If awake enough to answer questions, the patient may report headache, palpitations, weakness, or dyspnea. The classic odor of bitter almonds on the patient's breath greatly suggests cyanide poisoning, but is not diagnostic. Respirations are rapid and labored early on. As the poisoning progresses, they become slow and gasping. The pulse is usually rapid and thready. Blood pressure is initially elevated, but is followed by profound hypotension. Vomiting, seizures, and coma can occur. The patient's venous blood, and sometimes the patient's body, may be bright red. Even though oxygen is available in the bloodstream, it is not being taken up by the tissues. Thus, A patient who is cyanotic has either not been poisoned with cyanide or is very close to death. If the cyanide poisoning occurred as the result of a toxic inhalation, remove the patient from the source of the cyanide, the toxic environment. Establish an airway, and administer 100% supplemental oxygen, assisting ventilations as necessary. Establish intravenous access. The aim of treatment is to displace the cyanide from the cytochrome oxidase by introducing another chemical that will attract the cyanide and bind to it. Several medications may be considered. Check with your service to see what is available on the ambulance or in any specially equipped hazmat or CBRNE, chemical, biologic, radiologic, nuclear, and explosive response vehicles. A long-standing treatment for cyanide poisoning is amyl nitrite. Commercial kits containing amyl nitrite may be available depending on your service. Take a gauze pad soaked in amyl nitrite, and hold it over the patient's nose for approximately 20 seconds, and then remove it to allow the patient to breathe high-concentration oxygen for approximately 40 seconds. Keep switching between the amyl nitrite and the oxygen while maintaining this ratio. While you are administering the amyl nitrite, your partner should establish vascular access. Sodium nitrite is another medication to consider for cyanide poisoning, with a dose of 300 mg intravenously over 2 to 4 minutes. Neither amyl nitrite nor sodium nitrite should be used in the setting of carbon monoxide poisoning. One of the newer treatments for cyanide poisoning is the administration of hydroxycobalamin, a member of the vitamin B12 family. Consider hydroxycobalamin, if available, for patients who are hypotensive, have an altered mental status, or are in cardiac arrest after being removed from a house fire. Some paramedic agencies now carry kits with hydroxycobalamin. An adult dose of 5 grams intravenously or intraosseously may be given over 15 minutes. Consider contacting medical control for guidance on additional dosing. Hydroxycobalamin is considered a relatively safe antidote, with allergy or anaphylaxis as the primary concern. Patients will also experience some temporary effects such as redness of the skin, eyes, and urine, as well as itching after hydroxycobalamin administration. Regardless of the pre-hospital care you deliver, it is advisable to notify the receiving hospital en route, and contact your provincial poison center. Pesticides. Organophosphates and carbamates. Organophosphates and carbamates are the active ingredients in many household and farm pesticides. In developing countries, these agents are commonly used in suicide attempts because they are readily available, as compared to pharmaceuticals. Nerve gases, which are used in chemical warfare, are also rapid-acting and highly potent organophosphates. Organophosphates and carbamates are referred to as acetylcholinesterase inhibitors, exerting their toxic effects at junctions, synapses, of the nerve cells of the autonomic nervous system, preventing the breakdown of acetylcholine. The conduction of an impulse from one nerve to another occurs through the release of acetylcholine at the synapse. Acetylcholine works as a chemical messenger, crossing the synapse to depolarize the nerve on the other side of the junction. Once it has delivered its message, the acetylcholine molecule must be inactivated or it would continue to stimulate the target nerve cell indefinitely, leaving the nerve cell unable to receive another message from the brain. The symptoms of organophosphate or carbamate poisoning include central nervous system and peripheral nervous system manifestations, and are the same whether the exposure was by ingestion, inhalation, or dermal absorption. Central nervous system symptoms can include confusion, restlessness, tremors, seizures, and loss of consciousness. Peripheral manifestations are of cholinergic excess and can be remembered by the mnemonic dumbbells. Diaphoresis and diarrhea. Urination. Meiosis, or mydriasis. Bronchospasm, bronchorrhea, and bradycardia. Emesis. Lacrimation, and salivation. In addition, because acetylcholine is active at motor end plates, with excessive stimulation patients develop marked motor weakness. Remember that commercially available organophosphates and carbamates are usually dissolved in hydrocarbon vehicles. Respiratory toxicity can also occur from aspiration of the hydrocarbon. Assessment and management of a patient with exposure to a nerve gas or pesticide start with decontamination and removal of all contaminated clothing before initiating care or loading the patient into the ambulance. In most medium to large-sized systems, this is performed by a dedicated hazmat crew. Wear personal protective equipment if the patient has ingested suspect toxic product, because vomiting after topical decontamination may lead to exposure. Contaminated clothing should be placed in plastic bags and disposed of as hazardous materials. Ideally, the patient should be scrubbed with soap and water. After that, patient care includes the following measures. Establish and maintain the airway. Consider an advanced airway, as needed. Suction as needed. Administer high-flow supplemental oxygen. Establish vascular access. Place the patient on an ECG monitor, pulse oximeter, and capnometer. For an adult patient, administer 1 mg atropine intravenously or intraosseously push. Double the dose every 3 to 5 minutes until bronchial secretions dry and bronchospasm, wheezing, resolves. Do not use heart rate as your endpoint. Transport to a medical facility. Atropine is the primary antidote for acetylcholinesterase inhibitor poisoning. Liberally administer repeat doses to symptomatic patients. Relief of bronchospasm and lessening of bronchuria indicate clinical improvement. Do not rely on the patient's pupillary response or heart rate to determine the clinical endpoint of atropine administration. The patient's heart rate may be low, normal, or elevated during the exposure. Treat seizures with benzodiazepines at appropriate dosages. Intranasal midazolam may be a preferred route of administration, however, extensive nasal discharge may hinder its absorption. Poisonous plants and mushrooms. Poisonous plants. Of the thousands of plant species known, few are truly poisonous, that is, causing systemic toxicity. Indeed, many medicinals were originally derived from plants. Certainly, many varieties of plants can cause contact dermatitis. Similarly, ingestion of many other varieties of plants can cause gastroenteritis. Figure 36-14 shows some common Canadian plants that can cause toxicity. Of all the exposures resulting in calls to Ontario's Poison Centre, plants are one of the top 10 exposures in both adults and children. Table 36-4 lists plants that can cause toxic results and, in some cases, death. It is not expected that you should be able to identify the plant involved. Remember to attend to symptoms, and bring any remaining parts of the plant to the hospital with the patient. Several plants in the Auraceae family, including household varieties of Dieffenbachia, Caladium, and Philodendron, contain insoluble calcium oxalate crystals, or raphides. If chewed, these raphides cause a painful burning sensation in the mouth. This usually limits the exposure because of pain. However, chewing large amounts can cause edema of the upper airway. The leaves of rhubarb plants contain soluble calcium oxalate. Eating the leaves can lead to renal failure. This is not the case with the insoluble oxalates as found in the household plants. Chewing the pits of certain fruits, including apricots, choke cherries, and peaches, can result in a release of cyanide, because the amygdalin within them is activated by saliva. Swallowing the pits intact carries no risk. Similarly, one must chew the seeds of the black locust plant, which grows in certain parts of Canada, to release the toxalbumin within. This toxin is the same as that in a castor bean, from which the chemical warfare agent ricin is derived. Exposure to the toxalbumin causes a systemic illness that starts with gastroenteritis but, in days, leads to multiple organ failure. Many plants contain cardiac glycosides. The most familiar is foxglove, from which the cardiac inotropic digoxin is derived. Other plants, including monkshood and yew berries, contain other proarrhythmic toxins. Cardiac monitoring is essential in the event of exposure to large quantities of these plants. Some plants, such as the roots of water hemlock, contain central nervous system toxins that can cause seizures. Other plants are abused for their hallucinogenic properties. The seeds of the morning glory contain an LSD-like substance. All parts, but especially the seeds, of jimsonweed and deadly nightshade contain atropine-like toxins that lead to the anticholinergic toxidrome of dry mouth, dilated pupils, tachycardia, urinary retention, and hallucinations. Finally, all parts of the autumn crocus contain the medicinal, or toxin, if taken in large quantities, known as colchicine. This is an anti-metabolite used for the treatment of gout. Initial symptoms of overingestion include gastroenteritis. As white cell lines are depleted over time, infection and sepsis occurs. When you encounter a case of plant poisoning, get all the information you can from the patient or parent, and then consult your provincial poison center. What plant and plant parts were eaten? If seeds were ingested, were they chewed? When was the ingestion? What symptoms have developed? Most plant exposures are not toxic and do not require treatment beyond observation. The decision to allow a patient to remain at home should be made in consultation with direct medical control and the provincial poison center. Poisonous mushrooms. 3 groups of people are most likely to be the victims of poisoning related to mushroom ingestion: those that forage for their own mushrooms, those looking for hallucinogenic mushrooms, and young children who eat them accidentally. Even among educated people who like to gather their own mushrooms in the wild, mistakes can happen. A variety of factors determine whether a mushroom ingestion will produce toxic results: the age of the mushroom, the season in which it was gathered, the amount ingested, and the preparation method. Mushrooms are classified according to the toxins they produce. These classifications include cyclopeptides, amatoxins, gyrometrin, laurelinine, muscarine, muscimol, caprine, psilocybin, and gastrointestinal irritants. Toxic effects vary from mild gastrointestinal signs and symptoms to severe cytotoxic, even lethal, effects. In Canada, almost all deaths due to mushroom ingestion involve hepatotoxic mushrooms of the Amanita or Lepidoptera species. If the patient has ingested a single variety of mushroom, symptom onset can be a predictor of prognosis. Early onset of gastrointestinal complaints, within 2 hours of ingestion, is predictive of a benign exposure. Gastrointestinal complaints that occur greater than 6 hours following ingestion are more ominous. Many other manifestations of mushroom toxicity can occur, although, as with plants, most mushrooms are non-toxic. Some mushrooms cause seizures, others anticholinergic symptoms. Some are abused for their hallucinogenic properties. Rare varieties can cause renal failure. Management for the symptomatic patient following a mushroom ingestion includes the usual measures. Establish and maintain the airway, obtain vascular access, and consider fluid boluses for hypotension. Contact your local poison center and direct medical control for local protocols, and transport the patient to the hospital. Non-prescription pain medications. Acetaminophen. Acetaminophen is a well-tolerated pain-relieving drug. Tylenol is one brand name, with few adverse effects, and few drug interactions. It is available in many preparations on an over-the-counter basis. These characteristics have made this drug a popular analgesic. However, it is a common medication on which to overdose and has been responsible for a number of deaths. Its lethality may be secondary to the perception that acetaminophen is so safe and to the lack of awareness that acetaminophen may be one of many ingredients in many cough, cold, and analgesic preparations, so that inadvertent cumulative dosing occurs. A total dose of greater than 150 to 200 milligrams per kilogram can be toxic when taken acutely. Once ingested, regular release acetaminophen is rapidly absorbed from the gastrointestinal tract, producing peak serum levels in 30 to 120 minutes. Absorption slows when taken in combination with medications that slow gastric emptying, such as anticholinergics or narcotics, or when a slow-release preparation is taken. One unique aspect of acetaminophen overdose is that signs and symptoms can occur in 4 distinct phases. It is also possible that a potentially lethal amount may be taken, and the patient may have no symptoms initially. It is important to try to accurately estimate the time of ingestion, because this information drives the decision-making process for patient care in the pre-hospital environment and in the hospital. Although an antidote for acetaminophen, N-acetylcysteine, exists, its efficacy is greatest when given within 8 to 10 hours of the overdose. Typically, it is administered in the hospital based on laboratory results. As such, it is not a pre-hospital intervention. However, you may be asked to transfer a patient with potentially lethal acetaminophen ingestion to a higher level of care, and that patient may have an N-acetylcysteine infusion running. Treatment of the patient in the pre-hospital setting focuses on the airway. Give high-flow supplemental oxygen, and establish vascular access. Transport the patient to the hospital if it is established that the ingestion is of a toxic amount and/or the intention was of self-harm. Non-steroidal anti-inflammatory drugs. Medications used for pain management comprise a large part of the over-the-counter drug market. In the over-the-counter and prescription drug markets, non-steroidal anti-inflammatory drugs are some of the most popular options for pain relief, fever control, and anti-inflammatory action. Their convenient dosing schemes and large therapeutic windows, coupled with their safe track records relative to acute ingestion and overdose, enhance their popularity. Non-steroidal anti-inflammatory drugs are rapidly absorbed from the gastrointestinal tract before being eliminated from the body in urine and feces. The half-lives of these agents vary widely, ranging from 2 to 4 hours for ibuprofen to approximately 15 hours for selective cyclooxygenase 2 inhibitors to 50 hours for some long-acting agents. Patients who take lithium and non-steroidal anti-inflammatory drugs have slowed renal clearance of lithium, increasing the likelihood that they will inadvertently reach a toxic lithium level. Paramedics should also be aware that topical non-steroidal anti-inflammatory drug preparations are now available, with the same risk profile, and the oral preparations and the topical preparations should be accounted for when questioning a patient about their medications. Most of the problems associated with non-steroidal anti-inflammatory drugs involve long-term use. Patients may experience gastrointestinal bleeding and kidney dysfunction. Acute ingestions and symptomatic overdoses are rare. For symptomatic patients, pre-hospital care is usually supportive. For vomiting, give intravenous fluid boluses as necessary if hypotensive. For rare seizures, treat with benzodiazepines, as for any other seizure protocol. Transport the patient to a healthcare facility. A unique side effect of non-steroidal anti-inflammatory drug use is aseptic meningitis, in which a patient presents with complaints of a stiff neck, headache, and fever within several hours after taking a non-steroidal anti-inflammatory drug. Discontinuing the non-steroidal anti-inflammatory drug therapy generally resolves the problem, but patients must be evaluated at the hospital to rule out other causes. Salicylates. Aspirin, acetylsalicylic acid, products are almost ubiquitous in over-the-counter medications used for analgesia, fever control, liniments, cough, and cold preparations, and prevention of coronary heart disease, to name a few indications. For example, a single 30 ml dose of bismuth subsalicylate, Pepto-Bismol, contains 261 mg of salicylate, 2/3 the total dose of one aspirin. Similarly, many liniments contain high levels of methyl salicylate. 15 ml of 100% methyl salicylate contains 7,000 mg of salicylate equivalent. With continued use of these products alone or in combination for a period of days, one can be exposed to excessive amounts of salicylate. The clinical presentation of salicylate overdose can change based on 3 primary variables: the patient's age, the dose ingested, and the duration of the exposure. Ingestion of 150 mg per kilogram or less will usually result in mild toxicity, with chief complaints of nausea, vomiting, or abdominal pain. With a dosing range of 150 to 300 mg per kilogram, moderate toxicity results, with signs and symptoms including vomiting, diaphoresis, hyperpnea, ringing in the ears or tinnitus, and acid-base disturbances. At levels of 300 mg per kilogram, Severe toxicity may produce a combination of respiratory alkalosis and metabolic acidosis and pulmonary and cerebral edema. Chronic salicylate poisonings are probably the most often misdiagnosis in the confused older patient, and acute salicylate poisonings can be so severe they result in death. No salicylate antidote is available, so pre-hospital management is primarily supportive. Establish and maintain the airway, using an advanced airway as needed. Give high-flow supplemental oxygen, and establish vascular access. If hypotension develops from volume depletion, administer serial boluses of normal saline. Monitor end-tidal carbon dioxide levels with capnometry. Transport the patient to a medical facility. Urine alkalinization and dialysis might be instituted at the receiving hospital, depending on the severity of the intoxication in your patient. Household products. From a toxicologic perspective, the average home is full of dangerous substances. Many houseplants have poisonous leaves or berries. All pesticides and herbicides used in lawn and garden care are potentially poisonous. All hydrocarbon products, such as paint thinners, solvents, and gas, can cause permanent neurologic damage or death if inhaled in the right amount. The same is true of glue fumes, often called huffing. Many household cleaning agents are also toxic if ingested. It is not possible within the scope of this chapter to discuss all possibilities when it comes to household poisonings. Some of the more likely culprits are included here. As always, keep in mind that your provincial poison center is an invaluable resource. Caustics. Caustics include strong acids, pH less than 2.0, and strong alkalis, pH greater than 12.0. Both types of chemicals are commonly used in industry, agriculture, and hydrous ammonia, and the home. Most cases involve accidental dermal or ocular exposure, although occasionally you may encounter oral ingestions. The widespread practice of storing such substances in beverage containers, such as soft drink or sports drink bottles, increases the likelihood that a child will regard the substance as a tasty drink. As the liquid enters the mouth and begins to burn, the child may simultaneously remove the bottle and turn the head, resulting in burns to the mouth, tongue, and face. Caustic substances cause direct chemical injury to the tissues that they contact. Signs and symptoms of a caustic exposure can include severe pain, burns, difficulty talking, difficulty swallowing, with oral ingestions, and hypoperfusion or shock, rarely, usually secondary to internal bleeding. Most patients who have swallowed caustic substances present with severe pain in the mouth, throat, or chest. Respiratory distress can result, due to soft tissue swelling in the larynx, epiglottis, or vocal cords, which means that the patient is in immediate danger of complete airway obstruction. If the patient is alert and has just ingested the caustic agent, give a single glass of water or milk to the patient to drink to dilute the caustic. Never give a substance to neutralize because this will also result in a generation of heat, and thermal burns will complicate the situation. Never attempt to insert a gastric tube, as it can cause further damage to tissues. Establish vascular access, ideally en route, because immediate transport to the emergency department is indicated. With dermal exposure to a strong acid, the result is immediate and excruciating pain. For a strong alkali, the onset of pain is somewhat delayed, allowing more time before the patient reacts and increasing the severity of the burn. In such an injury, diluting and flushing away the caustic substance is the main goal of pre-hospital treatment. Acids tend to be more water-soluble than alkalis, so they are often diluted relatively quickly. With alkalis, it is more important to keep water continually flowing because it usually takes much longer to rinse an alkali away, compared with an acid. For an eye exposure, cut the prong section off a nasal cannula, place it on the bridge of the patient's nose, and plug in a macro-intravenous administration set and run it wide open to provide continuous irrigation. This also frees you up to perform other tasks. A Morgan lens may also be used after the initial gross flushing has been accomplished. One of the most common caustic exposures in the agricultural setting involves anhydrous ammonia. The exposure usually occurs during the hookup or disconnection of a nurse tank. Farmers often keep a small water bottle in the shirt pocket, allowing them to immediately rinse their eyes should an exposure occur. Without treatment, eye exposure to anhydrous ammonia can cause devastating damage in less than a minute, resulting in cataracts or blindness. Metals and metalloids. Many forms of metals exist. The inorganic forms of many are predominantly caustic. Symptoms include nausea, vomiting, hematemesis, diarrhea, and melena. Multi-organ manifestations occur later. Pre-hospital treatment is supportive, as always. Establish and maintain the airway. Give high-flow oxygen, and establish vascular access. Treat hypotension with fluid boluses and transport the patient to the hospital. Acute poisonings by metals and metalloids are relatively rare, except for that of iron. Iron. Pediatric iron ingestions have, in the past, been a major source of morbidity and mortality. Limiting the concentration of iron in preparations meant for children, and the numbers of doses in these containers, as well as child-resistant containers, have been important public health measures that have led to significantly decreased exposures in Canada. Although only a small amount of iron is required as part of a healthy diet, many adult and pediatric multivitamins contain iron. A small amount of iron is considered necessary for the normal functioning of the human body. As such, it is an essential mineral. In the average 70 kilograms adult, the entire iron supply is only 4 grams. This iron is bound to proteins in the form of hemoglobin, cytochromes, and myoglobin and is transported in the blood bound to transferrin. No iron is free, or unbound. Most iron is available in a balanced diet. However, supplemental iron is available in many pediatric and adult multivitamin preparations. When a toxic amount of iron is ingested, free iron is then available to damage target organs. For practical purposes, mild to moderate toxicity can occur with the ingestion of 20 to 60 milligrams per kilogram of elemental iron. Severe, potentially fatal, iron overdose symptoms occur with ingestions of greater than 60 milligrams per kilogram of elemental iron. Stages of iron poisoning have been described. Early symptoms are of gastrointestinal irritation with nausea, vomiting, hematemesis, and melena. Significant fluid losses can occur. Later systemic poisoning manifestations include cardiovascular collapse and hepatotoxicity. The mainstays of therapy are as for any other life-threatening illness. Assess and establish a definitive airway and ventilations as necessary, establish intravenous access, and give judicious boluses, 10 to 20 milliliters per kilogram, of normal saline for hypotension, perform a glucose check, and transport the patient to medical care. Hydrocarbons. Hydrocarbons are simple organic compounds made up of hydrogen and carbon atoms, with most, but not all, obtained from the distillation of petroleum. Hydrocarbons are found in a variety of products around the home, including cleaning and polishing agents, glues, spot removers, lighter fluids, paint thinners and paint removers, other fuels, and as the diluent in pesticides. Hydrocarbon inhalation. Most intentional hydrocarbon inhalations are recreational. The rich alveolar capillary network makes the lungs a highly efficient mechanism for providing a quick and inexpensive drug high. Unfortunately, long-term inhalant abuse can lead to permanent loss of mental function, as evidenced by a variety of neuropathies such as loss of hearing, loss of fine motor function, balance and equilibrium disorders, and occasionally death. The epidemic of inhalation began in the early 1960s, when the first reports of glue sniffing and its consequences appeared. Within a short time, the number of agents being inhaled to get high had increased exponentially, as had the techniques for inhalation. Simple sniffing over the opening of a glue bottle did not provide an intense enough exposure for serious abusers. Pouring the volatile material onto a rag, placing it in a plastic bag, and holding the bag over one's face to breathe in the fumes proved far more efficient, producing a more intense high more quickly. Inhaling fumes directly off a soaked rag or towel is termed huffing, and the use of a plastic bag is termed bagging or huffing. Table 36-7 lists commonly abused inhaled compounds. The primary goals when dealing with a patient who has inhaled hydrocarbons focus on removal from the noxious environment, giving high-concentration supplemental oxygen, and prompt transport to the appropriate facility. Hydrocarbon ingestion. Given the ready accessibility of hydrocarbons, and the high likelihood that they might be mistaken for potable beverages, it is not surprising that hydrocarbon poisonings are common among children younger than 5 years. The potential hazards of swallowing a given hydrocarbon are directly related to the viscosity of the agent. The lower the viscosity, the higher the risk of pulmonary aspiration and other complications. Most hydrocarbon ingestions do not produce lasting damage. Patients who develop symptoms within a few minutes of ingestion are likely to have aspirated and need immediate attention. Low viscosity hydrocarbons, such as kerosene, naphtha, and toluene, can easily enter the lungs during swallowing. If the patient reports coughing, choking, or vomiting immediately after swallowing the substance, assume that aspiration has occurred. Similarly, any signs of respiratory distress, air hunger, intercostal retractions, tachypnea, cyanosis, must be considered danger signals. Low viscosity also facilitates the uptake of a hydrocarbon by tissues of the central nervous system and, therefore, its anesthetic effects. At first, the patient may experience excitement and euphoria, followed by weakness, incoordination, drowsiness, confusion, and coma. Some petroleum products, notably gasoline, can produce hypoglycemia and cardiac dysrhythmias, so you should always monitor the patient's ECG rhythm. All symptomatic patients suspected of ingesting a hydrocarbon product, especially patients with respiratory symptoms, should be transported to an emergency department for further evaluation and care. Management should include the following measures. Remove contaminated clothing and decontaminate the patient, ideally before placing the patient in the ambulance. Establish and maintain the airway, and ensure adequate ventilation. Administer high-flow supplemental oxygen. Establish vascular access. Continuously monitor the ECG rhythm. Consider running a 12-lead ECG. Administer sequential bolus infusions of normal saline to treat hypotension. Transport the patient to the most appropriate facility. Toxic alcohols. The form of alcohol consumed by humans in alcoholic beverages is ethyl alcohol, or ethanol. It is not conventionally recognized as a poison, even though it has many properties of a poison when ingested in sufficient quantities. Instead, toxic alcohols, such as methyl alcohol and ethylene glycol, are generally considered alcohols manufactured for purposes other than ingestion, and are metabolized by the body to acids via the enzyme alcohol dehydrogenase. Ethylene glycol. Ethylene glycol is a colorless, odorless liquid found in a variety of commercial products, including antifreeze, coolants, de-icers, polishes, and paints. Because it has a slightly sweet taste, it may be ingested accidentally by children. The lethal dose of ethylene glycol is estimated at 2 milliliters per kilogram, or as little as 150 milliliters in the average-size adult. Ethylene glycol is very water-soluble. With oral intake, it is absorbed rapidly, with peak blood levels attained within 1 to 4 hours after ingestion. The liver and kidneys metabolize ethylene glycol into several toxic metabolites, including aldehydes, lactate, and oxalate. In turn, these metabolites produce metabolic acidosis. Metabolism of these toxins takes several hours. Toxic manifestations may not be evident for many hours after ingestion. Toxicity from ethylene glycol occurs in 3 stages, so the signs and symptoms vary depending on when you encounter the patient relative to the time of ingestion. Stage 1. Central nervous system depression is the hallmark of the initial stage. The patient may appear intoxicated, as evidenced by slurred speech and ataxia, without the obvious odor of alcohol present. These symptoms progress to include nausea, vomiting, seizures, or coma as metabolites begin to accumulate in the body. Stage 1 begins soon after ingestion and can last up to 12 hours. Stage 2. Cardiopulmonary symptoms begin to appear as the patient enters the second stage. The patient may exhibit hypertension, hypotension, or tachycardia. Pulmonary injury may present as pulmonary edema, pneumonitis, or acute respiratory distress syndrome. The patient may have hypocalcemia due to calcium oxalate precipitation. Stage may second develop between 12 and 24 hours after ingestion. Stage 3. Flank pain, anuria, and hematuria often characterize the third stage. The kidneys are injured, and acute renal failure may develop. Stage may third develop 24 to 72 hours after ingestion. Methyl alcohol. Methyl alcohol, also known as wood alcohol or methanol, is present in paints, paint remover, windshield washer fluids, varnishes, antifreeze, and canned fuels such as sterno. Methanol poisoning can occur after inadvertently drinking contaminated whiskey or moonshine. Methanol is commonly decanted into smaller containers, and can be accidentally ingested because of look-alike properties to sports drinks. Methanol is a popular substitute for ethanol when ethanol is not available. Methanol itself is not harmful. Rather, its metabolic breakdown products, formaldehyde and formic acid, are responsible for the characteristic signs and symptoms of methanol poisoning. A dose of as little as 30 milliliters, 2 tablespoons, can produce toxicity, and even death. Once ingested, methanol is quickly absorbed from the gastrointestinal tract, with peak blood levels attained within 30 to 90 minutes. In mild toxicity, the half-life of methanol is 14 to 20 hours. As toxicity increases, the half-life increases to 24 to 30 hours. The liver eliminates 90% to 95% of the methanol. The symptoms of methanol poisoning do not usually appear immediately, but begin from 12 to 18 hours, occasionally up to 72 hours, after ingestion. Consequently, the patient may not connect the symptoms to what he or she drank yesterday or several days ago. Patients report nausea and vomiting, in almost 50% of cases, headache or vertigo, abdominal pain, often from pancreatitis, and blurred vision, looks like a snowstorm, or, possibly, blindness. Physical examination findings may include altered mental status, ranging from drunken behavior to seizures or coma, dilated pupils with sluggish or no reaction, hyperpnea and tachypnea from metabolic acidosis, and bradycardia and hypotension, very late signs. Pre-hospital care. The treatment plan for a patient with suspected ethylene glycol or methanol poisoning is the same and is primarily supportive. Manage the airway, establish intravenous access, place the patient on a cardiac monitor, and promptly transport to an appropriate facility. The only potential difference between ethylene glycol and methanol is the possibly getting an order from medical control to administer 10 milliliters of 10% calcium gluconate via slow intravenous push to treat the hypocalcemia that accompanies ethylene glycol toxicity. This medication is usually ordered only after good urine flow is established, and after the intravenous line is flushed clear of sodium bicarbonate. After the patient arrives at the hospital, medical care focuses on correction of acidosis, administration of fomepizole or ethanol, and renal dialysis. Some paramedic systems, particularly those carrying out interfacility patient transports, may have treatment protocols for management of patients with toxic alcohol ingestions. The goal of treatment is to overwhelm or inhibit the alcohol dehydrogenase enzyme responsible for converting the alcohols to toxic metabolites. Ethanol infusions, mixed in a dextrose solution, can overwhelm the enzyme and prevent production of the toxic metabolites. The enzyme can also be inhibited by fomepizole, a drug that specifically inhibits alcohol dehydrogenase from breaking down the toxic alcohols. You should determine whether your local or regional protocols include specific treatment of toxic alcohol ingestions. Prescription medications. An exhaustive discussion of all prescription medications is beyond the scope of this chapter. Cardiac, oral hypoglycemic, and psychiatric medications will be highlighted. Ingestion of the former two medications can be potentially lethal in small amounts, because many such drugs have narrow therapeutic indices. The latter is discussed because of the frequency with which overdoses occur with these medications. Cardiac medications. The medications used to treat patients with cardiac and cardiac-related problems continue to increase in number and sophistication. The major classes of drugs used as part of these treatment regimens include antiarrhythmics, beta blockers, calcium channel blockers, and cardiac glycosides. Many patients take a combination of drugs, sometimes 3 or more, in attempts to control hypertension, ECG rhythm disturbances, or other problems. Overdose with these medications leads to the slow and low tox syndrome. Most commonly these patients are bradycardic and hypotensive. Other signs and symptoms of overdose may include weakness or confusion, nausea and vomiting, headache, and dyspnea. Work to minimize the negative effects of the overdose while determining if an antidote is available. As with all emergencies, ensure a patent airway, provide adequate ventilation, and administer high-flow supplemental oxygen. Establish vascular access in case of overdose with these agents, because several therapeutic interventions and antidotes are available if the specific agent is identified. For hypotension, a fluid bolus is recommended first, as always. Atropine may be beneficial for a digoxin overdose that presents with bradycardia. Calcium gluconate may be of benefit for hypotension due to calcium channel blocker. For both beta blocker and calcium channel toxicity, high-dose insulin euglycemia is now recommended. Glucagon is now controversial, because it can make hypotension worse. Among the most problematic cardiac medications in propensity to reach toxic levels are the cardiac glycosides, such as digoxin, which typically have very small therapeutic windows. For an overdose with these agents, digoxin immune Fab fragments are the antidote of choice. Antiarrhythmics of the sodium channel blocking family may respond to sodium bicarbonate intravenous boluses in the adult patient. Because of the complexity of cardiac drugs, and the likelihood that the patient may be taking multiple cardiac and other medications, making contact with direct medical control to consult with a physician is prudent. Psychiatric medications. Lithium. Despite the major advances made in many areas of psychiatric medicine, lithium remains the cornerstone drug for the treatment of bipolar disorder. In 1949, lithium salts made their debut for the treatment of mania. Eventually, they were found to be much more efficacious for the treatment of bipolar disorder, and they retain their position as first-line treatment for this condition. Lithium is almost completely absorbed in the gastrointestinal tract roughly 8 hours after ingestion. Bioelimination occurs relatively slowly, with approximately 95% of the lithium eliminated in the urine, although 2/3 of the lithium dose is excreted within 12 hours after ingestion, the remainder is excreted during the next 2 weeks. Early signs and symptoms of lithium overdose include nausea, vomiting, hand tremors, excessive thirst, and slurred speech. Increased toxicity results in neurologic symptoms, ataxia, muscle weakness and incoordination, blurred vision, and hyperreflexia, twitching. Eventually, the patient may have seizures, and become comatose. Pre-hospital management of a patient suspected of a lithium overdose is mostly supportive. Establish and maintain the airway, inserting an advanced airway as needed. Give high-flow supplemental oxygen, and ensure vascular access. If the patient experiences hypotension, administer serial boluses of normal saline. Adequate hydration will improve lithium excretion. Maintain continuous ECG monitoring, being alert for atrioventricular blocks and ventricular dysrhythmias. Finally, transport the patient to a healthcare facility. In some cases, dialysis may be indicated to enhance the elimination of lithium. Selective serotonin reuptake inhibitors. Selective serotonin reuptake inhibitors have a far greater margin of safety than do many other antidepressants. Selective serotonin reuptake inhibitors work by enhancing serotonergic neurotransmission and inhibiting the breakdown of serotonin. Selective serotonin reuptake inhibitors have few cardiac effects or anticholinergic effects, so they are a safer option for the management of depression compared to tricyclic antidepressants. However, some selective serotonin reuptake inhibitors or other atypical antidepressants may cause seizures even in therapeutic doses. Popular selective serotonin reuptake inhibitors include fluoxetine, Prozac, paroxetine, Paxil, citalopram, Celexa, and sertraline, Zoloft. As many as 50% of adult patients may be asymptomatic within selective serotonin reuptake inhibitors overdose. When selective serotonin reuptake inhibitors are taken in conjunction with alcohol, look for tachycardia, mild hypotension, and lethargy as the most common signs and symptoms. Other symptoms include nausea, vomiting, and tremors. Dilated pupils, agitation, hypotension, or hypertension, seizures, and hallucinations may be less commonly noted. Dysrhythmias are also rare but may include QT prolongation and torsades de pointes. Pre-hospital treatment is supportive and includes the following. Establish and maintain the airway. Administer supplemental oxygen to maintain saturation levels greater than 94%. Establish vascular access. Provide continuous ECG monitoring. Treat seizure activity with benzodiazepines per local or regional protocol. Should QRS widening occur, consult with medical control for consideration of sodium bicarbonate administration. Transport to the appropriate facility. Serotonin syndrome is an idiosyncratic complication that occasionally occurs with antidepressant therapy. This condition is not limited to patients taking selective serotonin reuptake inhibitors, but also can occur when patients take any combination of drugs that increase central serotonin neurotransmission. Drugs that can cause serotonin syndrome include monoamine oxidase inhibitors, selective serotonin reuptake inhibitors, tricyclic antidepressants, lithium, stimulants, and opioids. The onset of serotonin syndrome is usually within 6 hours of ingestion, possibly the result of a change in dosing of the culprit medication. Because a diagnostic laboratory test for serotonin syndrome is not available and the symptomatology is vague at best, the ultimate diagnosis is based on clinical suspicion after other psychiatric or medical causes have been ruled out. The syndrome is characterized by vasomotor instability, that is, fever, diaphoresis, hypotension, or hypertension, tachycardia, mental status changes, and musculoskeletal abnormalities, especially tremulousness. Rigidity has been described as well. Pre-hospital management is supportive, and cooling should be considered if the patient is hyperthermic. Tricyclic antidepressants. In the past, tricyclic antidepressants were the drugs of choice to treat depression. Since the introduction of the safer selective serotonin reuptake inhibitors, fewer patients take tricyclic antidepressants for depression, although the tricyclic antidepressants are finding other therapeutic indications such as neuropathic pain and enuresis. Common tricyclic antidepressants include amitriptyline, nortriptyline, doxepin, clomipramine, and trimipramine. Tricyclic antidepressants are absorbed by the body within the first couple of hours after ingestion, and they easily cross the blood-brain barrier. They work as norepinephrine and serotonin reuptake inhibitors. Overdose can cause sympathomimetic and serotonergic effects. Tricyclic antidepressants affect many different neurotransmitters. In low doses, tricyclic antidepressants are anticholinergics, causing dilated pupils, and blurred vision, dry mouth, dry skin, fever, urinary retention, confusion and hallucinations, and sinus tachycardia. At higher doses, they have some sympathomimetic effects but eventually lead to depletion of noradrenaline. This contributes first to sinus tachycardia, and then to bradycardia and hypotension. Tricyclics can stimulate gamma-aminobutyric acid receptors and cause a decreased level of consciousness. Finally, and most dangerous, in high doses, tricyclic antidepressants cause membrane or sodium channel blocking effects, leading to a widened QRS and ventricular dysrhythmias and seizures. These manifestations may be precipitous. At one moment, the patient is somewhat drowsy but otherwise vital signs stable. the next moment the patient is seizing or arresting. Pre-hospital management of patients with a suspected tricyclic antidepressant overdose includes the following. Maintain the airway. If the patient's mental status suddenly deteriorates, as is often the case, insert an advanced airway. Administer supplemental oxygen to maintain saturation levels greater than 94%. Establish vascular access. Provide continuous ECG monitoring. Watch for widening of the QRS. Consult with direct medical control to consider sodium bicarbonate administration, if the QRS is widened. Treat hypotension with sequential boluses of normal saline. Assess blood glucose levels. Give 50% dextrose in water if the patient is hypoglycemic. Rule out head trauma as a possible cause of decreased mental status. Seizures require rapid control with benzodiazepines and/or intubation and paralysis. Cardiac dysrhythmias often follow. Be alert for agitation or violence. Provide reassurance and administer benzodiazepines, if needed. Do not give flumazenil, may cause seizures, or physostigmine. Transport to the nearest appropriate facility. Oral hypoglycemics. Adult onset, or type 2, diabetes is treated with a variety of oral medications that act in different ways to achieve glucose control. Those that act to increase insulin release from the pancreas will cause symptomatic hypoglycemia, and generally have a prolonged duration of action. These include the sulfonylureas and meglitinides. If a toddler ingested a single tablet of either of these two classifications of oral hypoglycemics, death from hypoglycemia could result. The standard treatment of symptomatic hypoglycemia includes intravenous access, administration of exogenous dextrose, and monitoring until delivery of the patient at the medical facility. In the hospital, an antidote, octreotide, exists to limit the recurrence of hypoglycemia. Environmental toxins. Bites and stings. Injected poisons usually gain access to the body as the result of stings or bites from a variety of creatures. This section considers the ill effects that may result from unfriendly encounters with creatures from the land, air, and sea. Arthropod bites and stings. If sheer numbers were the sole criterion determining such things, arthropods would rule the world. The phylum Arthropoda includes at least 1.5 million species of joint-footed animals, ranging from the lobster to the mite. The classes of arthropods of most medical importance, because of their ability to inject venom, are the arachnids, including spiders, scorpions, and ticks, Chilopoda, centipedes, and insects, including the Hymenoptera. Scorpion stings. Scorpions are not native to Canada, although, as with other exotic creatures, it is possible for envenomations to occur when these animals are imported into Canada as unexpected passengers in personal luggage from the Caribbean or Mexico, or as hitchhikers on produce from endemic countries. Usually pain relief is the issue. Contact your provincial poison center for specific management guidelines. Spider bites. There are an estimated 34,000 species of spiders worldwide. Most spiders are carnivores, can bite. They normally use their venom to subdue their prey. The amount of venom injected into a human, proportional to the body size of a human, is usually inconsequential. No spiders native to Canada have venom potent enough to cause medical illness. This is not to say that occasionally an allergic manifestation or local wound infection might not develop. As well, there are incidences where medically significant spiders from other countries arrive in Canada in shipments of imported produce or furniture. A discussion of all venomous spiders in the world is beyond the scope of this text. Pre-hospital care of a spider bite includes attention to the airway and breathing, giving high-flow oxygen as needed, and establishing intravenous access. If there is no evidence of allergic or anaphylactic manifestations, analgesia may be necessary because some bites from exotic spiders are extremely painful. Death, even from bites of extremely potent exotic spiders, is not instantaneous, and often results as a complication of initial manifestations. Transport the patient to the hospital for a medical assessment. Tick bites. Ticks are blood-sucking arthropods found around the world, often in rural, wooded areas. Ordinarily, tick bites are not a medical emergency, but they are of concern because ticks serve as disease vectors. Bacteria, viruses, and protozoa can be transmitted via a tick bite, and they are linked to a variety of serious illnesses. With the exception of Lyme disease, these are uncommonly seen in Canada. In the unlikely event that you are called to a patient with a tick bite, the principal treatment is careful removal of the tick. Ticks attach themselves tenaciously to their hosts using their mouth parts, and a cement-like adhesive. If you try to pull the tick away from the skin, the mouth parts may remain embedded. To remove the tick, after putting on gloves, use curved forceps to grasp the tick by the head as close to the skin as possible and pull straight upward using steady gentle traction. Use even pressure as you pull and avoid twisting or jerking the tick. Do not squeeze or crush the tick's body. Dispose of the tick in a container of alcohol. Once you have removed the tick, wash the area around the bite with soap and water. You do not need to transport the patient if he or she remains asymptomatic. In case of tick paralysis, transport the patient with spinal motion restriction to an appropriate facility. Hymenoptera stings. The Hymenoptera family of insects includes bees, wasps, hornets, yellow jackets, and ants. Collectively, they kill more people each year than any other venomous animals, including snakes. Death from a Hymenoptera sting usually occurs from anaphylaxis, which is covered in detail in Chapter 33. The diagnosis of a bee sting is usually not difficult. Indeed, in most cases, the patient will have already made the diagnosis. There is almost always an immediate local reaction consisting of pain, sometimes extreme, redness and swelling, and sometimes itching at the site of the sting. Honeybees sting once, usually leaving the barbed stinger and the venom sac attached to the patient's skin. By comparison, wasps, hornets, yellow jackets, and fire ants can sting repeatedly until they are chased away or the patient is removed. If the patient has no history of allergy to bee stings, and does not have a systemic reaction, transport to the hospital is usually unnecessary. When this decision is made, advise the patient of the warning signs of anaphylaxis, and the urgency of calling 911 in such an event. Instruct the patient to have the wound checked by a doctor if it does not improve markedly within 24 hours. Bee stings, especially those to the extremities, often become infected and require antibiotic treatment. Treatment of a Hymenoptera sting focuses primarily on pain relief and minimization of the risk of infection. First, determine whether the stinger and venom sac are still attached to the skin. If so, use a scalpel blade to gently scrape the stinger and venom sac from the wound. Do not try to pluck the stinger out with tweezers or forceps. If you squeeze the stinger or the venom sac, you will pump more venom into the wound. After removing the stinger, clean the wound thoroughly with soap and water or an antiseptic solution. Apply cold packs to the site for pain relief. Snake bites. Although venomous snakes cause an estimated 3 million bites and 150,000 deaths worldwide each year, as there are only 3 species of such snakes in Canada, a snake bite from a native species is a rare poisoning. As mentioned earlier, exotic pets are found in every part of Canada, where enthusiasts may have venomous snakes in their personal collections. As envenomations are singularly uncommon, a call to the Provincial Poison Centre should be made whenever encountering such a patient. Pit vipers. The 3 species of venomous snakes native to Canada are all of the crotalid family, or pit vipers. The heads of all Canadian pit vipers are triangular, resembling an arrowhead. Just beneath the eyes on either side is an indentation or pit, which is a heat-sensing organ that helps the snake locate its prey. North American pit vipers also have vertical pupils, most other snakes have round pupils. These physical characteristics cannot be assumed to be similar to those of exotic snakes. Their long, erectile fangs are used to puncture the skin, leaving a distinctive mark. Pit vipers are not naturally aggressive, but will attack in self-defense or when surprised, such as when a hiker accidentally steps on a snake. A variable amount of venom, ranging from no venom to a potentially lethal dose, might be injected. This venom is composed of a mixture of metalloenzymes that cause local tissue damage, hemolysis, increased permeability of the vasculature, coagulopathy, and neuromuscular dysfunction. 1 of every 4 pit viper bites is dry, that is, no venom is injected. This determination cannot be made in the pre-hospital setting. Even without envenomation, the most common initial symptoms are fang marks and localized pain. Signs and symptoms of envenomation include a metallic taste in the mouth, nausea and vomiting, tachycardia, hypotension, tachypnea, and edema developing around the area of the bite. Pre-hospital care of the bitten patient includes attention to the airway, breathing, and circulation, as with any patient. Give high-flow supplemental oxygen, establish vascular access, and give a fluid bolus of normal saline if the patient is hypotensive. Keep the patient calm, supine, and motionless to decrease venom spread and absorption. Immobilize the extremity with the bite in a neutral position. Do not apply constricting bands. Do not apply ice. Finally, begin immediate transport to a medical facility. Antivenom does exist for the treatment of crotolid bites when envenomation has occurred. Chapter 34. Gastrointestinal Emergencies. Introduction. Gastrointestinal problems are rarely life-threatening. This fact does not minimize the systemic problems that can erupt from untreated or undertreated diseases of the gastrointestinal system. The appendix, a small, inconsequential portion of the intestine, has no known function, and its removal places the patient at no great health risk. Yet, if this dangling outcropping becomes infected, the consequences can be deadly. Almost everyone has experienced abdominal pain at some point. Pain, diarrhea, nausea, and vomiting are common symptoms, but they should be regarded as signs and symptoms of an underlying condition. These symptoms can cause a wide range of conditions. Gastrointestinal disorders are common, as indicated by the data in Table 34-1. For example, it is estimated that 10% to 20% of people in Canada have symptoms of gastroesophageal reflux disease. Patients may have risk factors that can predispose them to gastrointestinal disorders. Elements of a patient's history, such as age, previous illnesses or surgery, family history, medications, and use of cigarettes, alcohol, and illicit drugs may provide important clues to the etiology of a patient's symptoms. For example, alcohol consumption and smoking increase a person's risk for developing stomach disorders. Smoking can increase gastric acid secretion, and alcohol can help break down the gastric mucosal barrier to acid, putting the individual at risk for peptic ulcers within the upper gastrointestinal tract. Table 34-2 lists other activities that place patients at increased risk. Many people incorrectly believe that spicy foods can cause problems of the esophagus and stomach, but this is not known to be a risk factor for gastrointestinal disease. Anatomy and physiology. Examining the journey from food intake to elimination will illuminate the normal anatomy and physiology related to the gastrointestinal system. Here is an example. It is dinner time, and Miranda is enjoying one of her favorite meals, a garden salad with lettuce, tomatoes, cucumbers, raisins, peanuts, croutons, carrots, and shrimp with ranch dressing. In anticipation of eating, the salivary glands produce saliva, which contains water and mucus. Saliva helps to lubricate the food during chewing and swallowing. Miranda takes a bite of her salad. The lettuce, carrots, and cucumbers feel cool and crisp in her mouth, and this pleasant sensation encourages her to chew, a process called mastication. Miranda's front teeth are mainly used to tear or cut the food. At the back of her mouth, her molars pound and grind the food into a more easily swallowed consistency. This mechanical activity prepares food to travel down the esophagus and prevents aspiration. As food is propelled to the back of the mouth by the tongue, it triggers a swallowing reflex. Saliva also contains enzymes that begin the chemical breakdown of foods, in particular, starches. These complex carbohydrates can be disassembled into simple sugars that are more easily absorbed. In addition, some initial breakdown of triglycerides occurs. Now Miranda prepares to swallow. The swallowing process is actually a complex, coordinated reflex that is mediated by a group of neurons in the brainstem. The proximal esophagus is located at the posterior portion of the hypopharynx. This muscular tube is typically collapsed, that is, closed in on itself, which allows for air to easily flow into the lungs but not into the stomach. The proximal esophagus rises and opens to receive the food bolus, while the glottis closes to prevent aspiration. This collapsed tube idea also explains how gastric dilation and impairment of lung expansion can occur during ventilation. If a person needs positive pressure ventilation, bag mask ventilation can push air into the lungs. If the pressure of the breath is too high, then the esophagus dilates. Air then follows the path of least resistance. Given the choice between moving through a large tube into a large open space, the stomach, or moving down a series of progressively smaller tubes, the trachea into the right or left mainstem bronchus, air will flow into the stomach. This causes gastric distension, which can impede lung expansion and cause regurgitation. As Miranda swallows, a sequential series of muscle contractions propels the food toward the stomach. Although the esophagus is normally collapsed at rest, swallowing, reflux, and forceful ventilation with a bag mask device can all open this muscular organ. As the food moves more distally, the esophagus contains its own neurons that mediate sequential contractions, known as peristalsis, that propel the food bolus toward the stomach without involvement of the brainstem. As the food bolus nears the lower esophageal sphincter, this muscular segment relaxes to admit the food to the stomach. Some acid may be reflexed at this point. Saliva also contains a small amount of bicarbonate ions, which can neutralize small amounts of reflexed acid. Intertwined around the esophagus are veins that drain into an even more complex series of veins, which ultimately join together to form the portal vein. The portal vein transports venous blood from the gastrointestinal tract directly to the liver for processing of the nutrients that have been absorbed. If blood flow through the liver slows for any reason, the blood may back up throughout the entire gastrointestinal system because this series of veins lacks any valves. The veins surrounding the stomach and esophagus then become dilated. Even a low amount of pressure can cause leaking or rupture of these vessels. The esophagus does not absorb nutrients, but rather pushes the food along using rhythmic peristaltic contractions. The food travels in the esophagus past the diaphragm, and comes to a sphincter located at the junction of the esophagus and the stomach. The cardiac sphincter, which earns its name because people who have regurgitation of acid out of their stomach into their esophagus often feel they're having a heart attack, controls the amount of food that moves back up the esophagus. When empty, the stomach is rather small, but it is capable of stretching many times beyond its normal size to accommodate meals. As the food enters this muscular organ, the stomach begins to secrete hydrochloric acid and pepsin, which help to break down the food. To mix the acid with the food more evenly, the stomach also contracts, churning the acid and food mixture together until a relatively smooth consistency is achieved. The material that exits the pyloric sphincter, the muscular valve at the inferior portion of the stomach, is called chyme. Miranda eats a fairly large helping of salad. This is far too much food for the duodenum, the portion of the small intestine that will begin the very active stage of absorption. The stomach is designed to release only small amounts of the food into the duodenum, thereby enabling the small intestine to better manage digestion. The stomach absorbs some materials, such as water, and fat-soluble substances, for example alcohol. If Miranda decided to have a glass of wine with her meal, the absorption of the alcohol would begin, slowly, within the stomach. Alcohol is absorbed rapidly within the duodenum. The longer the alcohol remains within the stomach, the slower the rate of its absorption into the bloodstream. Drinking alcohol with a fatty meal will delay gastric emptying, as the stomach works to digest the difficult fats. Miranda's meal is relatively low in fats, however, so she will feel the effects of the alcohol relatively quickly. The real purpose of the digestive system is revealed in the next portion of the gastrointestinal system. Why is Miranda eating in the first place? As the levels of nutrients available to her cells begin to drop, she feels hungry. She eats to replenish her resources, keeping her cells supplied with proteins, sugars, fats, electrolytes, and vitamins. The main function of the gastrointestinal system is to absorb these resources for use by other cells in the body. The duodenum is the first part of the small intestine. It is where the pancreas, liver, and gallbladder connect to the digestive system. The exocrine portion of the pancreas secretes several enzymes into the duodenum that assist with digestion of fats, proteins, and carbohydrates. In addition, pancreatic juice contains bicarbonate, which helps to neutralize gastric acids. The liver creates bile, which is then stored in the gallbladder. Bile contains chemicals similar to detergents, which are used by the body to help break down fats into microscopic droplets that are small enough to be absorbed. Miranda's salad included shrimp and ranch dressing, both of which contain fat that must be broken down before it can be absorbed into the bloodstream. Bile is released into the duodenum, where it helps to emulsify, that is, dissolve into solution, the fats. The liver receives blood with all the absorbed nutrients through the portal vein, and is responsible for a large part of the body's carbohydrate metabolism and storage. The liver also affects the gastrointestinal system indirectly, through carbohydrate metabolism. The brain cells can burn only one fuel source, glucose. If blood sugar falls, the liver can convert its glycogen stores into glucose. Dramatic decreases in sugar stores will cause the liver to convert fats and proteins into sugar. As blood flows through the liver, fat and protein metabolism continues. Without a functioning liver, Miranda would soon die, because she would not be able to use any of the proteins that were absorbed from the gastrointestinal system. In addition, the liver detoxifies medications, completes the breakdown of dead white blood cells, and the heme component of dead red blood cells, and stores some vitamins and minerals. The real absorptive workhorse of the digestive system is the small intestine. 90% of all nutrient absorption occurs there. This 7-meter-long structure is divided into 3 sections, the duodenum, the jejunum, and the ileum. The small intestine produces additional enzymes that work with the pancreatic enzymes and bile to turn chyme into smaller molecules that can be absorbed by the capillaries of the small intestine, and move into the bloodstream. Blood loaded with nutrients exits the intestinal circulation and heads to the liver, where additional metabolism of fats and proteins takes place. The blood then leaves the liver, and enters the systemic circulation. The water-soluble vitamins from the tomatoes and cucumbers in Miranda's salad are absorbed into the bloodstream for use by cells. The large intestine, or colon, is the next destination for the remnants of the salad. The substance that arrives in this 2-meter-long structure is no longer called chyme, but feces. The valve between the ileum and the first portion of the large intestine is called the ileocecal valve. The first portion of the large intestine, in the right lower quadrant, is called the cecum. The appendix, a blind, worm-like pouch leading off the cecum, can contain small amounts of fecal matter. Occasionally, the appendix becomes impacted with material or infected and can become inflamed, resulting in appendicitis. Rising up from the cecum is the ascending colon. It is continuous with the transverse colon, which runs from right to left. After another 90-degree turn, it becomes the descending colon. In the left lower quadrant, the colon then takes an S-turn, where it is referred to as the sigmoid colon, which aligns its most inferior portion in the center of the abdomen. The sigmoid colon continues as the rectum, the last portion of the colon. The colon terminates at a sphincter called the anus, where feces are expelled from the body. The primary role of the large intestine is to complete the reabsorption of water. Although the majority of water is reabsorbed in the small intestine, the osmotic function within the colon helps to solidify the digested material into a formed stool. Excess fluid secretion in the intestine or failure of this portion of the bowel can lead to a soft stool, or diarrhea. The colon is also the site of bacterial digestion. Bacteria normally found within the colon help to finish the breakdown of chyme. This breakdown produces gas as a byproduct. Flatulence may be considered impolite, but it is certainly normal. Loss of normal bacterial flora can lead to diarrhea or overgrowth of pathogenic bacteria such as Clostridium difficile. Table 34-3 summarizes the organs involved in digestion. The entire digestion process takes 8 to 72 hours. At this pace, bowel movements range from 3 movements per day to 1 movement every 3 days. Of course, this number varies based on the types of food eaten, the amount of water consumed, exercise, and stress. General approach to gastrointestinal diseases. Diseases of the gastrointestinal tract present with certain common symptoms. The most common symptoms are pain, fluid losses, vomiting and/or diarrhea, bleeding, and alterations in bowel habits. Less common symptoms relate to alterations of liver or pancreatic function, such as jaundice or malabsorption. Taking a brief, but appropriate, history, conducting a focused physical examination, and deciding on appropriate pre-hospital interventions are key in dealing with a patient presenting with gastrointestinal disease. Abdominal pain. Abdominal pain can be a nonspecific indicator of gastrointestinal disease, although certain characteristics of the pain can provide important clues to the underlying etiology. In addition, organs that are not part of the gastrointestinal tract can also cause abdominal pain. You should consider whether the patient's pain could relate to non-gastrointestinal organs, such as the aorta, urinary tract, or reproductive system. As with all types of pain, obtaining a good patient history includes defining the nature and time course of the pain's location, aggravating and relieving factors, and associated symptoms. The internal organs of the gastrointestinal tract are poorly innervated for conscious sensation, thus, the patient may initially have poorly localized abdominal pain. This is typical of visceral sensations, which are carried through neurons of the autonomic nervous system. Associated symptoms such as fever, nausea, vomiting, or alterations of bowel function, either constipation or diarrhea, may provide additional clues as to the source of the pain. Sometimes visceral pain arising from a muscular organ such as the bowel or gallbladder will wax and wane with contractions of the organ. Referred pain is pain that is distant to the site of the problem, usually because of the way in which the body's autonomic nervous system has pain nerves arising from a large area. For example, pain radiating to a shoulder may herald a problem with an organ close to the diaphragm, such as the gallbladder, which shares innervation with the shoulder. Pain in the back sometimes arises from retroperitoneal organs, such as the kidneys, aorta, and pancreas. As the disease progresses, it may cause irritation of the peritoneal lining close to the organ. The parietal peritoneum is richly innervated, thus, the development of well-localized, somatic pain may point to the source of the problem. This typical progression sometimes occurs in appendicitis, which can start as pain in the umbilical region, and then become localized to the right lower quadrant. Perforation of an organ of the gastrointestinal tract can occur as the result of obstruction or an inflammatory process, such as an ulcer. With a perforation, the bowel contents spill into the peritoneal cavity, and irritate the nerves of the peritoneal lining. The generalized abdominal pain that ensues, along with reflex contraction of the abdominal wall muscles, is referred to as peritonitis. Peritonitis can also result from the irritating effect of bleeding into the peritoneal cavity. The presence of bacteria-laden fecal contents into the peritoneal cavity is also associated with the development of fever and, sometimes, septic shock. This can be seen in patients who develop a perforation as a complication of appendicitis. Fluid losses. Dehydration may result from vomiting, diarrhea, poor oral intake, or malabsorption of water in the large intestine. As the patient loses fluid, the body continues to shift water from the interstitial fluid to the vascular space, and from the intracellular space to the interstitial space in an attempt to maintain vascular volume for perfusion of organs. A patient may initially present with normal vital signs and thirst. Progressive dehydration can lead to tachycardia. The development of hypotension heralds severe dehydration because the patient is no longer capable of mobilizing fluid into the vascular space. Electrolyte balance is also affected by gastrointestinal fluid losses. Both vomiting and diarrhea are known to deplete potassium. Depending on how much sodium is lost, dehydration can also result in low or high sodium levels. Table 34-4 summarizes the effects of electrolyte imbalances. Depending on the speed at which these losses occur, symptoms may range from mild to severe and life-threatening. Gastrointestinal bleeding. Hypovolemia may also be a consequence of hemorrhage. The gastrointestinal tract's generous blood supply helps to ensure that nutrients can be absorbed rapidly, but it also makes it more vulnerable to severe hemorrhage. The location of the hemorrhage can sometimes be ascertained from the nature of the bleeding. Upper gastrointestinal bleeding in the esophagus or stomach will sometimes present with vomiting of blood or material that resembles coffee grounds. This latter material represents blood originating in the upper gastrointestinal tract that has been transformed by passage through the gastrointestinal tract. Rectal blood loss may take the form of obvious bleeding or a black, tarry material called melena. This latter material represents blood after it is transformed by passage through the gastrointestinal tract. Finally, some blood loss is termed occult, because it is only determined by fecal testing, and is not obvious to the patient or healthcare professional. Obvious blood loss through the rectum can result from either a lower gastrointestinal bleed or a particularly brisk upper gastrointestinal bleed. Most bleeding from the rectum results from erosion of blood vessels near the surface of the mucosa. This sometimes occurs in peptic ulcers, diverticular disease, or cancer. Other causes of bleeding arise from severe inflammation of the gastrointestinal tract. For example, patients with inflammatory diseases of the bowel such as Crohn's disease or ulcerative colitis may develop bleeding ulcers of the intestines. These patients will usually report other symptoms, such as pain and fever, in addition to bloody diarrhea. Trauma is an obvious but rarely seen mechanism for bleeding from within the gastrointestinal system. Common causes of gastrointestinal bleeding are listed in Table 34-5. Because the blood loss from the gastrointestinal tract cannot be controlled by the application of pressure, gastrointestinal bleeding can sometimes be fatal. With either severe diarrhea or hemorrhage, the patient may experience shock. The body compensates for shock by releasing catecholamines, as discussed in Chapter 21, Bleeding and Shock. In an effort to maintain blood pressure, these neurotransmitters increase the heart rate, strengthen the force of contractions of the heart, and increase vasoconstriction. During compensated shock, organ perfusion and blood pressure remain near normal. Signs of compensated shock may include tachycardia, and pale, cool, clammy skin as the body shunts blood away from the skin and muscles. The pulse pressure narrows, because epinephrine causes vasoconstriction, and respirations increase. As shock progresses, compensatory mechanisms begin to fail. The blood pressure may drop, and there may be ominous signs of loss of end organ perfusion, such as changes in mental status, and decreased urine output. Altered bowel habit. Although food contains a variety of bacteria, viruses, and fungi, most of these are destroyed through cooking or pasteurization of food. The organisms that remain are usually killed by stomach acid and digestive juices. However, small amounts of organisms sometimes get past the immune system's defenses, which can lead to gastrointestinal infection. In the majority of affected patients, gastrointestinal infections often present with diarrhea and/or vomiting. In Canada, an estimated 11 to 13 million people contract illnesses caused by foodborne bacteria each year. In as many as 3% of cases, foodborne illness results in chronic health problems such as chronic arthritis and kidney failure. People who are immunocompromised, for example patients who have acquired immunodeficiency syndrome or certain types of cancers, patients who are undergoing chemotherapy, and transplant recipients, the very old, and the very young generally have a harder time fighting off an infection of any type, and are more likely to have a poor outcome from foodborne illness. Traveling to other countries can also place a person at greater risk for food intolerances or foodborne infections. The incidence of travelers' diarrhea for people who travel to high-risk regions for up to 2 weeks ranges from 20% to 90%. As many as 10% will experience persistent diarrhea or other complications. The opposite change in bowel habit, decreased stool frequency, can result from constipation or bowel obstruction. Constipation is a common complaint, and sometimes results in calls to emergency medical services when it is associated with severe pain or discomfort. Constipation may result from changes to medications, use of opioids, or immobility or lack of physical activity, sometimes seen in the bedridden elderly, and may be acute or chronic. The longer the stool remains in the colon, the harder it becomes as the colon works to reabsorb water. Despite the discomfort, these patients rarely experience vomiting, and are still able to pass flatus. Bowel obstruction occurs when there is failure of peristalsis due to diseases of the bowel, systemic illness, medications, or mechanical blockage of passage of material through the intestine. The most common reason is when the intestines, which are normally free to move or slide internally in the peritoneal cavity, become twisted or entrapped. This can occur in patients who have scar tissue from previous surgery or hernias. Volvulus is a complete twisting of the bowel on itself. Finally, cancers may cause narrowing or complete blockage of the lumen of the intestine. Bowel obstructions present with crampy, poorly localized abdominal pain, absence of stool and flatus, and sometimes vomiting. Altered organ function. Symptoms attributable to the liver can sometimes result in right upper quadrant pain. More often, it is difficult to distinguish organ involvement without specific testing or imaging unless there are specific signs of failure of the involved organ. Patients with liver failure, once it reaches an advanced stage, may develop yellow skin and sclerosis from jaundice. Other signs and symptoms of advanced liver failure include altered mental status, from the buildup of bilirubin, ammonia, and other toxins, and itchy skin. A distended abdomen may be the result of cirrhosis, which causes blood to back up in the gastrointestinal organs and fluid to accumulate in the abdomen. The pancreas may become acutely inflamed and painful in pancreatitis, but poor pancreatic function can be more subtle, with diarrhea and fat droplets in a stool due to fat malabsorption. Specific conditions. Table 34-6 summarizes the major diseases of the gastrointestinal system. Esophageal varices. Esophageal varices occur when the pressure within the blood vessels of the distal esophagus increases due to liver damage or cirrhosis. In industrialized countries, alcohol is the main cause of portal hypertension. Chronic alcohol consumption damages and scars the interior of the liver, cirrhosis, leading to slower blood flow and higher venous pressures. These higher pressures are the cause of increased risk of bleeding. In developing countries, viral hepatitis is the main cause of liver damage. Esophageal varices can present with massive, life-threatening upper gastrointestinal bleeding. Mallory-Weiss syndrome. Mallory-Weiss syndrome may lead to severe hemorrhage. With this condition, the esophageal lining tears during severe vomiting. In addition to bleeding, a frank rupture of the esophagus can rarely occur, known as Boerhaave syndrome. Spillage of gastric contents into the mediastinum can result in pneumothorax and overwhelming sepsis. Mallory-Weiss syndrome occurs in men more often than women, and it is more prevalent in older adults and older children. Hemorrhoids. Hemorrhoids are caused by swelling and inflammation of the blood vessels surrounding the rectum. They are a common problem, with almost one-half the population having at least one hemorrhoid by age 50 years. Hemorrhoids may result from conditions that increase pressure on the rectum or irritation of the rectum. Pregnancy, straining at stool, and chronic constipation cause increased pressure, while anal intercourse and diarrhea cause irritation. Peptic ulcer disease. The stomach and duodenum are subjected to high levels of acidity. To prevent damage to these organs, protective layers of mucus line both organs. In peptic ulcer disease, the protective layer is eroded, allowing the acid to eat into the mucosal lining of the stomach. In the past, peptic ulcer disease was thought to be related to the types of foods eaten. Today, It is known to have a variety of etiologies. The major risk factors are Helicobacter pylori infection and use of nonsteroidal anti-inflammatory drugs. Alcohol and smoking can also exacerbate peptic ulcer disease. Peptic ulcer disease affects both men and women equally, but tends to occur more often in older adults. In addition to having an increased prevalence of H. pylori infection, the geriatric population also uses nonsteroidal anti-inflammatory medications more frequently for arthritis and other musculoskeletal complaints. Cholecystitis. Cholecystitis is caused by obstruction of the cystic duct leading from the gallbladder to the duodenum, usually by gallstones. Gallstones are believed to form either due to increased production of bile or decreased emptying of the gallbladder. The gallbladder stores bile, which contains a detergent-like substance used to break down fat. When it contracts, it releases this bile. When fatty foods are present within the duodenum, the contraction will occur, but if a blockage is present, the patient may experience severe extreme right upper quadrant pain, radiating to the right shoulder. In addition to the pain, the patient may demonstrate a positive Murphy sign. This can be elicited by asking the patient to breathe in deeply while pressing deeply on the right upper quadrant near the costal margin. As the diaphragm descends, the inflamed gallbladder is pushed distally toward the examiner's fingers. If the patient stops the inspiration suddenly due to pain, this is considered a positive Murphy sign. Pain alone is characteristic of biliary colic. Progression with development of fever, jaundice, and tachycardia suggests inflammation of the gallbladder, called cholecystitis. Women have cholecystitis 2 to 3 times more often than men. Older adults are more prone to this condition than their younger counterparts. Caucasians have a higher prevalence than African Canadians. People who are overweight or have had a recent extreme weight loss are also at greater risk. The 5 Fs of cholecystitis, related to people who have this condition most often, are fair, Caucasian, fat, female, fertile, and 40 to 50. Appendicitis. Appendicitis begins with the accumulation of material, usually feces, within the appendix. Once this organ is obstructed, pressure may build within it. This pressure decreases the flow of blood and lymph fluid, which in turn hinders the body's ability to fight infection in the local area. If left unchecked, the appendix may eventually rupture, causing peritonitis, sepsis, and death. Adolescents have the highest incidence of appendicitis, with the number of cases dropping as age increases. Although older adults experience appendicitis less often, they have a higher mortality rate with this condition compared to their younger counterparts. Men are slightly more susceptible to developing appendicitis than women. Diverticular disease. Diverticular disease was first recognized around 1900, when it was noted that people in Western societies tended to eat more foods containing processed grains, and less dietary fiber. Diets low in fiber tend to result in more solid stools, and increased intraluminal pressures in the colon. Small defects within the colonic wall are normally present at points where the arteries enter. The increased intraluminal pressures result in bulges in the colon wall at the points of entry of the arteries. These small outcroppings eventually turn into pouches, called diverticula. As feces travel through the colon, some may become trapped within these pouches. When bacteria grow there, they cause localized inflammation and infection. As the body attempts to manage this infection, scarring can occur, along with adhesions and fistulas. A fistula is an abnormal connection between two cavities. In the case of diverticular disease, fistulas are typically between the colon and the bladder, increasing their vulnerability to infection. Inflamed diverticuli, called diverticulitis, can occur anywhere along the colon, but is most common in the left lower quadrant. Patients with diverticulitis present with pain and tenderness, which is usually in the lower abdomen. Sometimes, inflamed diverticuli perforate, causing peritonitis and sepsis. The typical patient with diverticular disease is older than age 60 years. More important than sex or race is the amount of fiber in the patient's diet. Decreased fiber increases the risk for this disease. Interestingly, People in Western societies are more likely to develop diverticular disease than those from Africa and Asia. Pancreatitis. The pancreas produces several enzymes that help break down food into substances that can be absorbed by the intestines. If the duct carrying these enzymes becomes blocked, the enzymes become activated and begin to break down the protein and fat of the pancreas itself, a process referred to as autodigestion of the pancreas. Factors contributing to the development of pancreatitis include increased alcohol consumption and gallstones. Other causes include medication reactions, trauma, cancer, and very high triglyceride levels. Pancreatitis can occur suddenly or may persist over many months. Patients can have singular attacks or recurrent episodes. The condition is more common in men than women. It also occurs more often in African Canadians aged 35 to 64 years. Ulcerative colitis. Ulcerative colitis is caused by generalized inflammation of the colon. It is unclear what causes this chronic inflammation, but genetics, stress, and autoimmunity have been speculated to contribute to its etiology. In ulcerative colitis, the inflammation causes a thinning of the wall of the intestine, resulting in a weakened, dilated rectum. The damaged lining of the colon is then prone to bacterial infections and bleeding. The initial peak of ulcerative colitis typically occurs in the second decade of life, followed by a plateau, and a second peak in later years. Ulcerative colitis occurs more often in women than in men. Ulcerative colitis is also more prevalent among Caucasians. Genetics play an important role. The incidence of both ulcerative colitis and Crohn's disease are higher in families with a history of these diseases. Crohn's disease. Crohn's disease is similar to ulcerative colitis, but it may affect the entire gastrointestinal tract. In this condition, the immune system attacks the gastrointestinal tract, and the activity of the white blood cells damages all layers of the portion of the gastrointestinal tract involved. The most likely site of inflammation is the ileum, the final portion of the small intestine before it joins the large intestine. The result is a scarred, narrowed, stiff, and weakened portion of the small intestine. This damaged patch is found among areas of intestine that are perfectly normal. To date, no definitive cause for Crohn's disease has been identified. However, the presence of signs and symptoms outside the gastrointestinal system supports the hypothesis that there is an autoimmune component. Perhaps the presence of antigens within the gastrointestinal tract triggers an immune response, or perhaps the immune system itself is not working correctly. Another hypothesis is that the immune system creates antibodies for an antigen that does not exist, initiating a cascade of reactions to a ghost invader. The highest incidence of Crohn's disease occurs in the third decade of life. Men and women are diagnosed equally as often. People of African descent tend not to have this condition, whereas people of Jewish descent have an increased incidence. Many of the people with this condition have a blood relative with some type of inflammatory bowel disease, suggesting that these conditions have a genetic component. Acute gastroenteritis. Acute gastroenteritis comprises a family of infectious conditions presenting with diarrhea, nausea, and vomiting. Bacterial, viral, and parasitic organisms that can cause this condition include Escherichia coli, Salmonella, Shigella, Giardia, the norovirus, C. difficile, and rotavirus. These agents typically enter the body through contaminated food or water or through fecal-oral contact with ill patients. Patients may begin to experience cramps, vomiting, diarrhea, and sometimes fever and chills several hours to several days after contact with the organism. The disease then either runs its course in 2 to 3 days or continues for several weeks. Certain organisms secrete toxins that cause destruction of the intestinal mucosa, leading to bloody diarrhea. Immunocompromised patients are at risk of more severe infections, including systemic infections, and even death. Cholera, a type of acute gastroenteritis that is relatively unknown in Canada, is encountered frequently in the developing world. The norovirus is responsible for the majority of acute viral gastroenteritis in adults, whereas rotavirus causes the same condition in children. These latter two infections are usually self-limited and resolved with supportive care and oral or intravenous hydration. Non-infectious causes of nausea, vomiting, and diarrhea include medications or chemotherapy, toxins found in some shellfish or contaminated foods, or certain poisons. Acute hepatitis. Acute hepatitis is the result of damage to the liver caused by one of several viruses. In Canada, the hepatitis A, B, and C viruses are the predominant causes of acute hepatitis. Hepatitis D is a co-infection with hepatitis B, but is rare in developed countries. Similarly, hepatitis E is primarily found in Southeast Asia, Africa, and Central America. Two other strains, F and G, are also being investigated for their role in causing liver damage. Other causes of acute hepatitis include the Epstein-Barr virus, cytomegalovirus, certain bacterial infections, and liver cancer. Hepatitis viruses are transmitted in a variety of ways. Types A and E move from patient to patient by the fecal-oral route, that is, feces from an infected person are released into the environment, and then contaminates either the food or water consumed by another individual. Types B, C, and E are transmitted by person-to-person contact, typically either by sexual intercourse or parenterally, that is, blood-to-blood contact, usually by blood transfusion, accidental needle sticks, or sharing of dirty needles. Intravenous drug users and prostitutes are at higher risk for acquiring hepatitis B, C, and D, whereas people traveling to countries where food and water safety are not adequate are at risk for developing hepatitis A and E. The time from the initial infection to the emergence of clinical signs and symptoms can range from 14 to 180 days with acute hepatitis. Acute hepatitis can cause abdominal pain, vomiting, fever, and jaundice. Chronic infection or complications of an acute infection can lead to cirrhosis, with all its attendant complications. Assessment and evaluation. Scene assessment. Scene safety is the paramount concern for all types of calls. Although there are usually no specific concerns related to patients with gastrointestinal emergencies, you need to exercise caution to ensure that all personnel remain safe. In terms of additional resources, these patients often need some type of assistance with hygiene, as gastrointestinal complaints routinely involve body substances. Because many gastrointestinal diseases have the potential to cause transmission of communicable diseases, additional resources for the gastrointestinal patient may include extra gloves, mask, gowns, change of uniform, suction equipment, extra linens, blankets, wash rags, towels, and adult and child diapers. The mechanism of injury or nature of illness, as with most medical complaints, will contribute to your initial impression. Early in the call, the only information available may have come from the dispatch center. Use this information to help determine the amount and type of equipment you will take into the scene. Note that most calls for gastrointestinal problems will not involve multiple patients. However, a call for assistance at an office building where several people are complaining of gastrointestinal symptoms should lead you to suspect release of an agent. Biologic or chemical agents, for example, can cause people to have abdominal pain, nausea, vomiting, diarrhea, and other gastrointestinal signs and symptoms. The last component of the scene assessment is the use of personal protective equipment and routine precautions. This consideration is particularly important for patients with gastrointestinal problems. Gloves are needed, as with most calls. Given that you may need to manage vomit, diarrhea, and soiled patient clothing in these calls, additional personal protective equipment resources may be required. Gowns can be helpful when dealing with patients who have become incontinent. Masks can help with noxious odors. Initial assessment. Informing your general impression, closely examine the location where the patient is found, because it can provide hints about what happened. Was the patient walking to the bathroom when he or she passed out? Has the patient been sick for several days, and camped out on the couch? Was the patient at work when a sudden bout of pain doubled him or her over? Patients tend to assume the most comfortable position. Flexion of the hips reduces movement of the psoas muscle, and decreases pain. Ask the patient whether movement, walking, or deep breathing relieves or intensifies the pain. Peritoneal pain intensifies with movement. Patients with colicky pain, that is, renal, biliary, bowel, often present with restlessness, pacing, or writhing in pain. One aspect of the general impression that is different for the gastrointestinal patient is odor. What is the smell of the room or location of the patient? The foul-smelling melena stool that accompanies an upper gastrointestinal bleed can be an important clue to the disease, and these smells should be noted and reported even though they can make even experienced paramedics nauseated. When dealing with these strong odors, the key is to hold your ground. The sense of smell is the most acute for approximately 1 minute, but then more than 50% of the intensity of an odor is lost due to the olfactory nerve becoming tired of sending the same signal. If you are faced with a strong odor on a call, stay in the environment. After 2 to 5 minutes, the smell may be less noticeable. Airway patency becomes a more pertinent concern with the gastrointestinal patient. A patient who is vomiting has a greater chance of aspiration. Open the airway using the appropriate maneuvers, and closely inspect it for foreign bodies. Remove or suction any obstructions that are found. While evaluating the airway, notice any unusual odors emanating from the mouth. Patients who have extremely advanced bowel obstructions can have feculent breath, smelling of stool. Gastrointestinal problems rarely affect breathing directly. If a breathing problem or altered breathing is encountered, it typically stems from a systemic complication. Ensure that the airway is clear. Suspect aspiration if a vomiting patient has difficulty maintaining oxygenation and ventilation. The assessment of the circulatory system is essential in understanding how the gastrointestinal disease is affecting the body. As with all patients, assess skin color, temperature, and condition, that is, moisture content. Note findings consistent with shock. Determine the heart rate. Evaluate the peripheral pulses, and compare them to the central pulses. Many gastrointestinal diseases involve pain and/or hemorrhage. As blood volume begins to drop, the body tries to compensate for this change by releasing catecholamines in the form of epinephrine and norepinephrine. These agents attempt to stabilize blood pressure through vasoconstriction, increased heart rate, and increased force of left ventricular contraction. Pain stimulates similar body responses. Either problem can leave the patient with tachycardia, pallor, and diaphoresis. Check the patient's blood pressure. To ensure this measurement's accuracy, obtain a manual pressure before you use an automated blood pressure machine. Orthostatic vital signs will help you determine the extent of bleeding or dehydration that has occurred. First, have the patient lie down or recline in a position of comfort. Take an accurate blood pressure and heart rate. Next, have the patient sit or stand. Use caution, because the patient may potentially lose consciousness with a positional change. Wait 1 or 2 minutes, and then repeat the blood pressure and heart rate measurements. Normally, there should be little change in the blood pressure or heart rate with such a positional change. When a patient has a significant loss of fluid within the vascular space, however, you will note a 20 mm of mercury drop in systolic blood pressure, 10 mm of mercury increase in diastolic pressure, and narrowing pulse pressure, or a 20 beat increase in the pulse rate. Any of these findings indicates a significant volume loss. When you examine the gastrointestinal patient for gross bleeding, it is not unusual to find large amounts of blood. Take note of the amount of blood lost, focusing on being accurate. Many people grossly exaggerate the volume lost due to the emotional effects of seeing large amounts of blood. The amount of blood in a toilet is particularly difficult to estimate due to dilution. To practice volume estimation, measure the amount of water in a glass, and then spill it on a carpet. Note the size of the puddle. Spill another volume of water on a hard surface such as a tile floor. Again, note the size of the puddle. When making your transport decision, integrate the information gathered from the initial assessment. If the patient has an orthostatic change in vital signs, then thoughtfully consider how the patient will be moved. Can the patient tolerate sitting in a stair chair, or will he or she pass out? Is the patient critical, so that he or she needs to be moved urgently? In females of childbearing age, consider possible non-gastrointestinal sources of disease, such as ectopic pregnancy, spontaneous or threatened abortion, ovarian cyst, or pelvic inflammatory disease. Your history should include addressing the gynecologic system and the risk factors for these patients. In pediatrics, consider common causes such as gastroenteritis, appendicitis, and intussusception of the small bowel. Always maintain an index of suspicion for child maltreatment. The elderly can be poor historians, have muted symptoms, atypical pain, and low or absent fever. Focused history and physical examination. For the unstable patient, a rapid head-to-toe examination will provide you with ample opportunities to discover clues as to the underlying problem. Beginning at the head, perform the standard examination of deformities, contusions, abrasions, penetrations, burns, tenderness, lacerations, and swelling. With a gastrointestinal problem, examination of the head, neck, and chest will often not reveal any major changes. Instead, the major effects from gastrointestinal disease typically relate to the nervous, cardiovascular, and respiratory systems and result from pain, hypovolemia, and infection. Examination of the abdomen can be uncomfortable for the patient with abdominal pain. In addition, respect for the patient's privacy should permit a deferral of the examination until the patient is protected from curious onlookers. As you prepare for the abdominal examination, if the patient is stable, place a pillow under his or her knees. Have the patient relax the arms at his or her side. Maintaining straight legs and arms over the head can result in flexed abdominal muscles, which can distort your examination. Make sure your hands are warm before you touch the abdomen. If the patient is uncomfortable with this examination, try to distract him or her by having a casual conversation. If the patient is unstable, then proceed with the examination in a quick and compassionate manner. Examine the skin for irregularities. Do you see scars indicating trauma or past surgery? If so, ask the patient about the scarring. Do you notice stretch marks, striae? These indicate a change in the size of the abdomen over a short period of time. Recent increases or decreases in weight, pregnancy, and severe abdominal edema can all cause striae. Is the abdomen symmetric? Looking down at a supine patient, the abdomen should lie flat and gently slope off of the ribs with a gentle upward slope as you approach the pelvis. Tumors, hernia, enlarged, or distended organs, pregnancy, and other masses can cause asymmetry. What is the shape of the abdomen? Is it flat, round, protuberant, or scaphoid? As people gain weight, the weight can be localized to the abdomen, producing a round abdomen. If weight becomes extreme, the abdomen may protrude. Other causes of protuberance include fluid buildup in the abdomen, such as ascites in liver failure, pregnancy, and organ enlargement. A scaphoid, concave, abdomen may result from decreased abdominal volume, such as would happen with a diaphragmatic hernia, or malnutrition from malabsorption or chronic disease. Listen to the abdomen before you touch it, because palpation of the abdomen can alter the bowel sound patterns. Bowel sounds are transmitted easily through the abdominal cavity. Place your stethoscope lightly on the abdominal wall, and listen. Listening to one location, such as the right lower quadrant, is usually all that is needed. Normal bowel sounds sound like gurgles and clicks and occur 5 to 30 times per minute. In your examination, you are merely listening for the presence or absence of these sounds. Sometimes you may hear loud prolonged sounds. This stomach growling, borborygmi, indicates strong contractions of the intestines. It can be normal or it may present with diarrhea. Interestingly, increased activity in the bowel, hyperperistalsis, can also be heard in patients with early bowel obstruction, as the bowel contracts forcefully in an effort to overcome the obstruction. Decreased bowel sounds, that is, listening over the right lower quadrant, and not hearing anything for 15 to 20 seconds, can indicate decreased peristalsis of the intestines, hypoperistalsis. This lack of movement can lead to bowel obstruction. True absent bowel sounds are characterized by no sounds heard for 2 minutes. It is impractical to discover these in the pre-hospital setting. The absence of bowel sounds means that the intestines are not contracting, so any material within them is not in motion. Bowel sounds are summarized in Table 34-7. Palpation of the abdomen can reveal important information. To palpate the abdomen, place your hand flat on the wall of the abdomen with your fingers together. Choose the quadrant farthest away from where the patient is having the complaint to start your assessment, and systematically palpate each quadrant, finally making your way to the quadrant where the complaint is located. Such a cautious approach to an abdominal assessment will decrease the patient's anxiety, help to reveal more accurate information, and allow the patient to focus his or her attention on other portions of the abdomen that he or she may not have considered because of the current discomfort. With your hand placed on the wall of the abdomen, raise your wrist so that you indent the abdominal wall with your fingers about 5 to 10 centimeters. As you are palpating, assess the abdomen for the presence of rigidity, discomfort, or masses. Sometimes patients may feel ticklish or otherwise guard the abdomen with flexed muscles, which can make it difficult to determine if the abdomen is rigid or just muscularly guarded. A rigid abdomen may indicate peritonitis due to hemorrhage or infection. Have the patient breathe with an open mouth. It is more difficult to hold the stomach contracted during mouth breathing, so this technique can help to relax the abdomen and allow for a more accurate assessment. You can also hold your fingers slightly depressed into the abdomen during the respiratory cycle. When the patient exhales, the abdomen typically relaxes. You can also try to coach the patient to relax the abdomen. This is not always possible, however. Nevertheless, if you are going to report a rigid abdomen, you should take reasonable steps to ensure that your assessment finding is accurate. Pain is often a finding of importance with gastrointestinal exams, because it can indicate trauma, hemorrhage, infection, or obstruction. As with the initial assessment, determine the onset, provocation, quality, radiation, severity, time of the complaint. Table 34-8 describes the types of pain that may be experienced with an abdominal problem. As with all pain evaluations, you also need to determine when the patient has pain. Does he or she have pain when the abdomen is not being touched? Does the palpation of the abdomen increase the pain? What is the character of the pain? Does the pain change in character or location during your palpation? Rebound tenderness, parietal pain, may sometimes accompany abdominal pain, and is suggestive of a serious and potentially life-threatening pathology. It occurs when the peritoneum is irritated due to either hemorrhage or infection. The peritoneum is a thin layer of tissue lining the abdominal cavity, and normally contains only a tiny amount of fluid. To demonstrate the rebound tenderness of peritoneal irritation, your examination goal is to have the peritoneum vibrate or move rapidly. Once you discover an area of maximal tenderness, depress the skin with your fingertips about 5 to 10 centimeters, and then quickly pull your fingers off the abdominal wall. Speed is essential. If you pull the fingers off too slowly, you will not be able to get the desired movement of the peritoneum. The abdomen should be rather smooth when subjected to light palpation. Although assessment of internal organs by palpation can be conducted, this is rarely employed within the pre-hospital setting. However, if, as you palpate the abdomen, you note the presence of any bumps or masses, these may signal the presence of an engorged liver, bowel distension, aortic aneurysm, pregnant uterus, or cancerous tumors. The sample history will help you elicit the relevant current and past medical history. When asking patients about their complaints, you may need to reframe your questions in everyday language. It is important that you and your patient have a common frame of reference. For example, one person's diarrhea may be another person's soft stool. You may also need to use colloquial words to ask about bodily functions. Poop is sometimes better understood by non-medical individuals than bowel movements. Table 34-9 suggests ways to standardize language regarding excreted substances so that the healthcare providers taking over care from you will have the same understanding of the patient's condition as you do. Ongoing assessment. The goal of the ongoing assessment is to monitor your patient for changes en route to the hospital. Routine monitoring should include pulse rate, electrocardiogram, blood pressure, respiratory rate, and pulse oximetry. If the patient has gastrointestinal bleeding, continue to assess for signs of shock. Equally important, you should determine what effect your treatment is having. Before giving additional fluid boluses, auscultate lung sounds to determine whether the patient is deteriorating into heart failure. Also monitor the patient's pain level. Many patients with abdominal pain may be receiving pain medication. How effective was your treatment? Does the patient need more medication? What are the patient's blood pressure and respiratory rate? If the patient's condition undergoes a sudden dramatic change, repeat the rapid and detailed assessments as if this case were a new patient. This will give you the best chance of adjusting your pre-hospital care to adequately manage this new development. General management guidelines. Often, there is little you can do about the gastrointestinal disease itself, but you can provide pre-hospital care for the effects of the disease. Patients may be in extreme pain, they may have severe dehydration, hypotension, or extreme nausea. Your main goals are to take routine precautions and personal protective equipment, manage the airway, breathing, and circulation, and attend to the patient's pain and nausea. With patients with gastrointestinal problems, personal protective equipment is essential due to the high likelihood of coming into contact with infectious agents. Be prepared to deal with large amounts of vomit, feces, and blood. The following equipment will be essential to ensure your safety: gloves, gowns, eye protection, surgical mask, towels and wash rags, extra linens, absorbent pads, emesis basin, disposable basin, biohazard bags, sterile water for irrigation. Helping to clean the patient helps return some degree of dignity to a person who is often humiliated by the circumstances of his or her disease. The main airway concerns for the gastrointestinal patient are the potential for aspiration or obstruction of the airway due to vomit or blood. Although these complications are rare, they pose real concerns for the paramedic. Effective positioning of the patient will ensure adequate drainage of material out of the mouth. If the patient has experienced trauma, be prepared to tilt the backboard. In such a case, the patient needs to be packaged and padded well so that spinal movement is minimized when the backboard is moved. Portable suction should be part of every department's first-in equipment. If breathing problems are present in association with gastrointestinal problems, they are often associated with decreased hemoglobin due to bleeding. Be liberal in delivering oxygen to patients with gastrointestinal bleeds. Do not rely on oxygen saturation readings as evidence that oxygen is not needed. A patient who has been bleeding internally may have a severely decreased hemoglobin level. Although the oxygen saturation may read 96%, if the hemoglobin is low, the patient still needs oxygen. Oxygen masks can cause some patients to experience a sense of confinement, especially if they're experiencing nausea. Monitor patients with whom you use a mask to ensure they can get the mask off quickly if they need to vomit. Auscultate lung sounds. This baseline and continuing information are paramount to the safe administration of fluids. Blood or fluid losses should prompt the placement of 1 or 2 large-bore intravenous cannulas, if protocol permits. In patients who are dehydrated, the degree of hemodynamic instability combined with evidence of pulmonary edema will determine the aggressiveness of fluid resuscitation. The goal of management is to provide enough volume to keep vital organs from becoming hypoxic, but not so much volume as to precipitate pulmonary edema or increase the bleeding. If the patient is hypotensive, a rapid bolus of 10 to 20 milliliters per kilogram of an isotonic crystalloid such as normal saline or lactated Ringer solution should be initiated. Maintaining peripheral perfusion, as evidenced by normal mentation, skin condition, and presence of a radial pulse, should be adequate to allow for adequate perfusion of the brain, kidneys, and other vital organs. Once the patient arrives within the hospital, blood administration will be critical to stabilization of the bleeding patient. Pain management of the gastrointestinal patient is a controversial subject. Although some have suggested that analgesia may mask symptoms of disease or disease progression, it is now generally agreed that analgesia is humane and does not delay accurate hospital diagnosis of gastrointestinal problems. Your system protocols should provide guidance as to which medications, if any, are to be used in the setting. In any event, controlling pain should be a priority with gastrointestinal patients. The only true contraindication to pain management in the pre-hospital setting for the gastrointestinal patient is hypotension. Analgesia to decrease pain should be used judiciously because it may result in hemodynamic compromise. The following medications provide the paramedic with tools to manage abdominal pain. Meperidine hydrochloride, Demerol. This is a synthetic narcotic that is often given with hydroxyzine to decrease nausea. Morphine. This narcotic can cause hypotension and respiratory depression. Ketorolac, Torado. This medication is a non-narcotic, so it does not tend to cause hypotension and respiratory depression. It should be given with caution in patients with renal disease or patients who are bleeding. Fentanyl, Sublimase. This is a commonly used opioid agonist. It is very potent, rapid-acting, and has a short half-life. This narcotic can cause hypotension and respiratory depression. Proper cleaning and maintenance of equipment and uniforms soiled by bodily fluids from patients with gastrointestinal diseases is essential. Hepatitis B, for example, can remain infectious even in dry blood for longer than 1 week. The following medications may be administered to address nausea. Ondansetron, Zofran. This medication may cause damage to the developing fetus, therefore, it is not recommended as first-line agent for nausea and vomiting in pregnant patients. Diphenhydramine, Benadryl. This medication is typically used for allergic reactions, but also has antiemetic properties. Be cautious when using this medication because it can cause drowsiness and a drop in blood pressure. Assessment and management of specific conditions. Gastrointestinal bleeding. Presentation of gastrointestinal bleeding is variable, because it can reflect the presence of a number of diseases. Each of these conditions has its own pattern of disease progression. For example, diverticular disease has a rather gradual onset, and tends to strike people in their 50s, 60s, or older. Mallory-Weiss syndrome has a very sudden onset, and affects people of all ages. Gathering the information about how the patient progressed from initial symptoms to calling an ambulance is critical in forming your initial impression. The patient's medical history, and other possible events of abdominal pain or bleeding from the gastrointestinal tract may also provide important information. Find out which medications the patient is taking. Many medications can irritate the gastrointestinal tract, precipitating bleeding. Anticoagulants also increase the patient's chance of developing gastrointestinal bleeding. Determine how long the patient has had the problem. Question the patient about the length of time he or she has been experiencing bleeding. Ask whether the patient is taking any medications that affect coagulation. This will help you to estimate how easily the bleeding can be controlled. Aspirin, warfarin, Coumadin, clopidogrel, Plavix, and rivaroxaban, Xarelto, are examples of medications that affect bleeding. The most important component of the physical examination is to determine how much bleeding has occurred. Do you see evidence of bleeding in the environment? If so, try to estimate the amount of liquid present. Focus your assessment on evaluation for shock. Determine whether the patient is compensating for the fluid loss. Orthostatic vital signs are the key to gauging the degree of fluid loss in the pre-hospital setting. Care for the patient with hemorrhage is directed at maintaining perfusion of vital organs. Internal hemorrhage cannot be controlled in the pre-hospital setting. Although volume replacement is critical to ensure adequate circulation to the vital organs, aggressive volume replacement with crystalloid solutions can result in dilution of clotting factors, increased bleeding, and potentially death. Fluid resuscitation is common. In most patients, even those with stable vital signs, it is prudent to establish an intravenous line. This will allow you to quickly resuscitate the patient with fluids should conditions change. Specific conditions that cause gastrointestinal bleeding will be discussed next section. Tranexamic acid, an antifibrinolytic agent used by some EMS agencies in traumatic hemorrhage, is sometimes used in hemodynamically unstable gastrointestinal bleeding. However, there is insufficient evidence at this time to recommend routine use, and paramedics should seek guidance from their EMS agency or medical director. Esophageal varices. Initially, the esophageal varices are asymptomatic, but the patient may show other subtle signs of liver disease, such as fatigue, weight loss, jaundice, anorexia, edema in the abdomen, and pruritus. Once there is a variceal bleed, the presentation is quite dramatic. The patient may report sudden onset discomfort in the throat. There is often copious vomiting of bright red blood, hypotension, and signs of shock. If the bleeding is less severe, then hematemesis and melena predominate. Bleeding esophageal varices can be life-threatening. Treatment for patients with esophageal varices in the pre-hospital setting should follow the general management guidelines. As with any gastrointestinal bleeding disorder, accurate assessment of the extent of blood loss is critical. Be prepared for a very hemodynamically unstable patient who needs volume resuscitation and aggressive suctioning. If the patient's level of consciousness begins to deteriorate, consider inserting an advanced airway to minimize the potential for aspiration. In-hospital treatment involves aggressive fluid resuscitation, replacement of blood and clotting factors, and control of bleeding. The latter may be achieved endoscopically or by placement of a large esophageal balloon to tamponade the bleeding varices. Mallory-Weiss syndrome. Mallory-Weiss syndrome develops due to repeated, severe vomiting. In women, this syndrome may occur with hyperemesis gravidarum, that is, severe vomiting related to pregnancy. The extent of the bleeding can range from very minor, resulting in very little blood loss, to severe bleeding, and extreme hypovolemia. In extreme cases, patients may have signs and symptoms of shock, epigastric abdominal pain, hematemesis, and melena. Management of Mallory-Weiss syndrome is the same as for esophageal varices, and is directed at determining the extent of blood loss. The patient may be dehydrated from both repeated vomiting and blood loss. In-hospital management includes volume resuscitation, as needed, endoscopy to visualize the extent of the damage, and possibly an attempt to repair the damage. In most cases, Mallory-Weiss syndrome resolves spontaneously. Boerhaave syndrome requires management related to the potential for sepsis. Complicating this presentation is the symptom of chest pain. Because this condition tends to occur in men aged 50 to 70 years, the possibility of myocardial infarction is a reasonable conclusion. The patient should be managed as if he had experienced a myocardial infarction until proven otherwise. Be comfortable contacting medical control to help with these patients. Aspirin therapy is not desirable. In the hospital, patients with Boerhaave syndrome will require endoscopy to repair the tear and antibiotics to manage the infection. Hemorrhoids. Hemorrhoids present as bright red rectal bleeding. This hematochezia tends to be minimal and is easily controlled. However, the blood loss appears dramatic to the patient, because the water in the toilet turns red with only a few drops of blood. Additionally, patients may experience pain or itching, and a small mass on the rectum. Typically, this mass is a clot formed in response to the mild bleeding. Pre-hospital management of hemorrhoids is largely supportive. In isolation, hemorrhoids are more of an inconvenience than a life-threatening condition. Rarely, some patients sustain severe lower gastrointestinal bleeds, and a hemorrhoidal source for the bleeding may not be apparent. Ensure that the patient is hemodynamically stable, using orthostatic vital signs, and fluid resuscitate, if necessary. The majority of hemorrhoids resolve in 2 to 3 days with only conservative management, such as creams to shrink the inflamed tissues and stool softeners. Rarely, surgical removal may be necessary to stop bleeding, and prevent recurrence. The best management for hemorrhoids is prevention, which includes eating a high-fiber diet. Peptic ulcer disease. Patients with peptic ulcers experience a classic sequence of burning or gnawing pain in the abdomen that subsides or diminishes immediately after eating, and then re-emerges 2 to 3 hours later. Nausea, vomiting, belching, and heartburn are common as well. If the erosion is severe, gastric bleeding can occur, resulting in hematemesis and melena. Perforation of the stomach or intestine will result in signs of peritonitis. The major focus for the pre-hospital management of patients with peptic ulcers is to accurately assess the extent of blood loss, and to prepare to manage any hypotension that is present. Orthostatic vital signs are critical in determining fluid needs and transportation or packaging issues. In-hospital management includes acid neutralization and reduction therapies. Antibiotic therapy directed at H. pylori can prevent many new cases from occurring. Patients will often need an endoscopic examination to assess the stomach wall for damage. Surgical repair of the damaged stomach lining in concert with medication therapy is often effective. Cholecystitis. Patients with biliary colic typically develop severe right upper quadrant pain after large or fatty meals. The development of fever and tachycardia is suggestive of inflammation of the gallbladder wall, which occurs in cholecystitis. Pre-hospital treatment for cholecystitis is directed at making the patient comfortable and treating hypovolemia if there is a fever and indications of septic shock. Medications given to control pain include morphine and fentanyl. Although morphine has been reported to cause a contraction of the sphincter of Oddi, the valve controlling bile movement out of the gallbladder, in most cases, morphine is used with no adverse effects. To control nausea, use one of the anti-nausea medications based on local or regional treatment guidelines. Intravenous fluids and antiemetics are also indicated, because these patients are often vomiting. In-hospital treatment may include antibiotics, pain medication, ultrasound, and surgical removal of the gallbladder. Appendicitis. Patients with appendicitis classically present with periumbilical visceral pain that eventually migrates to the right lower quadrant. Rebound tenderness suggests possible perforation of the appendix with resultant peritonitis. Additionally, these patients often develop anorexia, nausea, and fever. Pre-hospital management for appendicitis includes remaining vigilant for signs of perforation or septic shock. Volume resuscitation may not be adequate to restore blood pressure. Be prepared to use vasopressors such as dopamine or norepinephrine if crystalloids are not effective. Administration of pain and anti-nausea medications is clearly indicated with these patients. At the hospital, these patients will receive antibiotics and typically undergo surgical removal of the appendix. Diverticular disease. Diverticulitis presents with abdominal pain, which tends to be localized to the left side of the lower abdomen. Classic signs of infection include fever, malaise, body aches, chills, nausea, and vomiting. Diverticular disease may also be a source of lower gastrointestinal bleeding, often without pain. Due to the local infections of these pouches, adhesions may develop, narrowing the diameter of the colon, and resulting in constipation and bowel obstruction. Management of diverticular disease is directed at making the patient comfortable. Examine the patient closely to ensure that severe infection is not present, because sepsis can occur, as well as complications such as fistulas to the urinary bladder. Patients with diverticular disease may also need large amounts of fluids with or without vasopressors to maintain blood pressure. In-hospital treatment includes antibiotics, allowing the gastrointestinal tract to rest by giving the patient a liquid diet, and possibly surgery to remove the pouches and repair any fistulas. Pancreatitis. The pain of pancreatitis tends to be localized to the epigastric area or right upper abdomen. It can be sharp and may be quite severe. Radiation of the pain to the back is common. Patients may also experience nausea, vomiting, fever, tachycardia, hypotension, and muscle spasms in the extremities as a result of hypocalcemia, low blood calcium. Both the inflammatory condition caused by pancreatitis and the erosion of nearby blood vessels, causing internal bleeding, can cause shock or hemodynamic instability. If there is severe internal hemorrhage, Gray Turner sign, bruising in the flanks, and Cullen sign, bruising around the umbilicus, indicate that retroperitoneal bleeding may be present. Management for the pre-hospital patient with pancreatitis should follow the general management guidelines. Pay special attention to assessing the patient for signs of severe hemorrhage. If present, begin fluid resuscitation. Because some of these patients will also have gallstones, the most conservative choice for the management of abdominal pain is meperidine. Morphine may cause spasms of the gallbladder, thus increasing the patient's pain. In-hospital management includes gastrointestinal rest and fluid resuscitation. In some patients, antibiotics and surgery can be helpful. Although the pancreas cannot be removed unless it is immediately replaced, that is, during transplantation, surgery may be performed to control bleeding or manage the gallstones, and subsequent blockage of bile from the liver. Ulcerative colitis. Ulcerative colitis presents with bloody diarrhea, hematochezia, and abdominal pain, which can range from mild to severe. Other signs and symptoms may include joint pain and skin lesions, possibly due to the systemic nature of the autoimmune response thought to be responsible for this disease. Patients may also experience fever, fatigue, and loss of appetite as a consequence of the infections occurring within the colon. Management of ulcerative colitis consists of determining the degree of hemodynamic instability. Look for signs of shock. If the diarrhea and bleeding have caused sufficient volume loss to make the patient's condition unstable, administer fluids to return the patient to a near normal volume balance. Otherwise, provide supportive care, and follow the general management guidelines. In-hospital care for these patients will include anti-inflammatory medications, antibiotics, antidiarrheals, and possible surgical resection of the diseased sections of the colon. Many patients with ulcerative disease experience periods of diarrhea and abdominal pain for years, and many of these patients will have part of their colon removed. Crohn's disease. Patients with Crohn's disease present with chronic abdominal pain, often in the lower right area. This pain corresponds to the location of the ileum. Rectal bleeding, weight loss, diarrhea, arthritis, skin problems, and fever may also be present. Bleeding tends to occur in small amounts over a long period of time. Acute severe hemorrhage is rare, but chronic bleeding resulting in anemia and hypotension can occur. Patients may experience episodes of mild to severe signs and symptoms. Management of Crohn's disease in the pre-hospital setting should follow the general management guidelines. Volume resuscitation may be needed because of diarrhea and chronic hemorrhage. Measures to control nausea and pain are commonly needed. In-hospital care focuses on stopping the inflammation, correcting any fluid imbalances, managing infections, and creating an environment where the gastrointestinal tract can heal itself. The damage to the intestines can be so severe that surgical removal of portions is sometimes needed. New medications are working well to control this chronic condition and allow patients to live near normal lives. Acute gastroenteritis. The presentation of acute gastroenteritis involves vomiting and diarrhea. Certain organisms cause inflammation of the intestines, resulting in blood, mucus, or pus in the stool. Abdominal cramping is frequent as hyperperistalsis continues. Fever, nausea, and anorexia are often also present. If the vomiting and diarrhea continue, dehydration and hemodynamic instability will result. As the volume of fluid loss increases, the likelihood of potassium and sodium imbalance increases. Watch for orthostatic changes in heart rate and blood pressure, changes in level of consciousness, other signs of shock, because they indicate a critical volume loss. Pre-hospital management of gastroenteritis follows the general management guidelines. Pay special attention to the problem of determining the degree of fluid deficit. If the patient's condition is stable, 1/2 normal saline solution may be indicated to begin rehydration. Indeed, patients often feel markedly better after rehydration. Performing cardiac monitoring is reasonable due to the risk of hypokalemia. Analgesic and antiemetic medications are sometimes also indicated for these patients. In the emergency department, care is directed to rehydration, control of vomiting and diarrhea, identification of the organism involved, antibiotic therapy, and stabilization of electrolyte imbalances. The patient will have blood evaluation of electrolytes before electrolyte replacement or stabilization therapies are initiated. Once hemodynamically stable, the patient may receive an oral rehydration solution containing water, sodium, potassium, and sugar. One of the most critical issues when managing acute gastroenteritis is education. You need to instruct patients about safe food and water use to prevent future infections. Acute hepatitis. Acute hepatitis, regardless of etiology, is often associated with a number of signs and symptoms. Clinically, the disease occurs in two phases. In the first phase, patients experience symptoms suggestive of a mild viral illness, such as joint aches, weakness, fatigue, fever, nausea, abdominal pain that is often mild, vomiting, and anorexia. At this point in the course of the disease, the patient may sometimes be misdiagnosed as having gastroenteritis. In the later phase of hepatitis, symptoms of liver failure predominate. This can occur days to years after the initial infection. This is characterized by colic stools, darkening of the urine, and the yellow skin, and scleria of jaundice. Abdominal pain in the right upper quadrant, and an enlarged liver also become apparent at this time. Depending on the disease progression, total liver failure may be only days away. Pre-hospital management for acute hepatitis is supportive and follows the general management guidelines for gastrointestinal patients. Two important areas on which to focus during patient pre-hospital care are infection control and medication administration. Patients with acute hepatitis are infectious, so you should take adequate precautions to limit contact with bodily fluids. Use good hand washing and equipment cleaning techniques, and remember that hepatitis B can remain infectious in dry blood for at least 1 week. A vaccine for hepatitis A and B is also available. One of the liver's functions is to detoxify medications. When patients have hepatitis, any medication that is given may remain active within the body for longer than anticipated. When administering medications to patients with signs of liver failure, consider using lower dosages and at longer intervals. Watch for signs of cumulative effects. Without a functioning liver, the patient will die within a few days. Although many cases of hepatitis resolve spontaneously, antiviral medications may be needed to slow the effects of the virus. In extreme cases, a liver transplant is the only effective treatment. Bowel obstruction. The presentation of bowel obstruction varies according to the underlying cause. If this condition is caused by a twisting of the bowels around a fixed point, then obstruction can manifest within hours. If it is caused by cancer, then the narrowing may take months to become apparent. Signs of obstruction include abdominal pain and fullness. Initially, diarrhea may occur as small amounts of stool bypass the obstructed area. Peristalsis increases as the body tries to overcome the obstruction, which may be perceived by the patient as crampy abdominal pain. If this effort is unsuccessful, constipation results, with decreased bowel sounds. Nausea and vomiting are common in the later stages, with both the emesis and the patient's breath having a feculent odor. Eventually, perforation of the bowel may occur, leading to peritonitis and sepsis. Management of bowel obstruction follows the general management guidelines. This disease is rarely life-threatening in the pre-hospital setting. In-hospital management focuses on decompressing the intestines, determining the cause of the obstruction, and treating any complications, such as infection or intestinal perforation. Surgery is sometimes required to relieve the obstruction. Pre-hospital management includes monitoring blood pressure, and being prepared for volume resuscitation and administration of a vasopressor. A nasogastric tube may be used to decompress the stomach of any material. Antiemetics are clearly indicated with small bowel obstruction. Based on the length of time the patient has had the obstruction, intravenous fluids may be needed due to dehydration.